Hello and welcome to the world premiere of the 2022 Mycotoxin and Chronic Illness Summit. I'm your host, Dr. Nafisa Parpia, ND. And with me is
Eric Gordon, MD, the co-host for this exciting event. And we also are joined by Dr. Christine Schaffner and Dr. Jamie Kunkel.
We're both so grateful to be here with you today. And we'd like to take a moment to thank our staff members, the people behind the scenes, our gifted speakers.
And last but not least, our summit sponsors. Please be sure to check them out with the links given in the videos. These are the people that help make this incredible event possible. Amongst them was Econugenics, the Mold Pros, BioPure,
Therasage, 5 Journeys, Infectolab,
Simply O3, Microbiome Labs, Purity Coffee, and Dr. Pollock.
And we want to thank you. We want to thank you, our community, for making this possible. We are so happy that you're here.
Thank you, and looking forward together.
Welcome to this episode of the Mycotoxin and Chronic Illness Summit. I am so pleased to have with me today Dr. Paul Anderson. He is a pioneer in functional medicine and modern naturopathic medicine. And literally, he changes the way that many doctors, including myself, have begun to practice naturopathic medicine. So thank you, Dr. Paul Anderson. Thank you for being here. Let's start by having you introduce yourself and tell everybody what you're doing these days.
Well, thank you. And thanks for having me. So I'm Dr. Paul Anderson, a naturopathic physician from Seattle, Washington. And that's where I am right now in my office. What I do currently, I've been practicing for a long time. And what I do currently is teach other doctors, all in the integrative and naturopathic space, advanced processes in just dealing with our modern chronically ill society, basically. My two big focuses are the chronically ill and then patients with cancer. So that keeps me very busy. I also write a lot for professionals, but I also write some books for patients. We have a few that we use to help cancer patients. And I'm working on some new ones. So that all keeps me pretty busy. And then it's something I never thought, because I'm not that clairvoyant, would ever happen. When COVID started, because of my involvement in research for intravenous vitamin C and some other things that turned out to be being used in other countries for COVID, I started getting interviewed a lot around COVID. And then that led to a lot of people contacting me and consulting for patients or family with COVID. And so in my spare time, what I do now is I have two sort of practice groups. One is literally consulting with people who might have a family member in a hospital, and they want information about other things that can be done, which is a very tough thing to do in the North American hospital system anyway. And then the other is a smaller group, because I have a very limited time for personal practice, but a small group of people with active COVID that I work with. So that's I was supposed to be less busy by this age, but I'm just more busy.
Thank you, Paul. You're always doing absolutely cutting edge, amazing things for medicine, for patients. So thanks for doing what you're doing now with people who have COVID. So it's acute and long COVID as well, right?
Mm-hmm. Yes.
Yeah. Well, today we're going to talk about long COVID. I'm going to ask you all kinds of questions, and I know that our audience is going to be really excited to hear from you. I know I am, that's for sure. So tell us about how you see COVID cases complicated by chronic infections, long COVID cases, that is. Or
sure.
Mm-hmm.
And I think one, just for everything we're going to talk about, COVID is almost unique, not really, but almost unique in that it has so many outliers on both sides of the fence. So for example, everything I'm about to say about, chronic infection patients and COVID, there's also exceptions where you might have a patient that has a lot of other infectious problems and they really don't, they get COVID and they have no long COVID problems, and vice versa. People who have nothing going on seemingly, and then they get all this trouble afterwards. So what I always like to just, set as a tone is that everybody's experience with COVID is very individual, which is kind of a common theme as far as what you do to treat it too. And so a lot of stuff that I'm going to talk about is what I see sort of in the middle of the bell curve, the majority of people. And then there's always people who have it maybe worse or better. So I think with chronic infections, the way I describe it to, say I have a current patient who's dealing with acute COVID. And I also know that they have a history of, a lot of other infections that they've been dealing with, say, maybe Lyme or chronic Epstein-Barr or CMV or some complex of whole bunch of infections, which is not uncommon in our world to see those patients. What I usually caution them around is that history and their immune system already being so active and maybe beat up by those chronic infections can have one of two experiences during COVID. One is they get sicker acutely, and we may need to be, really aggressive with the acute phase. But the other can be, and I was just having this conversation with a patient this morning, that their body is so worn down and weakened and suppressed by fighting all these other things, it doesn't have the energy to make them feel any sicker than they already are. And it's easier to put across the idea that if you get really a lot sicker and you feel horrible, well, we should be pretty aggressive, here with this acute COVID thing. If the person's already run down and suppressed and they really don't feel any worse than they did 5 days ago, it's harder to get in their mind that it's actually, we need to be very aggressive for a few weeks so that COVID doesn't add to your burden, what you already got going on, even though you don't feel worse specifically. So I think that it's, and I guess I started with that because that's a conversation I'm having a lot right now. I think especially with Omicron spreading faster, and I've got people who've now had 2 bouts with COVID or other things going on.
Right.
I'm having that conversation a lot, and what my practice with people has showed me over the last couple of years is, with respect to COVID, if there's any history of anything chronic, we want to appear to almost over-treat you during the acute phase. One of the things that does, and by contrast, if we don't acutely treat you with kind of a lot of force, if we don't do that, it doesn't turn out this way. If we do, usually the amount of post-COVID a person experiences either none or very minimal and very, treatable. Okay. If we slow pitch because you don't feel that bad or whatever, and you have a history of a lot of other infections, what we're seeing with people is a lot of things that we'd already treated and were quiet in their system, whether it's their Lyme or Epstein-Barr, or you could name another 100. 1, 2, 3, 4, 5 weeks after they've recovered from COVID, they've got a bunch of those active again. And so one experience of post-COVID is whatever you had before that was quiet is not quiet anymore.
Right.
So I think, and one of the things that I try and get across in, training for doctors is the first thing is history with a COVID patient. And if they had anything in the past, even if they thought it was gone, you want to know that that's on the table for the future, if you don't keep their immune system, working through the COVID really well. Because COVID is sort of the great unmasker. It kind of pulls up rocks all over the place, and whoever's
It sure does.
the rocks, it's just like stirs it all up.
Yeah.
So I think that's the biggest concept really, is if you have a history, and it doesn't mean that you're going to have a bad experience. It just means maybe you should be a a little more assertive with your treatment of not just COVID, but maybe do some preventive things for your past problems. And I don't know time-wise what works, but I just finished well, I don't know, finished, the person's still alive. I just have a case that we did of a person like that who had completely silent, past chronic infectious stuff because we worked on it for years. And then they got COVID, got really sick. And what turned out was they had activated a whole bunch of their old infections. We treated them in a way that seemed hyper aggressive to everybody involved, including the patient. But when they recovered from COVID, we treated them for a few more weeks to make sure the old infections were all quiet and their immune system was happy. And since they had zero post-COVID problems. So it's sort of like a little more effort on the front end pays dividends later.
Right. So then when you're treating these patients, they have acute COVID, but they've also have underlying infections that they know of, right? And so are you treating them for acute COVID and the underlying infections at the same time? Or are you treating for acute COVID first and balancing their system maybe so they can handle their underlying infections?
Yeah, so I would say what I learned the hard way over these last 2 years is, in early 2020, I probably would have done a lot of COVID-focused treatment, which does have a lot of crossover to other treatments that we do, certainly.
Right.
But I might have kind of said, well, let's see if anything develops with your old chronic infections. Well, what I learned was they're going to develop. Now, you don't always know, if the person had 5 before, that all 5 will get active. But what I tend to do is one of two things. If a person, so for example, this particular person, the most recent one, had a lot of trouble with chronic lung bacteria like Mycoplasma pneumonia and things. They collected a lot of the HHV viruses like CMV and Epstein-Barr and that family.
Right.
And they had even had some, chronic fungal problems in the past. Well, all of those are very clearly, helped out by COVID just because of the way COVID works.
Yes.
So in their case, we talked about it, but what I did was concurrently treated them with ivermectin and hydroxychloroquine and a bunch of the natural things that we do for maybe COVID, quote unquote. But I also gave them doxycycline for the atypical bacteria, because doxy not only covers atypical bacteria, but it's also antiviral, and it actually has direct anti-COVID effect. So it's sort of like 3 for 1. I gave them an antifungal at the same time, because one of the more common co-infections that they don't test for a lot in North America is Aspergillus. And I've seen people, I've seen people with the other SARS. A lot of them would get Aspergillus, and the Aspergillus would kill them. So I prefer not to have that happen. I just start with antifungals early, and then it's about, really by pill count, it's about 35% drugs and 65% natural stuff. But we just kind of start from day one. And a year ago, I might have waited, but I've seen, these are outliers, but I've certainly seen where you get the person who, we still don't know what the genetics are of those people that just get COVID really bad and they go downhill really quick.
Right.
We know they're out there. I've seen those people kind of slow pitch their treatment on the front and then wind up in the hospital or worse. So I just tell people I'd rather overdo it, have you not have problems later, and we can fix anything that we mess up with our treatment, So I do prefer that. Now, I have had people where it's usually 4 or 5 days in to an acute bout with COVID where they get a little break. It's like the fog is lifting and they think they're getting better, and then they get hit with a second wave that's worse.
I'm seeing that too.
And that's somewhere between 4 days and a week in. And I've seen people, these were not my patients personally, sadly they were friends, who thought they were getting better, and the second wave actually killed them, and they weren't really doing very much treatment.
Mhm.
So I know the second wave is dangerous, but what I see coinciding with the second wave when I test people is a lot of infections turn up positive, a lot of the same things you and I would find in our chronically ill people.
Right.
So I'm kind of testing the same stuff we would with a new chronic illness patient, but a lot of times we don't get the patient the day they get sick, right? So
Right.
if they come in and it's anywhere in that window, and then they're starting to say, whoa, it's coming back, I test them for that stuff and just, specifically treat who we find. But I usually try and cover atypical bacteria are just so common. The common opportunistic fungi are very common. And then the common viruses that we
Yeah.
see common.
I'm so happy you're bringing this up, because when people not only come to us and they have acute or chronic COVID, but also when it's being discussed in the news everywhere, if
Yeah.
people are only talking about COVID on its own, nobody else is really thinking about what other underlying infections that are at play here. So it's not just COVID on its own, but it's what else is going on with the patient. Why is this so overlooked, do you think?
Well, I think it's the way that medicine is thought of and done in,
Uh-huh.
certainly in North America. One of the things, just to give context, so more global context, a lot of other countries, for whatever reason, are very sensitive to and actually look at co-infections, at least not, if not immediately, if you're not getting better, they will do that. And there's research from the US on co-infections and COVID, but nobody apparently cares about it. But
Uh-huh.
in China, from the very beginning, at the three big Wuhan hospitals, when I got all of their data they were collecting, and then I had to have it translated, but when I got all of it, I was happy to see from the get-go they started checking people for other infections, because they knew that maybe it's not just this virus, but the virus opens the door. And so
Exactly.
in China, they had their own group of infections that they got. Some are similar to elsewhere. In India, it's different ones. Here, it's probably a little bit different. But I think North America, we're very, in medicine, we're trained that we really want to focus on the thing that we found the right test for. So one of the frustrating things, and I've literally seen, I said that I've got this other practice that's just consulting with doctors who are in hospitals, so they're not really my patients, because I can't, that's up to them to treat the patient in the hospital.
Right.
One of the problems where I've seen patients die is when they found out they had co-infections, but they don't test them until they're almost dead. And it's like, well, of course they have those infections. And what usually happens with the patients who die is they have all the infections I just told you about, but
Yeah.
then you have some other very hard to treat, either bacterial or fungal infections that
Mhm.
they probably got in the hospital. And so then finally an infectious disease comes in and adds in treatment, but it's too late. If they would have done it even 5 days before, the person probably would live.
Right.
So, and certainly, not everyone's dying. We know that it's a small number of people, but that illustrates how dangerous it is, because we don't know what our immune reserve is. We might feel okay, but we might be kind of close to the line, or COVID may really knock us down,
Right.
or for example, when I got COVID, because I have grandchildren who have all these other kid viruses and things,
Uh-huh.
I had COVID and I had RSV, which is a respiratory virus, and I had influenza all at the same time. So I had three viruses that, just ran over me. And then, of course, all the old stuff I used to have woke up too.
Right.
So it's not an uncommon thing. So I do think certainly it's more common in people with histories of, chronic illness. And that could be somebody who maybe is a chronic autoimmune patient. somebody certainly with history of chronic infections, but also people who are in recovery from cancer, because cancer treatment is hard on the immune system too. So yeah, I think it's a frustrating thing in North American medicine, where it's not like they don't know there's co-infections. It's they just don't think it's that common, or it's going to be that big of a deal, and it is.
It certainly is. I'm so happy we're having this discussion, because it's shedding light on an area that's really not discussed. Maybe it's thought about a little bit, right? But it's not
Yeah.
it's not discussed at all. So
Yeah.
thank you for bringing that to the table. So I'm thinking about the people who come in and they have long COVID all of a sudden, but they were never sick before. So I use the words all of a sudden because
Right.
they didn't have anything else. They're suddenly sick, as opposed to the people who have this history of being sick. Can you tell us about the silent infections that will be causing this, and anything else, Dr. Anderson, that you think will be causing this?
Well, and there's certainly things beyond infections, but since that's where we're starting, I'll stick with that for the beginning of the discussion. There's a number of reasons why a previously quote unquote healthy person would not, and a lot of the people that I've seen didn't have a bad time with their acute COVID. That was not the problem. And they probably, were okay, relatively healthy. And it wasn't like me where I got 3 viruses. They just got the one, and, they processed it through, right?
Right.
Maybe minimal or no treatment, right?
Mm-hmm.
I've seen lots of those people. And then, 4 weeks, 6 weeks later, maybe sooner, maybe later, they start to feel more fatigued, maybe more specific pain like joint pain, maybe more kind of global, just I don't feel good, kind of pain. Maybe they develop some specific symptoms, like new headaches or dizziness, or smell and taste changes that are we all know about those. Or maybe they go in and their doctor does some labs. They said, oh, well, it looks like you might be having some clotting problem, or one of those problems. So it's all sorts of manifestations of long COVID. And those people, of course, are always more surprised. Like if you were already chronically ill, you would say, well, all right, that kind of makes sense, that
right, exactly.
virus took me down. But what another concept that we're not great with in Western medicine, although we acknowledge it, we just don't think it's that important, I guess, because no one likes to talk about it, is you have to think of your reserve and your vitality and your immunity and all the things that make you feel healthy. Okay.
Right.
So this person felt healthy, they sailed through COVID, they're better now, and then they get these symptoms. Well, what makes you feel healthy is a whole bunch of things on the inside we never see and we really don't feel, and all of that. And so it's there are many analogies, but it's sort of like the bucket analogy. And you can have either a lot of reserve and that bucket is full, or you can be fighting off things and kind of taking out of your reserve, and that bucket's getting empty. Okay. Mm-hmm. And what happens is that we can feel really good, and the reserve bucket of goodness and good stuff that keeps us, healthy can be really low, but it's not empty. Well, what if then suddenly you get a virus your body's never had, probably, and it hits you really hard, and you sail through it, you get better, you had like a bad cold or flu, but then you're better. Well, what you did is you scraped out all the last of the reserve of your bucket.
Yeah. Just a quick question for you for our audience. Yeah. For our audience, what would you tell them those reserves are?
So it's, of course, it's many things. One is your immune system balance. And so your immune system, has this sort of ebb and flow it does to keep you from getting sick. And one of the things I always tell people, like during the cold and flu season, is that, you might be the person in your office or wherever where you're the last person to get sick. Some people are the first person to get sick.
Right.
That's a different problem. But people who are the last person to get sick, normally what happens is their immune balance, that bucket's pretty full. And they get exposed to person A, on day one, and the immune system responds and fights it off, and exposed to person B and C the next week, and immune system fights it off. And then eventually they just don't realize, well, they've been using up all their reserves, and then they finally get it. So immune balance is a big thing, and immunity comes from 10,000 little things that occur in our body.
Yeah.
But you can use it up, you can burn it out. Another one though that's very common is, what are things that would lower my resistance? So you can think of that like poking holes in the bucket. Things you might be exposed to before you got sick that you aren't feeling right now. Low level mold mycotoxins in your work or your home. Well, they're immune suppressive, but maybe you don't have a big problem with it until you get sick.
Right.
And then your rebound, like filling the immune bucket up, gets harder because you got these immune suppressant things. There are resistance factors that chronic infectious things build up, and they may not be bugging you before, but then again, you get sick with something, it wears you down, and then those chronic things use their resistance factors to take over some territory. So that's another, you can either be on the positive or negative side of that. Our hormone system is one of the things that makes us feel the way we do every day. And what often we don't think about, we think of hormones for, reproductive purposes, or we might think of it around like our adrenals and energy, or, other stuff. But one of the huge purposes of all that interaction with your hormones and the balance they normally have is if the immune system needs to up or down regulate, that's largely your hormonal system that helps orchestrate that. And what we often see in the post-COVID patients, especially those ones where they didn't see it coming, is again, the COVID experience didn't feel that bad to them, but the bucket for the hormonal control and where that interacts with the immune stuff, it just got overtaxed. And now
I'm seeing that.
hormones are, all out of balance. And that's part of feeling you don't feel yourself, but also your immune system can't correct anymore. The other one that's sneaky, and again, people like you and me think about this one all the time, but it still sneaks up on us, is our digestive system has so many components that, again, we don't think about unless there's something wrong, right?
Right.
When we're ill, not only maybe we're taking things, to help us through the illness or whatever, and it has to go through our gut, but your digestive system, obviously it breaks your food down, gets nutrients in, which is a critical thing to keep your cells working. But it also has your digestive immune system, which is as important as the rest of your body's immune system for keeping balance. Well, that gets beat up. And then you also have this whole enteric or digestive nervous system, that's trying to help auto-correct. So if you imagine you get everything run down and your digestive system gets beat up, you're not really going to be able to respond appropriately. And so usually we talked about, the people who were previously ill probably weren't doing great in a lot of these areas. And so they know they got, kind of knocked down, and maybe we got to reset all this stuff. People who felt okay, but maybe the bucket wasn't as full as they thought, the virus and or your immune response to the virus and just being run down will then leave you in the post-COVID phase. There's a little bit of a honeymoon period where your body's trying to auto-correct, but it goes from, you were working at 75% max, your bucket's pretty full. You come out the other end at 15%, and now things start to take advantage of you. So
Right.
stuff that you would have been resistant to before, now your hormones aren't quite right, and your digestive system isn't helping you like it used to, and all those things we talked about. So I really think the surprise post-COVID comes from that, and it's sneaky.
Right. So it's basically what the patient was already dealing with in their system, but they may not have known about it because
Right.
they were able to just ride through it, just through sheer strength, or just they just didn't know yet because it was so minimal. But suddenly COVID comes and it can start to tank all of those systems,
Mhm.
and then it becomes noticeable.
Mhm.
Yeah. Yeah.
And really, the whether the person was worse or normal or thought they were normal before, when you get on the other side over to someone with post-COVID problems, you kind of have to you consider the history, certainly for obvious things. But even if they didn't have a big florid history of any chronic issues, you have to say, well, where are you now? And there are ways to, there's grading scales of how bad is the post-COVID and all that. And what I normally do and what I teach doctors to do is just meet them where they're at there and say, is it essentially a small, medium, or large problem that we're dealing with? And then match your investigations to how disrupted you think those things are. But certainly looking at their hormonal landscape, uh, at least historically, looking at their digestive system function, maybe with testing, certainly looking at chronic infections that like to just hang out and irritate you, but not give you specific symptoms, things of that nature. And then, and in really low grade post-COVID, it's a clinical decision, but anything at the medium or high level, I strongly recommend that people do a new screening for mycotoxins, chemical toxins, metal toxins, because there's actually research that shows if you get sick enough with a infectious illness, not only there's direct research that shows it messes your hormones up, but there's also research that shows that it can make you much more sensitive to, say, a low level mold exposure, or chemicals that you maybe were always exposed to, but now they're a big deal, or just the immune suppressive nature. So I think the toxicity side gets overlooked a lot, but because it's immune suppressive, it's a big part of post-COVID.
Tell us tell us more about how toxins come up to the surface. So there's toxins, they're already there. Let's talk about maybe an old exposure. So there's acute exposures, there's chronic exposures, low level, and then there could be somebody who's had exposures in the past, and there's still a body burden. They might not have acute or chronic low level. Say they're out of the exposure, and then their body has been dealing with that. They've been okay. They didn't even know. Then they come in to our office, and then I test them for all these toxins, and inevitably I'm seeing that they're high. Tell that patient why it is that these toxins are affecting them now, but not before.
So there's two major source issues that people, if you're healthy, you don't like think about sickness and why you might be sick unless you're
Right.
like, right. So people naturally aren't sitting around thinking about this all the time, but just to make it as, I guess, crystallized as possible, one possibility is, which I see a lot, that your threshold when you're healthy for the normal amount of toxic junk in our world that we live in now, you're kind of tolerant to it. Okay, so these things may not be good for you, but your body, between your sweat glands and your liver and your kidneys and everybody else, kind of what goes in goes out, and you don't keep a whole bunch behind. and that process works for you, and you're not getting chronic headaches, or you're not having immune suppression, or you're not whatever.
Right.
So there's that sort of tolerance we develop in modern society. An acute illness will just basically take that tolerance away. So the margin between in and out, and that little bit you keep, not a big deal. You get acutely ill and you lose your margin, So even though you weren't feeling it before, it was there. So that's one thing. But the other thing is that our bodies, same story, we live in a world that's got way more toxins than 50 or 100 years ago. Our bodies evolved and developed to get rid of toxins as we had maybe 200-300 years ago. We were still doing pretty good. Well, we're not evolving that fast. We're not growing new types of liver tissue or better
right.
So now, our chemical evolution has way exceeded our human evolution.
Yes.
So what happens is that, we're dealing with it, we're going along, but the body can only get rid of so much stuff. And this is one of those misnomers I hear a lot, that doctors are taught this, but it's actually not true anymore.
Uh-huh.
And that is that, the body has natural detoxification systems, which is true. It's just they forget the part about the load that comes in is not nearly what the natural detox systems are set up for. So
right.
we get rid of a lot of stuff, but the load is way bigger. So our body then knows these chemicals or metals aren't good for us. And so, for instance, with metals, which are, in the mineral kingdom, it will take those, and first it puts them like, in solid organs like your liver and your brain and unfortunate places like that. And then eventually it moves it over, and your bones, which are set to, pick up minerals, don't want the metals, but they'll take them. So a lot of the metals in our bodies, and everyone's got metal in their bone, a lot of the metal in our body is old stuff.
Yeah.
One of the things that happens is hormonally, when you get sick, a lot of the chemistry, the hormonal chemistry that's trying to help your immune system, can go to your bones and release stuff. Now it's thinking it's going to maybe release low calcium or phosphorus or something, and it may release bad guys at the same time. Okay, old metals.
So it's a little bit like when women go into menopause. That's the same.
Natural bone release, but all the bad things that are in your bone go out too.
Right.
And the same thing with, some mycotoxins and chemical toxins. Certainly your body's trying to store them in the fat cells in your liver and other places, and you get a fever or you're ill, and the chemistry of dealing with the fever and the illness will start to break down those storage sites. And so it's like suddenly, I got this injection of toxin from myself, really, really common. So, so you've got both, low level exposure that you may not notice, not good for you, but you don't notice it. And then you've got your own body burden that if you go into a catabolic, a breakdown state when you're sick, which you do, part of what gets broken down is all the stored junk, so it's really common then that you get this sort of, post-infectious tide of all this junk. And then that goes, and it'll disrupt hormone receptors, and as we said, a lot of immune function, but also just your body getting back on track. So the toxic part is, I always think of it as it supports what the infectious things are doing and vice versa, so it's sort of like they get their own positive feedback that they do. And I think that's why we see so much of that with post-COVID, because the infection opens the door, and then, all those bad things come out.
Right. Can you tell us about mold and COVID? What have you seen?
Sure. One thing, I think maybe the most straightforward thing is, if you have a person who's just been diagnosed with like a large mold mycotoxin exposure, they didn't know their house was moldy or maybe work or whatever. And so they have these really high mycotoxin levels that their body's dumping out. Most of those toxins that mold put off, one of the biggest reasons they hurt us is that they literally suppress our immune system. Now, to the degree that there is a famous immune suppressive drug that's used in cancer and organ transplants and stuff when we don't want you to reject a new liver or something, that is made from a mycotoxin, and it's a common mycotoxin that we get exposed to. So they're that good at, at suppressing your immune system. So of course, the worst situation would be if you do or don't know, but you're exposed to a whole lot of that in your home or work environment. You get a new infection and your immune system is going to be really disorganized in the way that it goes about it. If you maybe don't have these big exposures, but like we were talking about, your body's kind of stuffed away some mycotoxins to try and get rid of later, and then you're sick and run down and you're literally burning up your liver stores, that can make you sick longer, or like I said, it can have that rebound effect. So there are many bad health things that the mold toxins do. But I think in our situation, we're talking about with post-COVID, the immune dysregulation and derailing your immune system obviously is not, that's like the top of the heap as far as what we don't want. Right.
What do you think's going on with respect to biofilm and COVID, acute and chronically?
Yeah.
Let's stop and tell them what biofilm is first.
Right.
They might not know. Yeah.
So biofilms are all over the world. They're in wet places. Okay, so the first places they were discovered were in the oceans. If you're an oceanographer, you know all about biofilms. They make the ocean work and all that. First place that we discovered them in humans was in our teeth. So dentists, actually, a lot of what they're doing to try and keep your teeth healthy is disrupting biofilms, because biofilms hold, you can think of it like a hive of multiple infectious things that live together. So it's not just, now this is where people get confused. There are particular, usually bacteria, there are particular species of bacteria that are biofilm formers. So they're like the builders, but they let everybody else in once they build this. And why do they build it? They build it to protect themselves. So, for example, there's some very bad infections that are hard to treat, like Pseudomonas. You get Pseudomonas in your lungs, you can die from it. Well, the reason it's hard to treat is the bug is tough, but the bug is a biofilm builder. So it builds like armor. Well, what'll happen, and we have these, the biggest area in humans start with the mouth, but it's your digestive tract, more so than anywhere else in the body. So the biofilm is natural to us. It's part of our ecology. But if you get some bad actors who can make more biofilm, then you can literally get parasites in there and viruses and fungi and, the whole kingdom. And what will happen is they'll operate now as a community, not as individual bugs. And so that's its own set of troubles. So
before you go on, tell them why they create biofilm.
Yeah, so the biofilm is literally formed, whether it's in the ocean or in you or anywhere else where there's biofilms, to protect the original organism that forms it. And so it's literally one of their mechanisms for symbiosis with where they live. So if you have a little organism, and let's say it lives in a coral reef or something like that, and it can't really survive as its tiny self, it will form a biofilm to attach to something stronger than it, and then it will live there happily. Okay. Well, think of that in your teeth or in your digestive tract or whatever. We have a lot of what I call normal biofilms. They're just part of our normal biome that's happy. During illness, the chemistry of illness tends to stimulate biofilm growth and care and feeding. because it takes advantage of the illness, the bugs that make them. And then what you get though is a lot of bugs you don't want staying,
Mhm.
joining in and getting in the biofilm. And then what happens is if you send, say, make it simple, let's say there's a bacteria that there's an antibiotic that will kill. Okay, not always that easy, but let's say that. If you have a naked bacteria and it encounters the antibiotic, the bacteria will die. If the bacteria is in the biofilm, it will just laugh at the antibiotic because it can't get
Right.
in. Okay. So, and this again is one of those things where people cannot have a problem with it because it's at a low, we call maybe normal level, but then they're sick for a while or they get a big, huge, maybe COVID response or any other infection, and their body will take that opportunity for some of the less friendly bugs to build bigger biofilm structures, et cetera, and then more pathogens get in there. So you literally can have people where you'll test for these things and the bugs are there on the test, and the treatments that should kill those bugs don't do anything, and it's because most of them are hiding out in a biofilm. Yeah.
Right. So what are your thoughts on COVID itself and biofilm? Do you feel like you need to bust the biofilm first at times?
Well, I think I'm only pausing because it's a multiple choice answer.
Uh-huh.
um, the way that biofilms affect people to create chronic illness is very dependent on how run down their body got during their earlier illness time, because biofilms are, they're natural, but they're not always good for you. Okay, so if they build to a certain point, they become on the opposition side. So what we normally see is if someone's in the post-COVID phase, and we definitely, as I've said, you're looking at their hormones and toxins and infections. So let's say you've looked and, oh gee, these infections flared up during COVID. We didn't treat them back then. Let's treat them now because they're making you fatigued and have pain and all this. What I usually say is, clinically speaking, if you're working on those infections through, and the way we do it usually is both, natural things and maybe some drug things in a mixture. If you're working on those and you're not seeing that person turn the corner in a normal amount of time, you should assume that the biofilms are protecting the majority of the bad actors.
Uh-huh.
And what we normally see is if that's the case and you add biofilm therapies to help open the biofilm up, suddenly the person will have these big responses, to the anti-infective treatment, which is both good and disturbing at the same time, because they're like, oh, I wasn't sick, and oh, now I'm really
No,
sick.
I am. Yeah.
You opened the door to something.
Yeah.
So we do warn them about that. But basically, if I truly believed that someone was actually pretty healthy pre-COVID, and I've had those people where they really, like, they've never had any sign of chronic illness in their life. COVID wasn't so bad, but now they've got, you name it, right?
Right.
I usually will, look at the big areas, get the hormones back on track, get their gut being kind of cleaned up and refurbished, look at what infections they picked up, just try and kill them. And usually in, weeks to a couple of months, they're really turning the corner. Now,
Mhm.
they might need specific treatments. For example, if they lost their taste and smell, you might be doing some specific neurological things there, or if they've got like chronic headaches or sleep disturbance or something, you may be adding things on top of that. But by the same token, and what we try and warn people is, if we're getting 3 or 4 weeks into aggressively working on all these factors and you have no change at all, something's being missed,
Right.
and so there, things like biofilms are in a bigger category of resistance factors. meaning the bad guys can resist you and your treatment.
Uh-huh.
And so resistance factors include, like those toxic things and biofilms and bad gut function and just stuff that takes away our natural ability to heal. So then you have to back up and do that. And then the other area I see in the post-COVID, and I know it's been going on the entire time we've had COVID and post-COVID, but it's getting more common now because I think we have so many people have COVID. We're noticing it more.
Yeah.
And that's the neuroinflammatory part of COVID, because all the same things that mess up your digestive function or make your liver release toxins or all these chemistry we have also makes your brain homeostasis, your brain ecology less stable.
Yeah.
So you see people, because you hear, let's pick an easy one that's super common, taste changes or loss of taste.
Yeah.
Some people 2, 3, 4 weeks and they get their taste back. Some people a year later, they still can't taste. Okay. People developed headaches. Some people, they went away. Some people still have them.
Right.
People develop, anxiety or sleep problems or whatever. COVID, we know now, can cause the same disease as a traumatic brain injury. So you could be in a bad car accident and hit your head super hard, lose consciousness, have a concussion, or you could have COVID and you could have the exact same problems afterwards. So the long-term neurological problems are also ones that are sneaky, and there's a lot of underlying things, a lot of these things we've talked about, that until they're addressed, you can give the person all the curcumin and boswellia you want and all these other things, and it'll help them, but they don't heal.
Right.
So there's a lot of trauma to lots of systems that we really have to think of these core things we're talking about.
What kind of treatments do you like to give to people who are having the neurological issues more than anything else?
So I just did a physician training for this, and it wound up being 3 hours long, which nobody liked, but it was good stuff. And I reviewed, there's probably 1,000 papers, but I reviewed 50 of the most useful ones that have been published in the last year or so, all about COVID. Okay, we're on 99% about COVID. So there's a lot that's known about COVID and the nervous system. The communities that treat these problems, whether it's neurology, psychiatry, ear, nose, and throat, are even acknowledging that the standard treatments they would use aren't working that great.
Right.
And they're actually publishing that things that we might do, like platelet-rich plasma or stem cells or nutrients or other stuff, like they're actually putting in papers, look, we've never used these before, but these appear to maybe be helpful.
I love it.
None of the other treatments we have do.
Yeah.
So I say that to say that, number one, they have to be very desperate if they put that in psychiatry journal or ENT journal.
Right.
But also it goes back to the fact, if you look at the science, the hardcore science for any neurological problem, it starts with what we knew very early in COVID, but now we know more mechanism that you hear about on the news, cytokines and cytokine storms and all this business. Well,
Right.
cytokines are just little chemicals that tell your immune system where to go, what to do. And they all do different things at different times. So they're very fun to try and track. Well, most of them that come along when you're dealing with COVID that might affect your brain, you don't notice right away because they're making you hurt or they're making, whatever. Well, what happens with the nervous system is the first insult is a 1-2 punch, where the fluid that protects and feeds your brain becomes more inflammatory with these little cytokines. and then the membranes that keep the fluid in your brain and safe, and keep the blood out of your brain for the most part, and in the rest of your body, basically get holes in them, so they become like Swiss cheese. It's not supposed to be that way. So the number one protective mechanism family in your brain gets less protective.
Mhm.
Then that allows more inflammation to go in, and your brain then, I would always tell patients, they say, why could one person get a headache and the other one gets anxiety and the other one maybe has nerve pain or something? It's because your brain does everything, and if one area of your brain gets more injured than the other, that area is going to give you symptoms that are wildly different than your neighbor got. So it's all the same problem, but if tends to be, for example, if you started out with a little anxiety, you might have a lot of anxiety, or if you start
Right.
out with little pain, you have a lot of pain, or maybe you get a new thing that you never had before. So in treatment, there's two levels. It's sort of like if you get a post-COVID patient, and there's those people where you get their diet dialed in, and they're on the nutrients that we talk about, and they start to exercise, get their muscles moving. 3-4 weeks, they're all better. That's not the patient we're talking about here. The
Right.
people who do all that and nothing happens, that person, then you have to step back and say, we have to fix the original insult.
Uh-huh.
And even the neurology and psychiatry literature, they say we have this blood-brain barrier problem, which is
Right.
not good. We don't have drugs that fix it, which you don't.
Mhm.
And so you have to start there and get your brain and your nervous system protected, and then you can fix the other problems. So this whole initial insult with inflammation in your blood-brain barrier, interestingly, although it shouldn't be because everything affects everything else, the hormone balance we were talking about is a huge part of getting that back online. What your body does usually under inflammation and acute infection and stuff is kind of shifts hormones towards maintenance during an infection. Okay, so if you're healthy, your cortisol will go up and estrogen will actually go up, and you'll kind of burn up your testosterone. Men or women, it goes down, and your progesterone and some of the other higher order hormones kind of drop or drop a lot. Well, it turns out your blood-brain barrier is very sensitive to progesterone dropping and testosterone and DHEA dropping as they do and all that. And so one of the core things is, that hormone rebalancing kind of helps stabilize. Then there's, other things that, and again, in the standard research, the number one thing people are trying, because most people know about it, is curcumin.
Mhm.
And so in the few research papers where they've tried curcumin, of course it works and it helps, so that
Right.
there's a lot of other plant medicines that we know that help that way. So there are things like that, but then there's also things that we think of often not till we have like a chronic neurological disease or something to use, like and this again is in the standard literature now, acetylcarnitine, which we use a lot with neuro stuff. But it turns out that acutely in these post-COVID patients, that's very helpful. And then all the other thing which is at this core, very core level, is the mitochondrial damage that COVID causes.
Uh-huh.
And now there's papers that show that the brain mitochondria are hit very hard. So as with all of our chronically ill people, your mitochondria go down with you.
Yeah.
All the typical mitochondrial supports, you have to bring in. So it's really building from the very base up. And that's probably why COVID is so able to, dysregulate everything, is it really attacks base processes. Your blood-brain barrier is a pretty base process. Your kidney nephrons are a base process. The lining of your arteries it's pretty important. So it goes to these places, your mitochondria. So I really think that's and we tend to sometimes come in swinging a little higher, and treating something obvious and missing the fact nothing's working anymore.
Right. Right. Well, thank you, Paul. This has been great. I really enjoyed myself. I know our audience has as well. I love how you're exposing what is underneath long-term COVID that very few people are talking about. And now our audience listening, it can have a sense of why they're sick from this.
Yeah.
So, yeah.
And why it takes more than a week or two sometimes to make you better.
Exactly. I mean, it is a lot like chronic tick-borne disease. I'm seeing that for sure. Similar mechanisms. Yeah.
Very much. Very much. Yeah.
Yeah.
Thank you.
Yeah. Thank you. Is there anything else that you want to share?
Oh. I think we did all of the current topics I've been working on, so that's probably enough, right?
Yeah. Well, tell them about your books. I see your books behind you.
Oh yeah. So those two there, I know you probably can't read them, but the two white books back there, one is called Outside the Box Cancer Therapies, and it's pretty much just what it says. Dr. Mark Stengler and myself wrote it together. And it is for anybody, the layperson's made to be read by anybody, but we reference it like a textbook so that cancer patients, when they go to see, say, their oncologist, etc., could have references and resources to show that it's not just crazy ideas and all of that.
Right.
The other thing we did is used our combined 50 or 60 years now of experience to prioritize treatments, because once someone's diagnosed with cancer, the internet can give you a million good ideas.
Right.
And what we try to do is what's in the research, but also just what have we seen, if we wanted to allocate your time and resources in somewhere, where would we start, and so things about that. There's a lot of things about the cancer research I was involved in and what we learned and things people could apply with their doctor. And then the other one is also a cancer-oriented book for either loved ones or the cancer patient. And it's called Cancer, the Journey from Diagnosis to Empowerment. And whether you have cancer or anything else in life, the more empowered you are, the better. Cancer is a disempowering diagnosis. And the reason I wrote it was, the other book's about what to do for your cells. And one of the biggest problems in cancer, regardless of how you're treating it, is it's like getting run over by a truck when you hear you have cancer. And that's not a position your mind and your body need to be in to maximally heal and do well and have good quality of life. And actually, the research is very clear that the more empowered you are, the better you do with drug treatments and quality of life and energy and everything else. So it's literally it's my experience over 3 decades of doing that every day with people, and what the process is to go from, oh no, I don't want to die, I have cancer, but what do I do, to actually moving towards being an empowered and emboldened patient. So it's an easy, quick read. The Outside the Box has got lots of stuff in it. The Journey from Diagnosis to Empowerment is made to be read quickly. It's got tips and takes you right through, and stories to help you understand. So, yeah.
Great. Thank you, Paul. Thank you for everything you do for medicine, to change the face of medicine. I mean, you do it. I want to publicly thank you for that. It's a big, big deal.
Thank you.
So
I work hard at it. Thank you.
I know. I'm grateful.
Appreciate that.
Yeah. Thank you again for coming on here with me today.
Thank you. It's been fun.
It has been. If you're enjoying these presentations so far, and I hope you are, because we sure are, consider taking home lifetime VIP access to the entire Mycotoxins in Chronic Illness Summit at a special discount right now.
Yes. Remember, you're going to get on-demand access to all 50 plus interviews and bonuses. And remember, by doing this, you're helping support our mission to getting this wonderful health information out to as many people as possible.
Thank you. We're so happy you're here.
Thank you. Welcome Welcome, everyone, to another edition of Mycotoxins and Chronic Illness. This is 2.0, and I'm excited today to be in conversation with Dr. Isaac Eliaz. Dr. Eliaz is someone I've known for a long time, and I really had the privilege of sharing patients and much learning over the years. Dr. Eliaz is a physician who is medical director of the Amitabha Clinic now in Santa Rosa, and he has a long history and tradition of Tibetan medicine, and also most importantly, and not most importantly, but I think most beautifully, is bringing it into helping people in oncology and cancer, and in really helping people find their lives again, and live a long time. And Dr. Eliaz has also done a lot of work in a field of medicine that I think is going to really help us move forward on a lot of levels. We're going to talk about how some of the compounds that he's been interested in have give us an opportunity to really help our healing. So, Dr. Eliaz, Isaac, it's just so wonderful to have you today. And before we go into the topic of mycotoxins, I just really want to get a background, because I realized before when we started to talk that I never got the full story of what got you interested in galectins and galectin-3. And I know that probably no one out there knows what galectin-3 is. So tell us a little bit about it and how you got started with it.
Yeah, of course, Eric, I'm so happy to spend this time with you. We know each other for decades. I actually believe it, for almost 25 years. And every time we chat, it's like we get so excited like kids, which is good. It's a sign of health. Yeah. So in my background, I'm a physician. I'm a licensed acupuncturist. And so I studied a lot of Chinese medicine, and I'm a healer. But I'm also an active researcher. We actively research, publish papers. And with this as my interest, and cancer as my focus, and other hard to treat illnesses, including mycotoxins and Lyme, I was always interested in innovation and formulation. I am a native of Israel, and in my neighborhood, in my small street, there were Ruth and Leo Cohen. They were both PhDs in organic chemistry. They're not alive anymore. And they were the pioneers in the citrus industry in Israel. Israel was very famous for citrus industry, especially in the 50s, 60s, 70s. Yeah. Most of the country was citrus. And they were the main researchers of the main industrial complex around citrus. And one day, as we took our evening walk to the house, I remember I was 12 years old, and Ruth turned out of the blue. She turned to me and she told me, Isaac, one day they will find a cure for cancer from the peel of the citrus fruit. And somehow I remembered it. And 24 years later, when the first research on galectin-3 came out by Dr. Avram Raz, which I formally collaborate with now, I publish with, I called her up. I was in San Francisco, and it was 1995, and I was telling her, Ruth, it's Isaac. I don't expect you to remember, but I remember what you told me. I need your help. And she put me together with some legendary pectin experts. One of them was already retired, Professor Pilnik. And somehow I got to plug into the most sophisticated pectin researchers, and it helped me in a journey of developing a commercially viable, reproducible galectin-3 blocker from the peel of the citrus fruit. And what's amazing, and I reflect on it, Eric, when I talked to Dr. Avram Raz, none of us have dreamt and expected that we are touching a field which is so big. It started with cancer. And then as I was moving on, after a few years, I started seeing the connection with inflammation and fibrosis and removal of heavy metals and immune enhancement, which were I discovered it. I have the developments on this, the patents. And now it's so big. There are close to 10,000 published papers on galectin-3. There's every day published papers on galectin-3. And even on our compounds, there is pectosols, there is more than 75 papers. But it all started with this intriguing comment that somehow got into into my, stuck in my mind. And it's really, I see it as nature's gift. It's really nature's gift, modified citrus pectin.
Yes, I love that. I mean, that the magic of life, when that always warms my heart, when these things that some people would just let pass by, but the right person held on to. And the modified citrus pectin is that's what we're going to weave through our conversation, because I mean, like, as we were talking before, how chronic inflammation in all of its ways is what really, to me, is chronic illness, and how you have found such an interesting, organic, safe tool for us to use as in the healing path. So, how do you, like I said, how do you connect this? I mean, with the mycotoxin world, I guess. Let's start there. I mean, like, where, we'll go back to survival and all the important things, but I just want to jump in. Where do you connect the mycotoxins and the galectin-3?
Mycotoxins are enhanced in the presence of the main protein, galectin-3. And I think in order to really understand it, because Eric, one of the issues is that when you look at, like, let's say on the papers on Pectasol, you will see we just published a multi-center trial on our modified citrus pectin and recurrent biochemical recurrence of prostate cancer. Okay, it's a biochemical recurrence. The prostate was removed and now the cancer starts coming back. Well, it's coming back in a unique environment,
Yeah.
And we see like almost 80% response. And when we follow for a long time, 80% of the people who responded are responding for years. Then you see publication that I published in other important papers on sepsis and acute kidney injury, on perfusion injury. You see on NASH, you see, how is it possible? We really have to understand the role of galectin-3 as our fundamental, what I coin, survival protein. It's our basic survival protein. And we are built to survive. We're talking about it a lot, right? We are built to survive. It's innate in us and it's automated in us. And this survival response, if it is innate and automated, we can't control it. So the first reaction is our autonomic nervous system, right? We immediately respond with a sympathetic response that we can also calm down with the parasympathetic response. But what we have found, a lot of my personal research, is that the biochemical survival response starts possibly within seconds, but definitely within minutes. So galectin-3 will rise within minutes, and then it will start a chain of events that will lead to the cytokine storm and to the abnormal inflammatory response. For example, I've shown in the most acceptable animal sepsis model called CLP, that if I give our modified citrus pectin before the procedure is done, I attenuate dramatically the rise in interleukin-6. So galectin-3 rises first. For a short time, it's enough. It's a message. But it starts this crazy vicious cycle. And then IL-6 goes up and up and up and up. Kidneys get damaged, the animals die. If you block galectin-3 or you remove it, you attenuate the process. So why? This is a survival response that causes inflammation. So now, if we want to look a little bit deeper in it, we say, how can we respond to survival? Well, it's a fear and flight response. Fear, flight, or fight. We either fight, we create inflammation, or we run away, or we hide. So the hiding is where we create a shield around us. And the shield, in the case of mycotoxins, is our biofilm. So biofilm is a very big term. Biofilm is a atherosclerotic plaque. Biofilm, really, if you want to look at biofilm in a deeper way, Eric, biofilm is really creating a microenvironment, an environment that is manipulated and becomes different than the environment outside of this very small area, where the players and the influencers can take control. So biofilms serve fungus where they can excrete mycotoxins. Of course, you have them in the gut, but you have them in the sinuses, where they can keep on excreting, mycotoxin that will go into the brain. And the classical microenvironment is the environment of the cancer cell or metabolic abnormalities. So it's really fascinating. Now, why is galectin-3 the key compound? Because it gets awakened almost immediately. It travels to the place of the inflammation, and it has a special structure, which what we call a carbohydrate recognition domain, and it binds to different inflammatory compound, different growth factors, different immune molecules that can suppress the immune response, and it creates a pentamer of 5 structures like this. And then what happened, the pentamer through a ligand, through a carbohydrate like glycolipids, and glycoprotein will bind to another pentamer, and you create scaffolding, you create a lattice formation, a coating, literally, structurally. And this is really the backbone of the biofilm. Over it, you got heavy metals and oxidized phospholipids and a lot of other growth factors. And the microenvironment is a survival response. So when the fungus feels that they are under stress, either the person is under stress, there is dysbiosis, we took antibiotics, the environment is changing, it fights. And you know it so well, you are such an expert in Lyme. Borrelia under stress will wake up. It's a survival response. So in this sense, galectin-3 will enhance mycotoxins and will also allow it, mycotoxin, dysbiosis, aggressive bacteria, LPS, it carries LPS. It will allow it to attach to the gut. It will create inflammation in the gut, and it will create systemic inflammation. And this is why you see such a basic and powerful effect of galectin-3 on practically all neuroinflammatory illnesses. It's this connection of the gut and the brain. So this is a little bit about the idea of what a survival response does, and we can revisit it and talk how do we change it, because we are talking about it because there are solutions.
There are solutions, yeah. And I just want to emphasize, what you're saying is just, it's just beautiful and so important, is that this response, the galectin-3 is a molecule that if you release it for a short period of time is signaling and doing its job. But for some reason, when it stays as a persistent signal is when we get into trouble. Is that
right? It's more than this. The mechanism of repair by galectin-3 is inflammation and fibrosis. That's a problem. So you're taking the wrong pathways. If you look at galectin-3, if I was showing a diagram, I will show that it affects macrophage, M1, M2 macrophage, create inflammation. They will secrete the different cytokine, IL-1B, IL-6, etc., right. TNF alpha, and you'll go down the inflammatory path, create extra, extracellular matrix inflammation and fibrosis. Or it will enhance TGF beta, and you'll go through myofibroblast, and you'll create fibrosis in the heart, in the liver, in the lung, in the kidney, everywhere. So even for the same person, galectin-3 will control the 2 most fundamental processes: the fighting process, inflammation, right. The hiding process, fibrosis, but they all end up with dysfunction. So if you look, for example, at centenarians, okay? Right. Galectin-3 goes up with age because there's more repair, more trauma. Right. If you look at centenarians, the average level of galectin-3 in centenarians, the average age was 104, is dramatically and significantly lower than if you look at a sample of the people in the 70s and 80s. Why? Because this, except that you see in the 70s and 80s, it's really neat to look at this study, a group that are really low. These are the group who are going to be the centenarians. So there is something about our ability to repair without leaving a scar. There's a Buddhist term, like a bird flying in the sky, when, like, if you don't attach to your thought, nothing is left. So a baby gets injured, it repairs without a scar. It has the ability to repair without a scar. In utero, we lose this ability over time for different reasons: mycotoxins, heavy metals, emotional stress, epigenetics, whatever the reason is, and we get, and it triggers this abnormal survival response. And in mycotoxins, it's key. It's key because this is where the abnormal inflammatory response, the mast cell activation happens, the hyperinflammation, the relationship between the organ. And that's why addressing galectin-3 is at the root of practically every treatment that you will give, because it's driving, if you look at the research, it's driving every single chronic disease.
That I guess one of these days, I'm always like to go to the beginning is so when you have a little bit of it, so it's your ability to turn it off quickly. But if you don't turn it off quickly, then it keeps driving the response onward.
Right. So it's a little bit more than this. You can block galectin-3. You can remove galectin-3, like what my research work with apheresis.
Right.
But yet, in the local tissue, when you need galectin-3, it can still be expressed because it's needed.
Right.
But it just prevents the overexpression. So it's literally about just allowing to get the message and then calm the whole system. So if we are very resilient, if we're very flexible, we let go. So, we talked about it in some of our last, talks that we spent time together. It's really about letting go. When something happens and we address and we let go, everything is different. We let go of emotions, we let go of traumas, we let go of thoughts. There's better circulation. Everything is flowing, right? We look at our heart. If our heart stops contracting and we stop flowing, we are dead. So when we hold to something, when we create a rigid environment, it's really the difference between life and death. And that's really what happened in the microenvironment. We create an hypoxic environment, even in the presence of oxygen in other tissues. And once you get a hypoxic environment, then the whole chain of event and the pathways changes in the cell. So in oncology, it will be P53 and AKT and mTOR1 and HIF, and the mitochondria get blocked, and you get the Warburg effect. In diabetes, you get AMPK, and the metabolism changes.
Right.
Now, these are very similar metabolism that you see in mycotoxins. The mitochondria stops functioning. Why? The cell lost its ability to take a deep breath.
Yeah.
It lost its ability to just relax, to feel safe. So it's about reintroducing the sense of safety, and anything goes, any method, from blocking galectin-3, which is fundamental, to training your mind, to working on your emotions, to opening your heart to others, to sharing, and to feeling safe on a cellular level, and as a being, as a community, as a country, as a planet. I mean, we see it right now, right?
Yeah, no, absolutely. It's funny because that's it. In a way, the Warburg effect is the inability for the cell to exhale, because the oxygen goes in, but it's not used.
Right, exactly.
I like that. Yes, we forget to exhale. Oh God, that is.
In order to inhale, we have to exhale. So what we're going to go to different places because our character. Exhalation is at the root of detoxification. Yeah. We come to this world, what's the first thing we do? We exhale, we cry. Yes. What is the last thing we do in life? We exhale before we leave our body. It's one final exhalation. So when you exhale, you create space. And when you create space, change can happen. You can't inhale if you didn't exhale. You need to have room. And as you know, the lungs' natural movement is a movement of exhalation, of letting go. In Chinese medicine, it's the fall season when the days get shorter. In Judaism, it's Rosh Hashanah. It's the fall. Yeah. We look what we did right, what we didn't do, and we ask for forgiveness, and we exhale, we let go. In Buddhism, it's every night we do it before our sleep. In every tradition, it's the same way. When we let go, there's a place of nourishment. And this is why I really call the healing process detoxification, transformation, and healing. And it's done very different on a cell level, like you mentioned, cell danger response, but our body is built to do it differently. And we're kind of jumping almost to
go. Keep going. You're jumping beautifully. Don't worry.
We're almost jumping to the end, but we're not jumping. If you look, and this goes back into mycotoxins, okay? It's about respecting the outer environment and the inner environment. So one thing that we overlook is that we are made, I'm going to round the numbers up a little bit, tiny bit. I don't know why they say 37 trillion, but we are made out of, let's say, 50 trillion cells. Eric, do you know how many reactions each cell has every second?
How many what?
How many reactions every cell has in every second?
Oh God, I have no idea. A lot.
Up to 1 million reactions a second, okay?
Yes.
So you got 50 trillion cells with million reactions in one body working together. Now, if that's not a miracle, I don't know what's a miracle. For us to be able to talk and comprehend, it's truly a miracle, you know, just for the system to work. But then we got, people can argue 50 trillion, 100 trillion of microorganisms in our microbiome and 90% of our genetic material. And there's an amazing dialogue between us and the microbiome, which is similar to the dialogue between our cells. So when we respect the microbiome and we treat the microbiome well in many levels, and we each come to this world with a little bit of a different baseline, then the microbiome becomes our biggest helper. I mean, it's amazing how you need a healthy microbiome for immunotherapy to be able to kill cancer. Or you give a drug like adriamycin and you give antibiotics the same day, adriamycin is not going to work. The microbiome has the wisdom to activate nutrients and to even activate drugs that we need for our body. When we insult the microbiome through dysbiosis, it goes into a fighting mode. You get abnormal bacteria, you get less variability, and fungus loves to grow. Then you give it a little bit of, you sprinkle some mercury inside, you know, and completely it goes, and then it gets methylated. And then all this abnormal environment is affected with the vagal nerve and affects your brain, and you really get a mess. But a part of it is really looking at our relationship with the microbiome in an harmonious way. And maybe to close the circle, we are built to do this. Why we are built to do this? Because every cell in our body wants nourishment and lets go of toxin. It's part of the cellular survival. But there is a concept, you know, in Hebrew, you call it arvut adadit, mutual support. There is a relationship between the different cells where a cell knows I'm going to live and then I'm going to end my life through apoptosis and another cell will come. If a cell gets stuck in a survival mode and doesn't want to really let go, that's per definition what cancer is, and then you get a microenvironment. But the fungus does the same if it's attacked.
Yeah.
The only organ in the body that thrives on taking others' suffering, what every cell didn't want, that's its survival. It can't survive without it. It is built in is the heart. The heart has to take dirty blood. If it doesn't, we're dead. It connects with the universe where our drama is not very meaningful to the endless universe. We connect with oxygen, with healing. And then when you come back to the lung, there's an exchange, a transformation in the capillary. You let go of CO2, of toxins, and you get nourished. And then the heart just gives without discrimination. So the aorta is a stiff artery. Think about it. It gives everywhere. And who does the heart nourish first? It nourishes itself. It nourishes itself with the coronary arteries in order to be able to nourish others, but as part of nourishing others. No, it's interesting. I haven't found, it's kind of was my insight one day when I was meditating, said, oh my God, nobody is really talking about this. Our heart is built to heal, to transform difficulties into love, compassion, and healing. And through our electromagnetic field, the field of the heart is so big, it's 100 times bigger than the brain. It gets to every cell in our body all the time. So when we bring this into our body, and that's why stress is an issue, it affects every cell in our body. And the other thing which is so amazing about the heart, which is really my big passion, I call the work I do open heart medicine. It's another book that kind of written, I just have to put it out. In open heart medicine, one of the interesting, when you look at the heart, it's the only organ that now doesn't nourish itself until it has finished its work. Think about it. It's done, it's giving the blood, and only then it takes blood.
Then it relaxes.
It's very unusual.
Right?
You know, it's very unusual because it's okay, I've done my work. And that's the selflessness of the heart as part of its role in this body. So if we can get a sense of harmony and sharing and open heart, for example, into the gut, then of course the environment changes. A fungus doesn't feel threatened. it won't excrete mycotoxin. Then you got the mycotoxin being excreted. You got a biofilm that allows a microenvironment which is hypoxic. You call it dampness in Chinese medicine, ideal for growth of fungus. Then you got a little bit of glyphosate or a lot of glyphosate sprinkling in and messing out your tight junction in the gut.
Right.
And then, then you get autoimmune disease, neuroinflammation, chronic kidney disease, cancers.
Well, yeah, no, glyphosate is definitely a, how do you say, it's a great example. It's in a way, it's the flagship of the last 70 years of chemical toxins, but somehow we've managed to create one that we've used everywhere on all of our food, and just get it totally into the environment. And that's something that you have been intrigued with for a while now.
Yes, I've been intrigued about it. And one of the reasons that I've been intrigued about it is that I really feel like I knew it, we all know about it, right? But we kind of almost accept that it's part of reality. And we don't realize how bad it is until, a few years ago, it kind of clicked on me. Oh my gosh. I mean, this is like an obstacle for healing, especially in the United States. I mean, and interesting, Eric, it's very hard to get the data, how much glyphosate is being used.
Yeah.
After 214, it's very hard. Even 212, you can't get the data, even if you look for it. So some people say it's 3-4 pounds per person per year in the United States. Some people say but it's an insane amount. And what happened, it is water soluble, but it does bioaccumulate. It's clear now that it bioaccumulates. You can find it in organs of animals. You can find it in bones. And it's really so similar to glycine, which is the smallest amino acid, that it can easily exchange with it. And the glycine motif is so common in so many protein, in collagen, in different tissues. And I think finally the world is waking up. There are so many parts in the world that glyphosate is not allowed, like in Europe. And I think in the United States, supposedly in 2023, it's not going to be used anymore in the household, which would really bring down the awareness, while 95% is still being used in the fields.
Yeah.
And so it's something we have to be aware of. And the nice thing, I'm solution oriented. So I've found, I was talking about the fact that pectasol, that modified ciprospectin, is a gift. So I started publishing on the heavy metal removal properties of modified ciprospectin, started researching it in 1998. And we published a few papers on the ability of MCP to remove lead, to remove mercury, to remove uranium, cesium, without depleting minerals. So we understood this ability, but when you look at glyphosate and pesticides, you really have to address the gut. So what modified ciprospectin does, it chelates heavy metals while harmonizing the immune response, and it has a systemic effect. But our exposure to pesticide through the gut is ongoing. And for this reason, I really worked on developing something specifically to change the environment and also address negatively charged ions, and look at glyphosate, look at which of our kingdom it affects. It affects plants, it affects the soil, and it affects the water. So I was looking for solutions from the three kingdoms, because always nature is smart. When it has a challenge, it puts out a solution. So if you find the solutions, that's my starting holistic point of view. And then the research comes into it, of course.
Yes, but that's always the part of your brain that I've loved, is that you start from the beginning.
Yeah.
Yes, but
So
you keep going.
No. Keep.
No. It was just because the glyphosate. I said, you say it's just one piece, but what concerns me so much about it is that we measure it in people who are really, really careful about their organic diets, and they're clean. Really clean living people, as good. As good as you can get. And many times it's very elevated. So that means that this is coming in through so many different ways into the environment and into the individual.
Of course, it's if you look at pesticides in a flat area with a lot of the soy field, the corn field, pesticides can travel 10, 15 miles. And, horizontally. So yeah, you can have a really nice organic field in 3-4 miles down, especially if there are hills, like in Sonoma County, you see people see, oh, I'm eating organic, and you look from the window and you see all these sprayed vineyards for like 500 acres, all elevated. Yeah, of course, the whole water table is coming straight into your well or into your water. Yeah. And I think the one place where it was very evident for all of us is that our gluten-sensitive patients, when they go to Europe, they go to Italy, which doesn't use glyphosate, suddenly they can eat pasta, they can eat bread. Absolutely. No problem, right?
Yes.
They come back and suddenly the gluten sensitivity. So we kind of tied it to the GMO, but it's really the glyphosate, because glyphosate increases the growth of fungus on wheat. It increases the excretion of mycotoxins. Now, galectin-3 activates the excretion of, for example, anti-glial mycotoxins. So galectin-3 will increase the excretion of mycotoxins because of the reaction, but also glyphosate will allow mycotoxins to thrive, and glyphosate is very tricky. And it's not the glyphosate, there are thousands of glyphosate formulations that are not regulated, okay? When we get an herb we use that has one side effect, it's in every major newspaper in the country, right? Somebody got to the ER. Yeah. But nobody is regulating these additional compounds in the formulation, which are often more toxic than the glyphosate itself. So you got glyphosate it's really one of its mechanisms. It chelates nutrient. It chelates every metal. So, for example, it will chelate tryptophan and will not allow lactobacillus to grow normally in the gut and will enhance mycotoxins. It will create inflammation in the lining of the gut that will lead to gluten sensitivity. This is well published and documented, acceptable, but it also will increase, for example, chronic kidney disease very significantly. And chronic kidney disease is one of the most underspoken. 17% of the population, 17.
It's considered normal at this point. Yeah,
exactly. And it's an area that I do a lot of research, and I published on CKD and AKI. But why? The kidney has to filter all this stuff, and it's filtering it. Or then on the other end, you get neuroinflammation. Glyphosate is involved in practically every disease of neuroinflammation. But it's this combination with galectin-3. If you look at the Alzheimer plaque has 20 times the concentration of galectin-3 compared to a normal tissue. So galectin-3 will potentiate glia cells to go into an astrocyte to go into an inflammatory cycle without stopping. So similar to the macrophage in the bloodstream, right? There's some fascinating studies. I don't want to go too much into it, but if you look, a great study that published 2 years ago showed when you did an injury in an animal model that created acute kidney injury, it increased galectin-3 levels, and then it traveled to the heart and caused fibrosis and damage to the heart. When you gave it to an animal who could not produce galectin-3, or you used our MCP, you prevented the effect. Again, these are done by big third-party academic institute. But when you took an animal without ability to produce galectin-3, okay, and you injected bone marrow that could produce galectin-3, the damage done to the kidney sent a signal to the bone marrow that produced galectin-3 that travel to the heart and create the damage. So that's an example of this injury response inflammatory compound. So galectin-3 will create neuroinflammation and glial response. Glyphosate will create it. And that's why we have to address both of them. And in the gut, you will say we have to address the biofilm, change the microenvironment, and we have to address the toxins, remove the pesticides. These are the manifestations of this very basic processes that are so damaging to us.
Yeah, it makes me want to ask you a philosophical question, which we don't have to answer today, but it just is that like what, we have grown into a world of inflammatory diseases. And it's not just the inflammatory diseases of the aged, because we're finding it in younger and younger people, all these chronic inflammatory diseases. And galactin-3, pardon me, is such a basic part of our physiology that we used to be able to control it probably better.
Of course.
So what is, again, it's the lack of control that's getting us into trouble. And that's that question is, is it just the toxin load? Over the last 120 years, and obviously the change in the diets and now the introduction of the chemicals, whatever it is, it's produced quite a change that we are now seeing such inflammatory disease in young people.
So it's really about pacing. Inflammation is heat, right? And heat is kinetic energy. And kinetic energy is created by friction. If anybody listening, you take your hands and you rub them, you produce heat, which degrades, whatever cells are being degraded by the friction. So we are now in a time of inflammation where the space between activities is getting shorter. The space between our reactivity is getting shorter, right? In the past, even it's insane. 40 years ago, we would send a letter. When my father was a civil engineer and he worked in South Korea, and I would write letter in 10th grade to my friends in Israel, and they would mail the letters. I would know what's happening. And every 2 weeks, I would get a letter and I would read it. Then came the phone and the cell phone. Now, if you don't answer a text in 2 minutes, what's going on? You forgot about me, Our span shortens. Also, our span, the space between our thoughts shortens, and we create a very condensed area. So there are two, and this is so important for mycotoxin people. This is like, I'm going to give now a joule, okay? I will define this as a joule, okay? So in the level of the mind, we want to create space between the thought to reduce our reactivity. That's a hard job to do because our tendency is to hold, to grasp, to identify, to survive. But if we move from our heart, from our brain, from our thinking to our heart has no concepts. The heart flows all the time. It never stops to think. The moment it contracts, we're dead. We get hyperviscosity, elevated lipoprotein A, no oxygen. So when we move into our heart, we are increasing the spaciousness. And from the point of view of mycotoxins, one of the key things to really consider is that our relationship to our symptom. Okay, so it's very important because that's where muscle activation falls in. So if we look at the survival response, one of the characteristics of survival is that some people are alarmists. They always see the trouble going, oy vey, right? It's a Jewish mantra, right?
Yeah.
Also in the Holocaust, we forgot to actually see it, it was the optimism, the other part. But so we overreact. So you have a headache and when I get this headache, usually I'll feel tired and then I'll get this kind of symptom and this kind, and we go down the habitual chain of symptoms. But if we could just let go of the headache and not identify it with other things, not hold to it, not struggle with it, we are reducing the survival response. The fungus in our body is getting a message that there's less danger. You can relax. You don't need to protect yourself because mycotoxins are excreted to protect the fungus. That's why they're excreted at any cost. And the irony and the sad part with infections, with cancer, eventually, if you kill the host, whoever is visiting the host is also going to die. It's not good for anybody. Harmony always works better. So this is a whole approach that is happening to us right now. And this is why, while I'm a researcher, I spend a lot of time in teaching meditation and healing. And the group of patients that responds best are the patients with chronic fatigue, with mycotoxins, with this chronic inflammation where it's very dramatic. And the reason is it's easier for our body to communicate in these areas. It's much harder to communicate with a cancer cell, which is completely independent. It's dysregulated. It doesn't want to listen. So using the mind to affect cancer is very challenging. Using the minds to affect inflammation is not as challenging. And once we create space, what happens? Oxygen comes in. And then once oxygen comes in and we are relaxed enough, suddenly our insulin receptors work better, AMPK gets activated, we produce more ATP, there's less hypoxia-inducing factor, mitochondria is starting to celebrate, glyphosate is not stealing our nutrient, and you get all the B vitamins, and PDH is working well, pyruvate dehydrogenase. Everybody's happy, and we can produce energy in a relaxed, efficient manner. I mean, it's amazing how glycolysis produces 100 times faster energy, but it's a terrible inefficiency of 2 ATP per glucose and tons of lactic acid and hypoxia. So these are the vicious cycles. So, you know, because I know how you work and how you think, and we think similarly. We have to address an acute issue. We can't say, let's talk about what happened to your grandfather 3 generations ago, right? But at the same time, we got to address the bigger picture. And that's the true journey of healing. So it's a combination of seeing the really big picture, which is beyond concepts, where you don't even set up an idea what your patient has. You just let it express itself. But into it, Eric, you know, you look at your history as a doctor, decades of experience. So you sit, you listen, and suddenly the insights come up, right?
Well, that's how we work.
But if you limit yourself to a preconceived idea, like an algorithm for the regular doctors that I feel bad for, you know, they're bright people who just took a different path, then you really don't have choices. Anything out of your scope creates survival response, creates fear, creates skepticism. Because what would happen if everything you believed in was found to be not true? For you and for me, we move on.
It happens all the time.
Exactly. That's part of it.
Yeah, you know, I always say, if I knew, you know, I wish I. Yes, the smallness of thought is just what happens when you start with algorithms, with cookbooks. You know, and again, you need them when it's life and death in the moment. You know, one of the reasons I don't think I was not as great of an ER doctor as I had wanted to be when I first got out of medical school was because I would say, oh, it could be this, but could be 6 other things too. Maybe we should, you know, and you know, when you're in the ICU or in the emergency room, you need to make a decision quick, you know, but could be. But the could be is what allows life and what allows the expression of the other person, because, you know, I say chronic disease is the individual expression of the other being, you know.
So it's when you don't restrict, you give the person more options. You know, often I always tell cancer patients, you always have options. At your deathbed, you have options how you're going to die, how it's going to affect the environment, and we always have options. We always have options, and options create space. Space creates letting go. And when we let go, everybody's happier. Everybody. I mean, it's sometimes incredible how like political and geopolitical crises happen because both parties are not willing to let go of something that will work better for both of them. You know, it's insane, right? And so, you know, you see this all the time. So the same thing happened in the dialogue between our body. If you look in my book, The Survival Paradox, where I really put all these decades into which it's a good book. I mean,
no, it's an excellent book, especially because at the end you've given some just succinct, just to do things that are not too difficult with good explanation. It's not the kind of like how to take care of yourself book that you have to change your whole life. You just have to be open to pieces. Yes.
Right. Longer, but it's also a journey. And so you know, we really have to really look what it's going to take, you know. And so I think when we understand this and suddenly we go to the biochemist, we recognize galectin-3, we understand why there are studies where MCP helps antibiotics in Lyme. It it promotes healthy gut. We did a number of
The
publications.
MCP for everybody is the modified citrus pectin.
Right. Yeah. And so we have multiple papers on pectosol and its effect on the gut health, because it's part of releasing this struggle survival response. But then we really have to address pesticides. I'm more and more emphasizing it. So in this sense, in glyphosate detox, what I did is recognizing the different kingdoms. I took a different kind of pectin. It's not a regular pectin. It's a pectin that is high molecular weight and binds better lipid-soluble toxins, which are very important, especially with mycotoxins.
Yeah.
And it stays in the gut because I need to address the gut. So this was my planned binder. See, pectosol is not, there are binders and there is pectosol. Pectosol addresses galectin-3. It's also a binder of heavy metals, of toxins, but it addresses a fundamental survival issue. When you come to addressing a pesticide and mycotoxins, so you got the pectin, and then you got the alginates. Alginates and pectins both are belong to a group called polyuronides. They bind very well to positively charged heavy metals, to toxins. They are really swamp cleaners. When there's toxin spill, you put alginates. But then we're using kelp, and kelp is documented, one, to bind to glyphosate, but also kelp has life. It offers us nutrient, it offers us minerals. And so this way we are covering the water issue, the plant issue, and then we come to the earth. And for the earth, one of the most amazing leftovers of the earth process is shilajit and fulvic acid and the different minerals. And fulvic acid was well documented, to bind to glyphosate. All of these compounds stabilize the tight junctions in the gut. So we're getting better integrity. And then for people interested in formulation, you always want to fuel your formulation. And I'm fueling it with glycine, because glycine helps glutathione, helps detoxification, helps neuroinflammation. And so when you put it together, we are seeing not only help in the gut, but we're also seeing help in neuroinflammation based. And we are now, I'm shifting some of my research activities in the level of clinical trials to this formulation, because I feel we need to make a strong statement and get some decent papers published so we get listened to. In my career right now, I got some grants from the NIH as a principal investigator, and I'm not part of academia, but I've done enough work and have enough people who are amazing people from academia who are working with me. It was acknowledged even by the NIH. So we have to do the same thing with pesticides. So it moves from rumors and alternative to showing it and offering a solution. The worst thing we can do, right, is like just cause fear without offering a solution.
Yeah.
At the basis is understanding the survival paradox, because the same way that we want to survive, the fungus wants to survive. The COVID-19, the coronavirus wants to survive. It's not surprising that the spike protein of the corona is practically identical in structure to galectin-3. It's survival protein, and how it functions by creating inflammation.
Yeah.
So it's really, we have to recognize that everyone wants to survive. And as long as we can create a harmony, but as you said, in emergency, you said, we got to bring the person into balance, we got to make the decision. And then I think it's really our only way out, Eric. We're kind of a little bit spinning out of control.
Yeah, no, I loved what you said in the middle there about, how creating some space, not demanding, and that's just in all things, in our health, in our world, a little bit of space. Don't have to answer that text message in 30 seconds. And and allowing, and just understanding that even the microbes that we worry about, the mycotoxins and the fungus that live, but we have lived in harmony with these for billions of years,
Billions of years.
Yeah, our cells grew up, the system grew up together. So it's not like we're implacable enemies. We really have to find a way to coexist again inside this polluted world that we've created.
Eric, this is fundamental what you said to it. Like people need to kind of repeat it. It's fundamental to healing because, you know, Western medicine is based on finding a pathology and treating it. It's not, it can't hold to the concept of maintaining health. It's non-existent. Medicine is based on a pathological change, which loses, by the way, its dynamic. If you think about India or Asia, everybody has parasites and they all live their lives. There is a certain level of harmony, you know, of living with it. So the same thing happens here, and we really have to get to this point, but it's a journey because often we need to recognize we can do our best, but we don't come with here in like a clean paper. We have our genetic predisposition that we are carrying, and we have our epigenetic predisposition. And there's a very beautiful saying. It's not a biblical, it's an old Talmudic saying that says, "Akol tzafui v'hareshut netuna." Everything is predicted already, but we have a choice. The prediction is our genetics. The choice is our epigenetics. And so we have a choice to change. And when we change, our environment changes. You know, in my book, I write the story about, I have a chapter towards the end. My last 3 chapters are about how to heal. It's called Healing the Scars of Survival. And I talk about my story, the Holocaust survival, and how it affected my grandmother, my grandfather, them named after I never met, and my mother. And now when I healed from this without telling them, it affected my mother because she was carrying the trauma from the previous generation. So when we work in this level, we are creating multi-generational healing.
Yes.
So it's all of us have, you know, so many cultures have their own Holocaust, their own traumas that they carry. Every generation it's somebody else, you know. I mean, it's kind of amazing, you know, thinking, I mean, I'm living a good life, and most of the siblings of my grandfather were killed by Hitler, and I didn't know them. Nobody told me about it, but it was carried in him. It was passed to me. I had physical symptoms in my chest, always had pain that I couldn't explain. I was a yoga teacher. And when I let go of it with meditation, with my own healing, all the pains went away. But then my mother, who could never look at any movie or any program about the Holocaust in the early 80s, suddenly was able to watch TV programs and go to like special evenings about that you would never be able to do before. I didn't tell her about it. It's our connection. So multi-healing is bigger than what we think. And what we need to recognize is we need to be humble about our understanding and understand that linear thinking and logic is one simple plane in this multi-dimensional reality that we can't perceive with our regular, you know, thinking process. And just being open to it, then we have a lot of possibilities. And that's why I love, one of my most favorite saying is, not everyone will be a miracle, but anyone can be a miracle. When we can be a miracle, what is a miracle? No, Eric, before we started, you asked me. A miracle is something that is not expected, right? So you can define a miracle as 1 to 10,000, pretty impressive, you know. 1 to 100,000, that's really a miracle. You know, 1 to 1,000,000 is like mind blown. As long as we keep the same habits, nothing is going to change. So it's expected. The more we can change our habits, the more a miracle can happen to us. Why? Because we take a different highway. And we always have this option with every breath and with every thought. So if people wanted to really look at it from a mind point of view, which is my big passion, and I teach, you know, on a volunteer basis. I teach many in Israel, but I will start teaching later this year in the US, because I've spent decades training in Buddhism, you know, 2 months a year in the mountains for 20 years, and for 10 years, half-day retreat, half-day work. Remember, we were talking when I was going to leave on 3 years, and you're going to come and take the clinic. 2008, remember? And I went to the mountain, and I spent months and months on my own. So really, we really have to really understand the multi-dimensional experience, and then it all boils down to connecting with our heart and opening it and allowing everything to flow. You know, that's really what it's about.
Isaac, that was just beautiful. Thank you. I mean, no, really, that was a teaching. You know, I hope people appreciate, you know, how multidimensionally important that is. You know, we have, yes, you know, modified citrus pectin, but it doesn't matter how much you take, changing your heart will let it all happen.
And it's interesting, Eric, if you think about my specialty in therapeutic apheresis,
Yes.
which I use a lot in mycotoxin, I'm treating the person outside their body, right? I'm making it bigger than the body. So for me, it was interesting in my own journey, kind of, you know, you asked me to share that on one level, I had this from younger, this very strong draw to esoteric, to meditation, not because I had a trauma, I had a great childhood. Something is a calling in me. Yeah. In the same time, I ended up being the leading clinician driver of galectin-3 and dissolving it, which creates isolation. You know, one of the key organs that the galectin-3 affects is heart failure, but not all heart failure. Ejection preserved heart failure, which is when the heart becomes fibrotic, it becomes hard. We are not giving, we can't expand, you know. So it's always fascinating for me how I came to it from a pure science, breakthrough, publication, research, and from my own non-conceptual, just, you know, being in the mountains, studying with many of the great meditation masters in the Himalayas. And now that I'm not as young, it's coming together. And so really my journey now is sharing it in every possible way. That's really what drives me to share. That's why I wrote my book. It's, you know, it took me to my early 60s to put things in writing. You know?
Well, really thank you for doing it. I mean, Isaac, it is beautiful. And, you know, I can only say it is, you know, you spoke so much wisdom, and it is so true that, you know, our medicine is, you know, the NIH, it's all based on pathology, which is not, it's useful, but it doesn't get you back to health. It just keeps you from dying, which is, you know, many of us will take that. But if you want to be alive, you have to go for health.
Yeah, completely.
And healing.
Yeah.
And that is a non-linear process for sure.
Totally.
Well, thank you so much.
Thank you, Eric. Every conversation with you, I learned so much. It's very inspiring to talk to you. I mean it, you know, because I can, you know, I can relate, you know, I can just feel it. I can just, you know, I think both of us, I remember our first conversation in the car over 20 years ago when, you know, we each looked at each other and said, oh my God, we can understand each other, you know, finally somebody to talk to, you know.
Yes, and so it's a journey that we will continue.
Yeah, thank you so much. Thank you for the opportunity.
Well, yes, really, yes, you too. There's so many blessings, Isaac, and just people should just read the book. It really is. It's just a work of the heart, and also just, you know, I can only say that the pectin products, and the thought. I want to end this just with the thought, the balance that you put into it, because that's what comes from the deeper work. You know, there's the biochemistry, but it is from that deep understanding of the Tibetan medicine, I think, that brings the balance to what you create. So thank you again.
Thank you.
Blessings. Bye-bye.
Eric, I am enjoying this Mycotoxin and Chronic Illness Summit so much.
Yes.
I mean, I've enjoyed putting this thing together with you, creating this community together.
It has been a joy, and to have a chance to interact and listen to so many experts on so many different subjects. But at this time, I'd really like to hear from our audience.
I would too.
So please press on that comment section below and let us know what you think.
Definitely. Let us know what you've been inspired by. We want to know what's moved you. We want to know what's helped you see things in a new light.
Yeah. So the comment section is ready, and please use it. We'd really appreciate it.
Yes, we look forward to reading all of your comments.
Thank you.
Today, I'd like to welcome Dr. Jill Carnahan to our Mycotoxin Summit. I'm so honored to have you today, Dr. Jill. I'm going to start by introducing with your bio. Dr. Jill Carnahan is your functional medicine expert. She uses functional medicine to help patients find the root cause of their illness and identify nutritional and biochemical imbalances that may be contributing to your symptoms. Dr. Jill will search for underlying triggers that contribute to your illness through cutting-edge lab testing and tailor the intervention to your specific individual needs. She uses nutrition, supplements, lifestyle changes, or medication to treat your illness, and always seeks the gentlest and least invasive way to help you find hope, restore health, and optimize healing. She completed her residency at the University of Illinois in family medicine at Methodist Medical Center, and received her medical degree from Loyola University in Chicago. She received her Bachelor of Science in Bioengineering at the University of Illinois. Dr. Jill is a survivor of both breast cancer and Crohn's disease, and passionate about teaching patients how to live well and thrive in the midst of complex and chronic illness. She's also a widely sought after inspirational speaker and travels the world to teach physicians the principles of personalized and functional medicine. She's a prolific writer, speaker, and loves to infuse others with her passion for hope, health, and healing. She's been featured in Shape Magazine, Parade, Forbes, Mind Body Green, First for Women, Townsend Newsletter, and the Huffington Post, as well as seen on NBC News and health segments with Joan London. She recently co-authorized the Personalized Precision Integrative Cardiovascular Medicine textbook, and her prescriptive memoir will be released by HarperCollins Zondervan in the fall of 2021. I am so honored to have you here, Dr. Jill.
Thank you so much for having me. I'm so excited to be here with you and to talk about my favorite topic.
Great. So let's start by talking about how you would first assess if a patient who enters your clinic has mycotoxin or mold illness. I know that it can be a confusing thing for patients. So how do you begin?
You got it. So, if there were one, I always get the question, if there's one test for mold, what is it? And people ask on the blog and ask on all places, and there's not one test, and I'll explain how we assess. But before I do, I want to tell you just a tiny bit of background. We are both traditionally trained in medical school. We're just not taught that mold is a systemic, multi-symptom, multi-system disease. We're taught it's an allergen. And a lot of the stuff we've learned in the last decade or two was not part of traditional medical education. And it's sad because there's so many people really suffering from it. Now, a lot of the stuff we're talking about, it's very science-based, but we're kind of on the cutting edge of what's possible with healing and diagnosis and treatment. So things are constantly changing. So today you'll hear this and we'll give you the very best science that we have, and it might change in a month or two, but the basic principles are the same. So diagnosis and treatment. Basically, diagnosis, you're going to look for inflammatory signals in the body. What happens with mold is mold not only is an allergen, as we were taught in medical school, but it also causes a systemic cytokine response in the body. And there is a difference with genetics. There's a portion of the population that has more trouble tagging and identifying these toxins and getting them out of the body. So for that reason, those subset of patients, around 25% of the population, they're going to have more collateral damage in their body. And it's not just from the mold, the mycotoxins, the spores, the fragments, which are all part of this picture. We can think about it as like toxic soup in a water damaged building. And the more data that we're finding, it's not just mold, it's not just the toxins they produce, which are called mycotoxins, but it's also bacterial and endotoxins and other fragments and things that are in this soup that cause an inflammatory reaction in the body of someone who's susceptible. And I just frame that because as we do lab testing, there's no one test. I wish there were. So what I start with in clinical practice is a great history. I ask very specific questions about symptoms. We can talk about that in a few minutes to classify if they have a lot of symptoms that relate. And in order to be diagnosed with a chronic inflammatory response to mold, you have to have multi-system, which means like the brain and maybe the heart, maybe the lungs, maybe the kidneys or bladder, or skin. You have multi-system and multi-symptom, more than one symptom in each category. So it actually crosses over into a lot of disciplines because you might have rheumatological arthritis, you might have brain dysfunction, early onset dementia, memory issues, executive cognitive function difficulties, and you might also have a wheezing, trouble breathing, cough, shortness of breath, frequent infections, skin rashes, and I could go on, but these things, as you can tell, they're multi-system, multi-symptom, and that's where we get into how diverse this is and how difficult to diagnose. So the very first thing, like I said, is a good clinical history. Those of us who do mold-related illness are well trained to ask good questions, and I would say by the time I've talked to a patient, given them plenty of time to tell me their story, I am with about 99% certainty accurate on the diagnosis of mold versus not. And then I prove it with a test that I'll tell you about. Then what we do visual contrast testing, which tests the visual acuity of the retina. These are some of the smallest blood vessels in the body. And the reason this is important is because cytokines that are created by the mold response damage and cause inflammation and leakage to blood vessels. And so we can actually measure that damage with the visual acuity testing. This is scientifically based. It's been used since the 1940s in the armed forces to determine if they were susceptible or if they were exposed to biological warfare agents. So it's not just for mold, it's for any biological toxin. But if they have a positive history and then they have an abnormal visual contrast test, those two things are free. So right now I've come to a pretty good conclusion with spending no money of the patients or of my own. And then the next things are testing. So if those are both positive, I usually do proceed with testing. Blood work is important to me. Not all doctors do it. I do like to do the chronic inflammatory immune markers. And some of those include the HLA typing for genetics, VEGF, which is an inflammatory marker, MMP9, which can relate to blood-brain barrier permeability and lung damage, TGF-beta, which is a trigger for immune arm called Th17, which can cause more autoimmunity in the patients, antidiuretic hormone and osmolality, which determines if they're able to regulate the saltwater balance and volume in their hydration status. That's often affected by mold. And then sometimes we'll test VIP. I don't use that as much anymore. And there's other markers like anti-gliadin antibodies and autoantibodies that may indicate there's a permeability, a barrier breach in the gut, which is also really common. One final one that's very common is MSH, which is melanocyte stimulating hormone. And this is related to all of the hypothalamic pituitary axis. It's one of the grand regulators. So if this is off, the hormones can be off, the adrenal function can be off, the thyroid can be off, your hydration can be off with ADH, your oxytocin can be low, so you're isolated and antisocial. So a lot of things are affected by that. Those are blood labs. Now, none of those are specific to mold. So really important to know that just because you have a positive or an elevated TGF-beta or an elevated MMP9, that's not diagnostic for mold. But if you're a good clinician, you can look at the patterns and see many of those things abnormal in the case of someone with a positive history of exposure. And then the next test that I'll do is urinary mycotoxins. Now, this in our world of physicians that have been trained is somewhat controversial. I find it incredibly helpful as long as you know the lab, the technology, and what you're doing. There's 3 labs that do this testing right now. One is Great Plains, one is Real Time Labs, and one is Vibrant. And there may be more coming right now. Those are the 3 that I know of. I use them all. I do have my favorites, which I won't necessarily mention here, but they all have their advantages and disadvantages. All this is an excretion test of mycotoxins. And that's important to know because say you test in the beginning, you're trying to figure out a cause and you have some excretion of ochratoxin or of trichocythines. You know this person has probably been colonized or exposed on some level. And again, I'm talking, you could have colonization where they actually have internal growth or biofilms in the sinuses in the gut, or you could just have exposure where there's no colonization. But when that happens, then the next step is to determine, what's going on with their detox because you're measuring excretion. And if you repeat the test in 3 months or 6 months and you've just put them on an intensive detox, those levels are probably going to go up as they should. So it's really critical when you're working with your doctor to make sure that you know the timing, because just because you go on a detox protocol and those levels get elevated doesn't mean you're getting worse. You have to remember it's excretion. Those are some of the main things. Environmental testing is a whole nother aspect. I'm sure you'll have experts on the summit talk about that, but I can't not mention it because you've got to remove yourself from the source if you do have a mold exposure. So working with an environmental expert to measure the environment and to either do dust sampling, air sampling, or both is also really critical.
That's great. Thank you, Dr. Jill. We do work in such similar ways. Those are the same tests I run as well. One thing I want to ask you about is the crossover that you see. So then now you've done, that would be like the Dr. Shoemaker initial panel. You've done that. And then you talked a little bit about genes. I'd love to hear you talk more about that. Do you find that patients with mycotoxin illness tend to have other SNPs, like in their SNPs in their genes of detoxification, or even in cognition? I'd love to hear what you have to say. But what's your
Oh, love it. Now I could
Yeah.
spend 2 hours on this, right? But I'll talk about some of the common ones that maybe your listeners have heard about. So MTHFR is the popular kid on the block. Most all of us practitioners and patients have heard about this. This is the methylation gene. There's many, many more. There's MTR, there's MTRR, there's FUT genes, and these are all related to B12 and folate metabolism. And actually the end product here is the glutathione. So the reason it matters is these methylated Bs and the methylated donors will actually contribute in the metabolic pathway of methylation to, number one, repair DNA from damage. Number two, which also prevents cancer. Number two, create neurotransmitters. So all of our neurotransmitters that we need to think and be happy and sleepy and all those good things are created by methylation processes. And then detoxification and immune function are also critical here. So as you can imagine, that's one reason why this is so popular, because it really encompasses a lot of things we need to do. So one of the popular ones, MTHFR, if you have variations in C677T or A1298C, these can impair. So instead of being 100% activity of this genetic process, you might be down by 30% or down by 80% or 90%. So usually 2 copies, you're down in the 10 or 20% of activity. So that what that means is that process for you takes a little bit more effort and definitely requires higher levels of donors. So I don't treat people based on MTHFR, but what I do is take it into account when I'm giving them methylated Bs, and I may support more methylated Bs with an MTHFR person. Now, the caveat is if they come in, they've just been in a moldy building and their toxic load is over the top of the bucket, they're spilling out with symptoms. If I put them on 5 or 10 or 15 milligrams of methylfolate, oh gosh, beware. They will probably crash and burn like crazy.
But tell me, yeah.
Talk about that, yeah.
Yeah, it happens all the time. Yeah.
Because what happens is they've been under methylating, and it's actually protective, because when they start to rev up that methylation, they're going to massively go into detoxification, which is what we want. But if we push it too quickly, I just saw a patient the other day who, by another doctor who didn't really understand, gave them 15 milligrams of methylfolate, L-methylfolate, and they crashed. And again, it's a great thing eventually, but you have to do it in relation to their ability to keep up with that. It's like, I always think of it as taking an old 1950s Model T or pickup truck and racing it 100 miles an hour around a NASCAR racetrack. It's going to shake and rattle and roll, and pieces are going to fall off. And that's such a good analogy, because you're pushing something that is not capable of going that speed. So that's important. So that's MTHFR. Another one more common is COMT. This one is related to breakdown of estrogens and norepinephrine and epinephrine and some of the adrenaline hormones. The reason this is important is if you have 2 copies, we call them COMT positives. I'm one of those. You might be too. And we tend to be driven and, and do lots of things and have lots of energy. But the downside here is, if this is impaired, you're going to produce a lot of taurine and cysteine, and you're going to produce a lot of sulfur metabolites that can cause pain and inflammation. One of the little tricks here is molybdenum can really help that detox pathway. And the other trick is if you give something like quercetin, which we love, it's a flavonoid that's anti-inflammatory, antihistamine. It could actually inhibit this pathway in the COMT positive. So you have to be careful of who you're giving it to. The big thing about this is it breaks down estrogens. So for men or women who are in mold, they already have aromatase upregulated, which makes excess estrogens. So women will have endometriosis, fibrocystic breast, painful heavy periods, all these symptoms of estrogen dominance. And men may have, a man boobs, weight gain around the middle, lack of sex drive, decreased muscle mass. And this is common in mold, where that upregulation takes all the testosterone from men and women and makes it into estrogen. And that's doubly magnified in a problem when we have a COMT issue. So these are things to be aware of. The other real big ones are GSTMP1s and 2s, and those are all in the relation to glutathione production. I think it's GSTP1 that's on the mucosal surface of the lungs. I have this one, so it's particularly problematic for people who breathe in and inhale mold, because, for example, when I was in the worst of my mold, I looked like a smoker with a COPD kind of picture, because those interstitial places in my lungs were inflamed, and there wasn't enough glutathione naturally because of the gene mutation to actually fix and repair. Now, I think they're back to almost normal, but it took 4 or 5 years, and I probably still have a low level of lung inflammation that would look like, I've never smoked in my life, not even one cigarette, but my lungs would look to a doctor like someone who had been a smoker because of that lack of glutathione on the lung surface and then the exposure to mold. So those are just a few of the genes, but some of my favorites. Is there any other ones you want to talk about?
Well, thank you, Dr. Jill. I find that piece just so important is how we can look at the patient truly holistically and where their triggers might be. So on a similar page to that, tell me about other infections that you find. You know, we spoke about crossover of genes. How about crossover of other infections?
I love, and I knew you and I would think so much alike. This would just flow so easily because
Yeah.
I always talk about functional medicine as I've been doing it almost 20 years. So I'm like, I've been doing this a long time like you. And one thing I always think about is if I simplify functional medicine down to the patients that I see, what is the thing all across the board for nearly everyone that comes in my office? And it's always toxic load and infectious burden at the core. And I say always, there's probably a few caveats of maybe a weird genetic issue that's not related, but most of the time, 99% of the time, this is the case. And the reason that's important to understand is we're always framing things in that toxic load. So mold is part of that. Heavy metals are part of that. Phthalates, parabens, organophosphates. I could go on, arsenic, cadmium. I could go on and on about the toxic load. And that's continuing to increase in our world, unfortunately, just like exponentially. And it used to be when I started practice with functional medicine, someone would come in with a thyroid disorder. We'd fix them 3 months later. They were fine. They didn't come back because they were great. Now the complexity and the chronicity of our patients is much greater. And I believe that's related to our increasing environmental toxic load and stress levels. So toxic load's that one thing. And then your question was, what about infectious burden? And these go hand in hand because what happens is you might have gotten, like me, I grew up in Illinois farmland and we went hiking in timbers and got tons of tick bites. So you might have gotten bit by a tick as a child. And those infections, Borrelia, Babesia, Bartonella, et cetera, are lying dormant because a good immune system is your best defense. Not everyone who has Lyme needs treatment. And there's tens of thousands of people walking around that if we test them all, they would come back positive for Western blot for Lyme, but they're fine. So then what makes a difference of those who need treatment? And what happens is, especially in a moldy environment, most of these molds have a very powerful immunosuppressive effect. They're some of the worst toxins in the universe. Trichosathines, which are from Stachybotrys and Cotomium. These are used as chemical warfare agents. They're being studied for their effects on toxic to the kidneys, toxic to the brain, very, very toxic to the immune system. Another metabolite called mycophenolic acid is used to create immunosuppressive drugs. Same with gliotoxin. So we know these toxins, this is in the literature, this is nothing new. And when we get exposed to them, I think of it as a limbo bar. The limbo bar drops, and all of a sudden, old viruses, which we can talk briefly about, old tick-borne infections, they will start to pop up and manifest symptomatically. So your question here is like, which came first? What do we do? I like to frame it in the inflammation, the mast cell activation, the stuff that creates this really, really difficult to treat scenario needs to be calmed down a little bit first and addressed. And then next, you have to get them out of the mold or the toxic exposure because those infections are important. But if you start firing guns at the infections because of the dead and dying debris that it's created, it's like shrapnel, you're actually creating a greater toxic load and they're already overloaded. Their bucket is spilling over the top. It's full. So I think you have to kind of go in that order. But most of these patients have underlying infections as well.
Yeah, Dr. Jill, we treat the exact same way. I just love talking with you. Same language. Exactly. So tell me about what you use to calm down the immune system first. You're talking about that. Oftentimes I'll use peptides. I'll use before frag, BPC 157. I'll also detox and put them on a big mast cell activation protocol before I'll even start to treat the infection, before I'll even start to detox. So calm the immune system down first. Then I'm going to start to pre-tox them, give them some support to detox. Then bring the toxin load down before I even start to kill the infection. And as I'm killing the infection, I'm using the peptides to modulate the immune system. And I have a feeling you're doing the exact same thing. I'd love to hear about how you do this.
I love that. And you're so right. I remember an interview we did a while back, and I just loved how you were talking and really on the cutting edge, because most people know about MCAS, but they're not using peptides. And as we were talking, you're just like me using all the tools in our toolbox because we need them, right?
Right.
Like we sow
Right.
them. So I completely agree. And usually what I'm doing is assessing, where they're at. And it's funny because I love supplements and nutrition and that, but I'll often give them things like drink mineral water. It's so simple, but it alkalinizes the body, or even alkaline water if they have a filter or can buy it. And that tends to be better between meals. Doing Epsom salt baths routinely, doing something like dry brushing so that they're getting lymphatic stimulated, or lymphatic drainage remedies. I'm a huge fan of infrared sauna, of course. So some of these things are just like lifestyle principles that they're setting up the foundation so that they can excrete. And I always talk about with toxins, you need to mobilize the toxins and then excrete them. And I find it easy to mobilize. We can give glutathione, we can do binders, we can do mobilize easy. Excretion, there's a limiting factor of our patients, and whatever the limiting factor is, like their kidneys or their lungs or their skin or their bowels, you cannot push it faster than their excretion. So it's very common to see practitioners maybe don't know any better and are pushing the mobilization of toxins really heavy, just like I mentioned with the MTHFR. If you push too fast, you can mobilize these things and they have nowhere to go. And that patient gets very sick. They can really crash. So I always am thinking about those two things. So as we're talking, we're saying, how can we get excretion ramped up? And I love your word. This is from you. I've been now using this and I give you credit. It's the pre-tox. I love the pre-tox because that's exactly what we do, is that pre-tox, and how do we get that mobilization? Now, even sauna for a lot of people can be too much. So I might start at 100 degrees for 5 minutes, like really tiny little bits. And if they're not sweating, that's an autonomic dysfunction. It's autonomic issues that have to be addressed as well. So like you said, supporting peptides are so powerful. I love that we have that tool right now. Hopefully we'll continue to have that accessible. And then the mast cell stabilization, some of my favorite things, and I'd love to hear if you have any others. Quercetin standard, except for maybe those COMT people. Chinese skullcap, I really, really like. Perilla seed is a good one. Bromelain, nettles, and sometimes I'll use things as simple as teas. Even hydration, water is the number one antihistamine. And it's so simple. So if people are dehydrated because they have that antidiuretic dysfunction, just hydrating them is a big piece of the puzzle. And that can be tricky if they're drinking and peeing, which is common with mold-related illness. Any comments on that, or mast cell? Because I think that's actually a really important piece of the puzzle.
I think that's a huge piece. So most of the time our patients, their mast cells are on a hair trigger. So anything is just going to trigger that off. They're going to release histamine and 500 other chemicals actually that the mast cells release. So I find that ketotifen has been really, really helpful. Most of our patients, they have insomnia as well. So the ketotifen is going to help put them to sleep. And that's the one I've noticed gives the biggest calming down. Of course, I'll also give them Allegra and Singulair, Cromolyn, but from the compounding pharmacy, because oftentimes our patients are going to react to the fillers and the colors from just the over-the-counter medications. And so when those medications are pure, I've seen them really, really work wonders, change people's lives. Yeah.
And it's not uncommon, if you're listening to this, to need 2, 3, 4, 5 layered. The layered approach is really important. You think, okay, maybe one thing, and these patients, they often need a multi-layered, and those drugs are absolutely H1, H2 blockers, mast cell stabilizers. I find I need often all of them plus herbs. And
yes, exactly. I tried to get a hold of Rapatidine, but it's available in America. You let me know if you ever find it. But yeah, and I'm also finding thymosin beta 4 or TB4 frag is helping to calm down that immune response as well, especially when given with the BPC 157. And the great thing I've noticed, and that I've also read in the literature, is that the combination of TB4 frag and BPC 157 also helps with brain inflammation. So I'd love for you to talk a little bit about that, because as we know, the inflammatory cytokines that come about due to mycotoxin illness, they can cross the blood-brain barrier, and our patients have a lot of brain fog and brain inflammation. So we just have to
I'm going to pull up. I just sent this to you. I have a monograph on TB4 and thymosin beta 4. And because it's right here, if you give me 1 second, it was so relevant because I know all these things, but I read them and I was like, wow, that's such a great summary. I'm going to read real quick for your listeners because I think it's so relevant, and it'll remind us both what all it does. So differentiation of endothelial cells, which is your blood vessels, so healing their growth of new blood vessels, improves collagen deposition, so skin and hair and nails and everything, decreases scar tissue formation. Quick little story here. I had what they thought was a melanoma on my back last year. It turned out not to be. It was benign, but I had a very deep Mohs procedure, right, to remove that, which is like just a surgical procedure that takes out a lot of tissue. And they said, keep the stitches on for 14 days, then come back, and you might still need them longer because it was deep and on my back. 5 days with TB4, and that scar was beautiful.
Great.
I put the stitches out myself because it was 14 days was my follow-up. So I saw the benefits after surgery for that. Faster healing of wounds, which is what I just said, repair of tendons and ligaments, improved flexibility of joints, prevents formation of adhesions and fibers, bands and muscles, tendons, ligaments, decreases inflammation, increases muscle growth, increases endurance and strength, relax muscle spasm and improve muscle tone, healing of ulcers and lesions. Here's the fun ones: promotes hair growth, protects and restores neurons after brain injury, and the last one protects the neurons from autoimmune inflammation. So this is a pretty powerful thing.
It sure is. And so, speaking of brain injury, a lot of our patients have had concussions or traumatic brain injuries, and a lot of them also have cranial cervical instability. So then you put those two together on top of mast cell activation syndrome, and things go haywire. The mast cells, they start to tenderize the brain stem. And so, Dr. Jill, I'd love to hear about your experiences with that, with cranial cervical instability, mast cell activation syndrome, that combination.
Oh, I'm so excited.
Yes, POTS.
Yes, all of it together. Just this morning, I was listening to a colleague of mine do a lecture. He's a neurosurgeon, but he does functional medicine in this. And he was talking about, there's a paper, if you guys want to look it up, it's free online, environmental subconcussive injury, axonal injury, and chronic traumatic encephalopathy. So what that means in layman's term is, bottom line on this revolutionary article, if you have toxin like metals or something that's affecting your brain, or mold, and you get a concussion, the effects are worse. And what the neurosurgeon, he works for the Denver Broncos, he treats a lot of athletes professionally. And what he was saying is he really believes the majority of these people who have the long-term concussive symptoms have previously, prior to the concussion, had a mold or toxin exposure that predisposed them. And a concussion by itself with no toxin or inflammation or autoimmunity may not actually create the post-concussive syndrome. That to me is, like, you and I understand this, but to me it's revolutionary in this world. A conventional neurosurgeon talking about the fact that what he sees is the worst post-concussive outcomes are those with underlying autoimmunity or toxicity. And again, it makes perfect sense, right?
This is revolutionary to hear a surgeon talk about this, because it is what we see every day in our practice, every day. And it's been my hypothesis, it's been the hypothesis of our clinic and of you, I'm sure. And so thank you, Dr.
I'll send you the article.
Yeah, I want to read that, because that's just even more proof to our patients, right? For what we tell them is going on here. Yeah. And boy, we don't have too much time left, but if you could tell me a little bit about how you go about treatment. I'd love to hear about your steps in treatment, because I know it's a multifactorial and timing is critical with respect to treatment. So tell me about how you treat mycotoxins first and other environmental toxins as you might do that at the same time as mycotoxins. And then when do you bring tick-borne illness treatment?
Yes. I love this. It's so fun to talk to you. It really is. So I'm going to do kind of the very basics, because honestly, the very basics do work. I mean, we know a lot of the things, whether if there's little tricks or triggers or MCAS to do, but sometimes the basics, and people who maybe don't have access to a doctor, some of these things, ideally you want a functional medicine doctor helping you, but not everybody has access. Number one thing that I cannot say enough is you have to get out of the exposure. This is the hardest thing. And I remember when I first started and I realized someone was in a moldy home, and I didn't always have the courage to say, you need to leave or you need to remediate. And I will say, I like it if they can remediate, but most of the time it doesn't work, because what happens is it causes, unless you have the perfect sterile situation, even in that case, there tends to be fragmentation of these dead mold species that actually just go all over the house, and the micron size of these things can go right into the lungs, into the alveoli, and be directly absorbed into the bloodstream. So what I see most of the time, unfortunately, is after remediation, patients get worse and they get stuck. I wish that weren't the case. It just is a fact that I see. So,
Jill, thank you for saying this, because I say the same things to my patients, and it's a difficult thing to tell a patient. I think the best thing for you to do is to move, clean up the house as best as you can, move, get rid of your furniture, buy new clothing. I mean, what a difficult thing to tell patients, but to hear you say that you have to say the same thing to your patients, I'm hoping that the patients listening here today, that they understand that this is a real thing, and we don't like to have to tell you this.
It's horrible. I remember like
Horrible.
years, I would just, and I'd be afraid. And now I'm more bold because I know that their health is more
Yeah,
important than any house.
exactly.
Right.
Exactly.
But it took a lot more. And then just experience now, I know that I'm right on. I know that I'm not telling them something that's like questionable. I'm always certain if I tell them that, but,
Exactly.
and I wish it weren't the case. It's because, and that's why I'm spending 5 minutes here, is because getting out of the exposure, there's no amount of binders, no amount of MCAS treatments, there's no peptide, none of those will touch your illness if you're still in exposure. You'll just continue to go merry-go-rounding.
And it's a waste of time and money on treatment, and with us trying to treat you if you keep getting exposed.
Yes, yes.
So,
and then on the other hand, part of the mold induces brain dysfunction, depression, anxiety, mood disorders, OCD. So this can be, it's a very traumatic thing. And I'm going to stop right here and say part of the treatment is treating the trauma. You must treat the limbic system and treat the trauma. Yeah. There's programs, there's binaural beats, there's somatic therapies, there's all kinds of things that you can do, but that's part of getting well too, because whether you are super emotionally healthy and have done all the work, you will not get well if you don't tag that limbic system trauma, because what happens is when you get the mold physiologically exposure again, maybe you go to a hotel or something, your body feels threatened again. And even if, again, you're psychologically healthy, you've done the work, you're not depressed, you're not anxious, you're still going to feel this limbic activation, and you've got to detag that or desensitize your body to that trigger. So that's part of the healing. So get out of exposure, limbic system training and retraining and fixing that part. And I just say that because what I don't ever want to do is make you more paranoid, make my patients more OCD about it. But there's like a real fine line, because you have to be somewhat careful as you're getting well. Now I'm 5-6 years out from my really bad mold exposure. I can go to moldy hotels. I can try, and I just feel poorly, take charcoal. I'm fine in an hour. Like, it's no big deal long term, but that took me a lot of work to get to that point. And I'm no longer like, it doesn't trigger me psychologically or limbic system wise. But again, I've done a lot of work around all those things.
It takes so much internal work. Our patients are warriors for their own health. I tell you that they're so inspirational.
They really are. So that's the foundation, and that's big stuff I didn't want to ignore, but the basics are detoxification, detoxification, detoxification. And the things that you want is you want to raise glutathione. Not everybody will tolerate glutathione. There's more SNPs that cause oxidation. So if you can't tolerate glutathione, which is your probably best bet, you can still make glutathione with NAC, with vitamin C, with glycine, with glutamine, with selenium, with lipoic acid. These are all nutrients that I include most of the time. And again, you have to tweak it a little, because not every patient will tolerate all of them. My first 2 years of mold, I could not take glutathione, so I got well without glutathione. I just got precursors.
Yeah, exactly.
So it worked.
Patients, they're going to crash with glutathione, but if I give them those precursors, cofactors of methylation, they can just start to tap on their own methylation system, and then we can bring them into actual proper full-on detoxification treatment. Dr. Jill, tell me about order of treatment with respect to infections. Usually I'm going to treat mold first, and then tick-borne illness, and then viruses. Before that, even parasites often. So there's a template, but sometimes the template isn't the right thing. Each patient is different. I'd love to hear about your order of treatment after detoxification.
Yes, so totally agree.
And
and the one thing I didn't mention, binders are really critical. There's so many out there, and everything from zeolite, which is great for metals, to clay, to charcoal. Those tend to be really good with trichosathines, to the prescription cholestyramine or Welchol, and everything in between. And there's a lot of options nowadays. And then there's some new humic fulvic acid types of things that are very gentle. So I often combine, because each of these has different charges. And so they will, the more you can combine and patient tolerates it, the more you can get different affinities for different toxins and really clean out the system. So the glutathione, the binders are core. And then order of operations, you have to calm the system enough to treat. So you have to support that excretion stuff, lymphatic drainage, sweating. And then I always try to calm the MCAS down. And then I try to treat the mold first before I treat infections.
Yeah.
Always that direction. And I would agree, probably parasites, fungal layer before Lyme. And then Lyme is usually towards the end. What I found is there's a percentage of people that don't need aggressive Lyme treatment once you get all this layer off.
Exactly. Yeah. And same with viruses. A lot of times they'll have a high viral load to begin with, but we don't need to treat that then because it corrects for itself after we've done that order. Well, Dr. Jill, thank you so much. It's always so much fun to talk with you.
I agree.
We treat so similarly. It's really exciting. Thank you for joining us. Always a
You're welcome.
pleasure.
So
Yeah.
fun to be here. And if you, I'll make sure and give you all those resources in case you want to share.
Thank you so much.
You're welcome.
Bye for now. Did you know it only takes a few seconds to change or potentially save someone's life?
Sharing the Mycotoxins and Chronic Illness Summit with friends and loved ones is giving them a key to health and happiness that they may never hear about otherwise.
All you have to do is click the share button below to help spread the word.
So please do. It'll really help someone.
Thank you.
Thank you.
Welcome to another edition of Mycotoxins and Chronic Illness. And chronic illness has always been my focus. And today, it's my pleasure to interview and discuss long COVID with Dr. Mobeen Sayed. My pronunciations, I apologize.
Either way is fine.
And he is CEO of drbean.com, a wonderful resource for medical information, and also host of his podcast, which I think has been a wonderful source of information on what's real and what's the real science in COVID. And I said, I've listened many sources, and I keep coming back to Dr. Sayed as the man to listen to. So with that, I want to welcome you. And today we're going to talk about long COVID. And where would you like to start?
So thank you very much, Eric, for having me. It's an honor to be here with you and discussing the chronic diseases. I am a baby in the field of chronic diseases. You are a master here. So thank you very much for giving me credit as well. But really, I am a beginner. For COVID, it actually become I think we all became accidentally pushed into having to learn about it. There was no other way for it. So for COVID, as I have been for the last 2 years presenting various studies, researches, I have collected a number of studies, and based on those, a number of possibilities for chronic COVID or long COVID, both after the infection and after the vaccine. And then what are the managements and what have been the successful managements? So I think that is the topic that you have asked, and that is what we'll discuss today. So once again, thank you for having me.
Thank you. And again, thank you for being here and organizing the information. I think that's the most important thing. People don't realize how much work you put into organizing the information for us. So thank you.
Thank you very much. So shall we start?
Yes, let us get going.
Excellent. So the way we will discuss today, and please, Eric, discuss with me during this time as well, add in your comments too. The way we will discuss is, number one, I would like to show some references to various pathologies that we have seen so far. Data is still evolving, information is still coming in, we'll know more, and the management will become more refined and more specific. At this time, it is, I believe, refined enough, but not fully there. Secondly, I would like to show a reference to FLCCC site where the iRecover protocol is present that I have led, and many other doctors, Dr. Paul Merrick, Dr. Pierre Corey, Dr. Tina Pierce, Dr. Bruce Patterson, Dr. Yo, they have all kind of worked together to pull this protocol together, which has been working fairly well. The disclaimer I want to make sure, I have no financial or other interests involved with any of the parties I would discuss here. I'm going to discuss InCell, I would discuss the cell trends, I would discuss FLCCC. I have no interest at all, other than they are good people who are doing good work, and I use their work to share that information with others. No financial interest, no strings attached. So that is the structure. So I'm going to share my screen very quickly and start from the references. So here, if you see, this is the FLCCC's site. So you can write flccc.net, and that would redirect you to covid19criticalcare.com, or you can directly write critical care. In here, if you go to protocols, and then if you go to iRecover management for long haul COVID-19, you would see that this protocol is led by me. So the approach outlined below is a consensus protocol based on a collaboration led by Mobeen Sayed and al. So whenever you are looking for managing long COVID, the audience here, I'm expecting them to be medical professionals, medical students, nursing students. This area, for example, we are updating it right now, and maybe in another week, this would be further updated with the first line. I'm going to discuss some part of that today, and then you can follow that here as well. Now, for some of the studies that have shown the pathogenesis, which we will discuss some of that today, and then see what could be the clinical signs and symptoms, and then how to manage them. So the baseline studies are the following. Number one, this is a study or a paper, development of phase 2 antibodies after SARS-CoV-2 infection. So there is a professor here, Professor William. He has done this paper as well. There is another study that I'm presenting here. There was a network hypothesis by an immunologist last century, where they had said that when we encounter a pathogen, we make, of course, antibodies against that pathogen. Then what happens is that once the antibodies are produced that are now attacking the pathogen, for example, if you use Omicron or SARS-CoV-2 as an example, as it arrives in our body, we make antibodies against the spike protein and other parts of it. Then what happens is we need these spike protein, these antibodies themselves to be cleared out. And to clear them out, one of the homeostatic normal mechanism, normal response of our body is to make antibodies against these antibodies to clear them out. This is a homeostatic function. This is a normal function. Right. However, in some percentage of people, those antibodies, or also called anti-idiotype antibodies, they do not go away after being produced. And now they would continue to attack our own body because the original antigen now looks like, these antibodies look like the original antigen. So I'll discuss this a little more later on.
Yes.
The result of that is we would end up with autoantibodies to ACE2 as a result of either vaccination or the infection. And so this is that network theory that I discussed, or I showed you. Then continuing with our references, there is a lot of work done by Dr. Bruce Patterson and Dr. Yo, and that work is about the monocytes, and monocytes carrying pieces of spike protein, especially S1, in them for long period of time. This is the paper, this is the fresh paper here, 10 January 2022, persistence of SARS-CoV-2 S1 protein in CD16 plus monocyte in post-acute sequelae of COVID-19, up to 15 months post-infection. And so that is a very, very important paper, and they have answered a lot of questions, but I wanted to talk about one important statement here, and that is that their observation is that up to 30% of the people infected could become long COVID. That's a very high number. That is a pandemic in itself.
Yes.
So not only this is a disaster, but this also puts a lot of burden and responsibility on doctors who are managing chronic diseases to be aware of what is happening and how the pathologies are evolving, and then how to manage. Because these patients are now part of our daily life, and they're suffering, and the misery just continues. So this is a great paper to look at. Then there is this paper. This is the long-term changes to blood cells triggered by COVID-19 infection. So in this study, the researchers found that it is possible that the blood cells, RBCs, WBCs, these cells can lose their morphological structure, become a little rigid. And most importantly, when RBCs do that, then you know that RBC would get stuck in various blood vessels and the clotting would occur and blood flow disruptions will occur. So that is also an important thing to keep in mind. I also wanted to say from this one monocyte, the outcome of this, if I could summarize it so you have the seed planted in your mind, that is monocyte carrying S1 and then patrolling the boundaries of the blood vessels will mean that there will be vascular inflammation. And when that vascular inflammation is towards the head and neck region, then there can be a lot of neurological disruptions. So now imagine inside the blood vessels, we are getting issues with the clotting and the blood cell shape changes. And outside of the blood vessel, there are monocytes that are dysregulated. And now blood vessel is attacked from both sides and it is inflamed and the blood flow is disrupted and clotting is occurring. That is what is a possible mechanism that is happening in long COVID. Then finally, anosmia. So this is a study about anosmia. Anosmia has been a very common outcome as well during the long COVID. Interestingly, some people's anosmia recovers by itself. Some people, when we give them therapies, the anosmia recovers within a few days to weeks. And for some folks, the paresthesia or hyposmia continues for months.
Yes.
So these are the basic studies that I wanted to first put in front of our audience. So far, so good, Eric?
Yes, I said each one of them, it makes me want to dive deep. But I'm going to let you keep going before I take us off the path, because I want to get through these. These are just wonderful. Okay.
Absolutely. So I think what we can do is this. Today we'll talk about management, so that a more practical value is in front of the doctors and they can use it. And then we can do a separate series where we can go individually for each one of these studies and discuss them in depth.
Yeah, because they just to come again, they tie in, they give us a window and more insight into what we see in chronic diseases of all types. I mean, that's the beauty of this work. It doesn't stand alone. It's tying together information and data that we've been looking at and just giving us ways of putting it into more practical, so we can really begin to use this to help patients. So just
absolutely,
we'll go with what we can do today.
Absolutely. So I'm going to go back, and now I have a presentation as well. I am very drawing oriented too. So every so often I'll go to my drawing board and draw some of the concepts too. So be ready for some drawings. So
I enjoy them.
Thank you. So first of all, medical disclaimer. These are not advices. We are talking peers, we're talking doctors, and sharing information, sharing other people's researches and observations of doctors with the medicine. Of course, if this is a patient who's listening, please talk with your doctor. If there is a doctor who's listening, please make sure that, as you do all the time, case by case, the management may differ. So let's start with the possible causes for the long COVID. There is a theory in immunology of virus hit and run, where the virus arrives, does some disease, causes some pathology, and in that process ends up triggering the immune system, dysregulating it, and then the virus is wiped out. But the immune system behind is still dysregulated. It is still wobbly. It is still incorrectly functioning. And that continues to go on, and that becomes the basis for a chronic disease. So that hit and run is possible. I think it is very much possible with COVID. That's one. The second pathology, and I have given the references before, the S1 protein pieces sitting in the monocyte. And again, you may have a lot of questions that why are they sitting in there? How long would they continue to sit in there? Will they ever get eradicated? Would they ever be cleared? What is the outcome of the S1 sitting in the monocyte? All of those questions are in the paper and the answers to them.
And just to specify for people, this is a piece of the spike protein. We've been talking this.
Correct. Absolutely. And so if you would like, give me 1 second. So I hope you can see my drawing board now. So on the virus, so let's say this is SARS-CoV-2. On the virus, the spike protein is divided for its functional pieces. It has a receptor binding domain, or RBD. This is where it binds to ACE2. So that is one. So this blue part is the ACE2. This is the remaining cell. The red part is receptor binding domain. Then for the remaining part of the spike protein, there is an S1 unit and there is an S2 unit. And for completion's sake, what happens is when the virus comes and docks with the ACE2, this is ACE2, the blue one.
Right.
When the virus docks with the ACE2, then the TMPRSS2, that is a surface protein on our cells, it cleaves a part of the S1 from S2, which causes this whole S1 and S2 to become separated. Now, S1 stays stuck to the ACE2, and it is actually recycled or downregulated and brought into the cell for digestion. However, the S2, and please don't mind, my cat is here with me and it is going to start meowing. It just woke up. The S2 portion that is then made naked because S1 is removed. This S2 portion acts as a fusion protein and it connects with the cell membrane, and then it allows the virus to fuse and send the RNA in. This is the normal function. We are talking about this part, the S1 part, sitting in the monocyte. So let's say this is a monocyte. This S1 part is somehow hanging out in monocyte for months and months in some people. And that causes this monocyte to become dysregulated because it has an antigen in it, and it would present that, and the other cell would trigger it, and the monocyte itself would continue to be triggered and make cytokines, which causes it to cause continuous inflammation. Now the monocytes are, again, they are in 3 states. I'm so sorry I'm going on with all in this depth. You can stop whenever you like.
Well, no, this is fine. Just one thing that's always interested me about this story is that the monocyte normally has a very short lifespan, I would imagine.
Correct.
And so there's something about this, once it's in there, that kind of immortalizes it a bit.
Correct. So they discuss that in this paper as well. There are a couple of possibilities. So let me complete my blood vessel part, and then I'm going to address that question. That's actually a beautiful question, and it is asked very often. And that was my curiosity as well. And we still only have conjectures about it. So let's say this is a blood vessel, and outside is a monocyte. Monocytes usually patrol the boundaries of our interfaces, our tissue interfaces. Blood vessels are interfaces. There are other interfaces as well in our tissues. So monocytes are patrolling there, and when needed, they can convert into macrophages. They can convert from classical to non-classical and intermediate. However, if they are irritated by this antigen present in them, then they continue to create inflammatory state around the blood vessels, which causes the blood vessels to become inflamed. And we see a lot of pathology related to that.
Yeah.
So having said that, the question, monocytes are supposed to be either short-lived or convert into macrophages and be long-lived. How do they start surviving? So in this paper, Bruce Patterson and your doctors, they discuss that it is possible that the continuous irritation of the monocyte makes it not become cleared out, or it is possible that the one monocyte is eaten up by another, as part of the regular homeostatic mechanism, where a senescent cell is removed by phagocytosis from another cell. And when it is eaten up by another cell, then the spike protein just transfers to the next one. So it is now going from cell to cell and sticking in there and keeping the dysregulation continuing. There may be more mechanisms, but these are some that they have done. Now, if I go back here to the discussion, so S1 protein sticking out in the monocyte and continuing around the blood vessels and inflammatory state is a very important possibility for long COVID. Then, as I showed you the reference before, there is a possibility of the blood cell morphology change, where especially the RBC shape change can cause issues, as we can all suspect.
Is that from changes in the membrane lipids, or
so it is, they say that there is a change in the membrane lipids, which makes a cell a little more rigid. There may be microtubular changes as well, but more importantly, they have observed the shape changes. Exact pathology is still not clear.
Right. Yeah. Well, and again, I someday we'll talk about this, and I think I can relate this to mitochondrial, but RBCs don't have mitochondria in them, right? So they don't count.
So there is something going on with the RBCs and the other blood cells as well. And the end result is they become a little more rigid and their shapes become dysmorphic. And so they're not easy to walk around in our blood vessels or fly around in the blood vessels, and they get stuck and they cause issues. And that would then start the propensity towards clotting as well. Then the autoantibodies to ACE2. This is the mechanism that I was discussing before. I'm going to quickly draw this to see if I can make sense of, or I'm able to present it. So let's say here is a spike protein. And this spike protein, again, now you know the pieces of it, RBD, this is RBD, receptor binding domain, this is S1, this is S2. Now, we know that we can make spike antibodies against the RBD. So let's say we make an antibody that binds here to the RBD. This is the antibody's binding site. So this is the other binding site. We know that there is a light chain and that there is a heavy chain. I'm just simplifying my illustration. These are not normal illustrations that we see. So here is the binding domain. And this is the function of this antibody. So this antibody is going to now bind with RBD and try to clear the virus and coat the virus and do all the biological functions that we are aware of. Now imagine our body decides to make another antibody. I'm going to make it green, which is against this antibody. And so that antibody learns to bind with this antibody. Right? So this is the binding domain of this antibody. This was the binding domain or the binding region of the other antibody. So you can now see, look at the red antibody first. The red antibody is connecting with the RBD. So if there is anything that is going to connect with our red antibody, then that thing has to look like RBD. Otherwise, the binding will not occur. So when our body, in all its wisdom to try, it's a homeostatic normal mechanism, it is called network hypothesis. When our body makes anti-idiotypical antibodies, so this green antibody is called anti-idiotypical antibody because it is against another antibody.
Right.
And it is against the idiotypical part of the other antibody. But here is a delicate point here. This antibody, the green one, when that is formed, it will have an appearance of the spike protein's RBD, only then it can bind with the red one. And now because this green one has the appearance of the RBD, this green antibody can start binding with the ACE2 receptors.
Mm-hmm.
Because it looks like this antibody's binding region looks like the spike protein's binding region. So when it starts binding to the ACE2 receptor, that is where the dysregulation starts coming in.
Right.
Now, in theory, so the paper that I showed you, they saw that the antibodies, autoantibodies in hospitalized patients, 93% of them had them. In the
Right.
outpatient, about 40% had them. And they saw that most of them got cleared out within a couple of months, but in some people, these just persisted and stayed on. Now,
Right.
will they eventually get cleared out? I think so. But at least by the time they were doing the research, they found that in some people, they were still there.
Yeah.
Now, those autoantibodies are going to stimulate ACE2, and they're going to bind with ACE2 and do the similar dysregulation as spike does.
Right. And, so we start having problems with, all the functions of ACE2, but you would think that this would go away when the danger signal, if we could get the danger signals to go away, usually the autoantibodies should dissipate.
That is correct. So this is a homeostatic mechanism.
Right.
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 Ideally, so pathogen comes in, antibodies to the pathogen are made, then autoantibodies to the antibodies are made, then all of the system, pathogen goes first, then the antibodies to the pathogen go, then the autoantibodies go. That is a sequence, but in some people, this sequence fails and the autoantibodies just hang out there.
Right.
And that they cause dysregulation. And in case of, so you could ask this question that why in case of COVID, it ends up with the long COVID with all variety of symptoms and all those issues. And the reason is that the binding region for the autoantibody is very important. It is binding to ACE2. ACE2 has a hugely important function in our body to manage inflammation. So as soon as we disrupt ACE2s, we put body in a chronic inflammatory state. And that is the underlying problems with the chronic diseases. There is a chronic inflammatory state, either triggered by the virus or bacteria or whatever, or by our immune system just doing it by itself. So here we have an autoantibody continuously disrupting ACE2s, disrupting the inflammatory system's balancing system, and causing an increased inflammation in the body, tendency of the inflammation. Okay, continuing. Then you would see in many COVID patients, there is tinnitus. Actually, I have COVID right now, and I have some tinnitus which comes and goes. Some patients, it's really horrible for them.
Yeah.
So tinnitus can develop. Then there could be a balance problem that can develop, or hearing loss that can develop. And the reason for that is vestibulocochlear dysfunction, in which one thought so far is that because the blood vessels to this area are very delicate and small, these are capillaries, they can become easily clogged by the other mechanisms that I discussed. And that can cause, and 1 second, if I back up, we also know that COVID causes clotting tendency too. So if we put that all together, it is a possibility that vestibulocochlear system, especially hair cells, are not getting their oxygen correctly and nutrition correctly, and the waste products are not cleared out correctly, and that causes the disruption in their function, and tinnitus occurs. If that is happening to the hair cells in the semicircular canals, then the balance issues would occur. And if this damage is permanent, then the hearing loss would occur. This is a problem for long COVID as well. The signs of it starts within the COVID, but then they start persisting.
Yeah, and again, we see this in many chronic illnesses when the red blood cells start to stiffen a little bit, and you have a little bit more fibrinogen floating around. It doesn't take much to make that very difficult for that red blood cell to get across out of the blood vessel.
Absolutely. And then one of the outcome, it would create outcomes in all parts of our body, but there are some outcomes which become very, very prominent for us, and we start noticing them.
And that's right. The more narrow the area, the harder it is. Yeah.
Right. And then before I go to the GIT and other, there is one bullet point that is missing here, and that is anosmia. Anosmia or hyponosmia or hyposmia are very common complaints as well, where the patient stops or has reduced smell, or they even have phantom smells. They say all of a sudden I smell coffee or I smell a bad smell, and that is because they've developed hyposmia. So I had shared a research there before in the early part of the discussion. The researchers had shown that the epithelium of the olfactory bulb, not the neurological pieces or the olfactory nerve, but the epithelium of the olfactory bulb and the supporting cells, they become infected, and the inflammation, local inflammation, presses on the olfactory neurons and dysfunctions them or causes dysfunction of them. Plus, because there is an inflammation of the epithelium, and if there is damage to the epithelium, that damages the whole system's function. So anosmia is also another important thing to keep an eye on. So if I'm going to now continue, long COVID is a set of symptoms, syndromes, which can be clustered in various parts. And in some patients, they can be combinations of them, all of them, some of them. Long COVID could be just neurological, GIT, respiratory, musculoskeletal, cardiovascular, autonomic, or a combination of them. I have seen mostly combinations of them. And the most disturbing for the patients are neurological, where there is brain fog, there is lack of concentration, lack of ability to process, cognitive decline, possibly anosmia, tinnitus, and so on. So there are a lot of neurological issues that patients find really bad, and they cannot perform their functions correctly. While the tragedy at this time is that they're not recognized very well. And so others think that they're just making it up, or this is just psychological, and that makes it even worse. Now, the disease's course is hills and valleys. Patient feels better, patient feels bad, they feels better, they feel worse, and so on. They just keeps going through that process. And one thing I forgot about neurological, Bell's palsy and its recurrence is also a very important part of neurological disruptions. Guillain-Barré is mostly acute, but Bell's can actually be fluctuating in post-COVID for a long time, and even with the vaccine for a long time. So hills and valleys, persistent low intensity, persistent high intensity, then temporary improvement with intervention, then permanent improvement. So this is very important, that sometimes as we discuss the protocols, you would see that patient has improvement and then they have a relapse. And that means you have to try a different avenue. There are multiple pathologies. And so there is, all of them give rise to inflammation. So when you control the inflammation, you would see a good response. But now what is the underlying pathology that needs to be addressed? So you may have to do some research, some exploration by trying various possibilities, management possibilities, to see which one works.
I just, this is a beautiful slide because, I think this is what you see when you try to treat, chronic Lyme disease or chronic fatigue. But this laid it out just so simply and just made it so obvious, because when you're dancing with the immune system, and it's like MS, just the way MS was considered a psychological disease till we got an MRI, until we could really see that these people had something wrong with them, or we could see the abnormal proteins in the CSF. But all these diseases have been delegated to the psychiatrist, and much to the chagrin of the patients. I mean, I think that's what causes even more of it increases the debilitation, is when you're just not respected by anybody.
Absolutely.
So,
I have a very young patient, and not my patient, but family members. She's a patient of long COVID. Young woman, very dynamic, very energetic, looking forward to her life. And all of a sudden, she got post-vaccine injury. And one big part of that was and is still persisting, but thankfully has almost 90% gone, was brain fog and concentration difficulties and ability to work and cognitive decline. And she would tell me that when she would say this, that hey, to her superiors, her workplace, that I'm having these difficulties, her peers would laugh. I mean, they're her age as well, so they'll just make fun of her and say, you're just making it up. And her management would not even consider. They would say, talk to the doctor, and doctor would say, this seems like a psychological issue.
Yeah.
So this is how bad it is.
Yes. Yes. So this
And I
is-
suspect that, so you are working with the chronic diseases. I suspect this is similar everywhere with the
Oh,
chronic.
this is everywhere. This is, it's gotten, actually has improved tremendously over the last 20 years. I mean, if you can imagine it being that's bad now, it was impossible in the past. It was just totally, patients were generally just ignored. They lost their families, their friends, because nobody would believe them. But what's really so important here is to understand that when symptoms wax and wane a lot, just remember it is your immune system is dancing with you. It's not a fixed, people have this concept of the body as a fixed thing, and our medical pictures are broken legs and bullet wounds and heart attacks that happen in the moment, and not the waxing and waning of your immune system, how it dances with the world. You have a good day, you have a bad day. You're in a good mood, you're in a bad mood. I mean, it's life. And anyway, it's just so important that people remember that when you're dealing with these diseases, you're just seeing a reflection of what it is to be human, that there's change every day.
Absolutely. Absolutely. So with this, management considerations. So of course, like any chronic disease, the considerations are, there are prophylaxis that should be done within the disease itself, so that the chances to become long COVID are less. And what I've seen is that ivermectin has been very useful. Treatment with steroids as soon as the viral phase is over is also very important to start controlling the immune system from going totally dysregulated. And then other prophylaxis, for example, vitamin D and other such substances should be in the correct amounts. That is important. So that is one consideration. This consideration is more than for the chronic disease doctors. This is mostly for acute disease managing physicians, because they have to take care of it, that patient doesn't become or has less chances of becoming long COVID. Then neurological component sometimes is not just very easily handled with the management. And so one has to look into various techniques, including lymph flow massages, which some people think it is crazy science, but this is actually important because it helps move the lymph a little faster. And that helps clear out some of the debris that is collecting a little faster and move things a little more.
Yes. When we talk to the profile, one of the difficulties is when people first get ill, they're often not very sick. And it's, and so it's very hard to say, well, try the ivermectin and the Luvox. I know you don't need it today, though I think the ivermectin I've seen turn people around overnight when they're moderately ill. Sometimes, doesn't work all the time, but it's worth trying. But it's people understanding that that you don't want to wait until you are in the second week and very sick to start doing things. Correct. Try the simple, safe things first, and be willing to, and know that you're not that sick. It does feel like a cold, but this is a cold that can get a lot that can get a lot worse fast.
Correct. Absolutely correct. So then in some patients, pulse therapies on monthly basis may be needed. So I've seen that for the management, sometimes continuous management helps, but in some patients, continuous management does not help, and you've got to give a break and then resume and then break and then resume. And that slowly helps them to come out of this situation. So sometimes pulse therapies are more important than continuous. And then disease usually goes in remission within a week or two. Then the patient goes and bounces around and does their thing and be happy, and then they come back with a relapse. And then it seems like a couple of months are needed for a continuous therapy. And what happens is, one of my friend doctors was saying that usually the benefit starts appearing in 6th, 7th week. But patient doesn't wait for 6-7 weeks. They just want it. Today I started my medicines. Today I should feel better. So there is a lot of close consultation with the patient to have them go through this journey.
Yes, patience.
Patience,
Yeah,
absolutely.
and just one other thing is what we see all the time in chronic illness is toxicity is what's keeping a lot of people stuck in chronic inflammation. And just as you're saying, the lymph flow, the TMJ, the chronic neck tension that is, we spend our lives sitting at desks with our arms up typing. That is the things that we don't usually attend to, because if you have a cold, it doesn't matter. But when you have chronic inflammation, detox is critical. And
Absolutely.
And attention to structure, through chiropractic, osteopathic, all these different ways of dealing with the structure will help. Again, it's not the magic bullet for most people, but it's an important component to getting these medicines to get people where they want to be with these therapies.
Absolutely. And now that you're saying it, I'm looking at my shoulders. I'm sitting like this because my chair armrest is elevated. So I'll try to be.
One of these days we have to talk about your ergonomics. Yes.
Yes, absolutely. So these are some considerations. And the second set of disabling, so the most disabling and disturbing things for the patient are neurological symptoms and then the cardiac symptoms. So focus on those and help them through those. So now let's look at general idea for how to management. The basic approach is, and this approach changes, but I want to put my thought out. And of course, folks who are in the chronic disease management, they know better than me. And that is that
I'm not so sure. You are too modest, but okay.
There is a propensity for inflammation that is causing damage. And what I've seen is that many patients, let's say that there is inflammation of the cranial nerve, and the swollen cranial nerve is now slowly getting damaged. If we don't control the inflammation, then it is possible that the damage becomes permanent, and then we can do whatever, it's not going to be reversed. So there is an immediate need to keep the tissue damage from happening or reduce that as much as possible while you figure out what is the basic pathology to address. So in the beginning, steroid therapy is important. I have seen many protocols which deviate from steroids and they want to use more specific chemokine blockers. That is interesting as well. What I've seen is that their side effects and their specificity has its own issues. Generally, low dose steroid for a couple of months is something to keep patient on while you're figuring out what else is wrong and to fix it. This reduces their damage while you're treating them. So now labs. There are a couple of companies whose labs have been very much used by the chronic long COVID or post-vaccine injury patients. One is the Celltrend. It is not in the US. It is a, I believe, European company, but they do these autoantibodies for ACE2 and many other parts. They have a beautiful profile of autoantibodies that they do.
Oh yeah, I'm not aware of that. Thank you. That this is very interesting. Yes.
Yeah. So you can go to, I believe, Denmark, celltrend.de/en, if I remember it correctly. Let's actually very quickly see it so that we can see. Yeah. And again, I have no financial. Celltrend.de/en. I don't know if it is Celltrends or Celltrend. So my apologies if I come up with some weird site here. Okay, so we are on the correct side.
Right. It looks right. Yes.
So they have a great profile of autoantibodies that they do, which are not available here. So you have to work through their site with them. Okay. But I am seeing so many patients. I have interviewed a patient, Sean. He has been working with them as well and got his profile.
Okay, no, that'd be very interesting because I'm very interested in future use of plasmapheresis for people who just aren't responding, and this would be a
Yes,
help. Okay.
correct. So that is one. The other one is the InCell DX. Once again, I have no financial interest of any sort.
Yes.
InCell DX have created their own set of tests, and with that, they create a long COVID index, and they say if the index is here, then you need management this way, and so on. So they have that as well. I think it is $360-$70. I do not know if the insurance covers it, but again, somebody who is in trouble might want to.
It's well worth it. I recommend that. I'm actually doing that on almost all my patients who I'm stuck on, whether they have long COVID or just chronic fatigue or chronic Lyme or whatever. I think it's useful. I've done lots of cytokine tests over the years, and stopped. I do it for a few months, and then I realize I'm not doing anything with the information, and I stop doing it. And then it looks exciting again because we love numbers. But I have to admit, the panel has been helpful. Yeah.
So once again, no.
No, we're not advertising. We know no kickbacks, no commissions.
So in addition to those, one can look for interleukin-6, interleukin-12, fecal COVID test for any remnants of the COVID wedge.
Yeah, I wasn't. That's another test I wasn't aware of.
Yeah. So if possible, so again, it is not available everywhere, but if possible, fecal testing for remnants, because there are studies which show that debris of the virus can continue to stick in the GIT cells for up to 59 days after the symptoms have subsided. And now there are diverse studies from there. Some studies says that the presence of those broken RNA pieces inside the cells help build the immune system strength against the future exposure by affinity maturation. And we all know that that is a process where the antigen is exposed to our through follicular dendritic cell to our B and T cells, and they become more and more mature in attacking this antigen in the future. And some studies say that this continuous presence of messenger pieces of RNA are actually disrupting the local immune system and causing local inflammation, which then creates a lot of GIT-related long COVID symptoms. So far, the studies have not shown viable virus, but they have shown inviable pieces of virus, which may be immune dysregulating. This also could be a problem with the microbiome as well, and that restoration would be useful as well.
As well, yeah.
So general approach to the COVID is basically two branches. One is to see if our immune system is dysregulated, and the other one is to see if the virus pieces are sitting somewhere. Or a third one will be a combination of both. And so whatever is the basic pathology, it's going to fall in these categories. Either the virus pieces are there, or the immune system is dysregulated, or both of these are present together. And then based on that, there are a few management approaches. For example, if immune system is dysregulated, then that dysregulation could be of multiple types and outcomes. For example, mast cell activation syndrome could be unmasked by this dysregulation. So a patient who actually has MCAS, mast cell activation syndrome, and is not aware of it, they all of a sudden might start having MCAS, and that is an unmasking of the MCAS. In some patients, there is even a triggering of the MCAS as well. And the patient of MCAS, who are already the MCAS patients, they may get flare-ups. So that is one possibility. Second possibility is, as I discussed before, that may not be here in this diagram, is the inflammatory state of the monocytes and the blood clotting issues, which are also because of the autoantibodies. And this is why I believe that this discourse of saying the spike protein goes around in the body causes an issue is not possible, because spike proteins are picked up by the immune system. It is the autoantibodies that are freely allowed to circulate in the body. And if they are idiotypical antibodies, anti-idiotype antibodies, then they would act like spike proteins, and they could behave as a moniker for spike protein, like spike protein. So if it is an MCAS-like signs and symptoms, then MCAS management should start, and the FLCCC protocol, I would show you there, the management approach is present. If it is not that, if you suspect it is not MCAS-like behavior, then steroid and ivermectin with low-dose naltrexone should become the first line. I have seen this to be repeatedly the gem of the prescription, the first line of prescription. And think about it, that steroids would keep the inflammation in control, the damage in control. Ivermectin, there is a study, I can probably look it up right now in front of you, and you might find me Googling it, but it's interesting. In vitro study, ivermectin binds with spike protein and ACE2. I believe this is the one. So ivermectin docks to the SARS-CoV-2 spike receptor binding domain attached to ACE2. This is an in vitro study. And here they have these beautiful diagrams. So if you see here, this is the ivermectin molecule. This is, I believe, ivermectin molecule docked with the SARS-CoV-2 spike receptor binding domain bound with ACE2. So here, this triangle is the viral spike protein. This arrow is the ivermectin, this little thing. And the remaining, this molecule is ACE2. So ivermectin disrupts the interaction of ACE2 and the spike protein, at least from this in vitro model. And if that is the case, imagine if we have autoantibodies and you give ivermectin, it is going to bind with that autoantibody in the same way and disrupt it, just like it disrupts the spike protein. This is
That's
such
beautiful.
a beauty.
Yeah, no, that is beautiful. I mean, that is, because you see, we see it work clinically, and it's so nice when you have a story that makes sense.
Correct. So, Eric, one of the requirements I have from myself is that when I present something, I present that based on some mechanism, some known science, so that we can think about it.
Yes.
And of course, there are doctors, there are researchers who can hypothesize and then go find the solutions for that. I am actually using someone's hypothesis and the solution and presenting them here. So steroid would keep inflammation under control. Ivermectin would help with, if the spike protein is hanging around, they would help with that. If the anti-idiotype antibody or network hypothesis mechanism is occurring, ivermectin would help with that. We also know that ivermectin helps with the nuclear factor K beta or kappa beta light chain beta disruption as well, and then helps with the inflammation. So that would be there as well. And then finally, I've written fluvoxamine here. Since then, we have changed it to naltrexone. So low dose naltrexone, not naltrexone, but low dose naltrexone has been working like magic. So what you do is you start with these three, and then 3-4 weeks later, you start tapering them. Take steroid out first, then take ivermectin, then leave low dose naltrexone for some time and remove that too.
Yeah.
Worst case,
we have people on low dose naltrexone for years and with excellent results. So.
Yeah, so this has really been great. It's whoever started this, the naltrexone's use, kudos to them, but that has really helped. Now, if there is a possibility of some virions or broken pieces still hanging out somewhere, then ivermectin once again will help, because it would keep binding with the spike proteins and keep disrupting the spike protein from interfering with the other immune systems. And then, of course, we've talked about vaccines as well. Eric, you and I talked about too. Vaccine, anyone who is at risk, although nowadays the efficacy of vaccine has become an issue with Omicron. Fortunately, Omicron itself is becoming milder too. but please speak with your doctor to figure out if vaccines are an important part. Now, management, I'm just going to recap. This is the first line. On the I recover, this would be updated soon. So I am kind of taking that part and presenting it here before it has become updated. In a few days, it will be. So the first line, prednisolone, and low dose, 10 to 15 milligram, and you continue for 2-3 weeks, and then you taper it by 2-3 days of 5 milligram reduction, then another 2-3 days of 5 milligram reduction. I usually try 1 week each. So starting with 15 for 2-3 weeks, then 1 week for 10, then 1 week for 5, and then stop. But if you have a tapering mechanism that you prefer and like, there is no hard science on the tapering. So you do what you feel comfortable. In addition to that, ivermectin, 0.2 milligram per kilogram body weight. So it's not the ivermectin need of a higher concentration, because we're really not attacking the virus itself. It's just the binding with those disrupting autoantibodies or with the spike protein, if that is present somewhere. And then low dose naltrexone, begin with 1 milligram, and then it can be escalated. Just be be in close contact with the patient to make sure that their side effects and their situation is managed. This is the first line. Now, before I go to the rest of this, what I'll do is this. So there is a lot more here. What I'll do is this. For the remaining part of the discussion, I would then go here to say, after that first line, it is possible to try fluvoxamine for neurological situations. And I have seen that in some people, fluvoxamine can actually increase the neurological issues. And if that is the case, we stop.
Yeah.
And we also know that fluvoxamine is not being given for psychological or psychiatric condition here. Instead, this is the sigma-1 antagonism that reduces inflammation in the brain. You can think of fluvoxamine as a partner to ivermectin. Ivermectin cannot cross blood-brain barrier, so that stays in the body, and fluvoxamine can go there and help with the inflammation.
Yeah, and I'm very interested in the dosing, because I like for the treatment of acute COVID, they've been talking about the 100 milligrams twice a day, which again, many people can't tolerate. And I've often start people at 50 milligrams, and I've thought even 25 is enough for some. And so it really looks like from the data there that the dosage for what we're trying to accomplish here can be much lower than that's what's used for treating depression.
Absolutely. Even a half of 25 milligram, even 12.5 milligram seems to be fine as well.
Yeah, that's clinic. I've gone that way because people just couldn't tolerate it. And I figured that it was just they picked the 100 milligrams twice a day dose just because that's what is approved.
Correct. You're correct.
Yeah.
So steroid therapy is here. Then if you wanted to see that macrophage activation syndrome and how do we manage that? So here it is: vitamin C, omega-3, atorvastatin, melatonin. And then if you wanted to see how to help with the MCAS, then that Dr. Tina Pierce has been very good in putting together this part of the protocol that is here as well. So my point is, after that first line therapy, for the remaining parts, you can actually see the management protocol here. You can refer it and you can help further.
Right. Yes, there's lots.
This will be updated in a few days with the first line showing up here, the first line that I just presented.
Right. Yes, I'm noticing I didn't see the Maraviroc. Did I miss?
Okay,
that?
so Maraviroc is something that, in my opinion, that is in the extreme cases.
Okay.
Number one. Number two, Maraviroc has a larger set of side effects, and so needs very good care from the physician. Number three, Maraviroc could be expensive as well.
Oh, yes, it is. It's
Right. So Maraviroc is an option Dr. Yo's group, Dr. Bruce Patterson's group, they swear by it that Maraviroc in all refractory long COVID, it works like magic for them.
Well,
I haven't used it. I haven't had a need to use this, but then I do not have a refractory long COVID person as well. Most of them recover with the remaining protocol. So Maraviroc is an option, but I don't have it here. And I think we'll keep it as a side note that in refractory.
refractory, no, it does, see, just because of my practice, when I'm on, part of their referral list, but because, the nature of my practice, people look at the website, they see we treat chronic disease. We tend to get the ones who are failing.
Correct.
And
Maraviroc works there.
well, even then it works, but not quite as miraculously as advertised. It does work, but it takes a long time. We haven't, that's another thing.
I think one balancing thing that should be done is that what I see sometimes in these protocol discussions to say no steroids, just Maraviroc. And I think that is not entirely the right approach. Steroid has a broader implications for the immune system. And because there is so much dysregulation, Maraviroc alone is a very specific part. So overall help with steroids is necessary.
Yeah, I think one of the things we run into is that again, when you start getting into the very sensitive patients, there are many of them who can't tolerate even tiny doses of steroids, even 1 milligram.
That happens, absolutely happens.
They just can't sleep. They get so agitated. So then we have to do other things. And I'm also noticing while we're talking here is that the atorvastatin, because Dr. Patterson's group is in love with pravastatin. And
we would be updating this as well. So pravastatin is fine as well. Atorvastatin is fine.
No, I use both. Some people feel atorvastatin because it gets into the brain might be more useful. It's just interesting. And just the dosing between 10 and 40 milligrams.
So melatonin is very interesting as well. And once again, on the wrapping up part, I would suggest that if the patient is refractory, before Maraviroc, there may be an attempt for pulse dosing, stop things, and then start again in a couple of weeks and see if that works. If that does not, then of course, Maraviroc is one more option, but this is the management approach. I forgot about, my apologies. I forgot about anosmia. 0.3 milligram per kilogram body weight ivermectin for 3 days. In majority of the patients, anosmia is removed, is gone. That's just a beautiful thing. I've seen it so many times now. My own mother-in-law had anosmia, and she had it for weeks. And I said, all right, take this. And within 3 days, she was fine.
That is, I love the things that you've seen work, especially in people with long-term cases, because one of the things that was so difficult in the beginning, or still is that it is so many people who get acute COVID, do so well that so many of the treatments it's only when I saw people who were really sick respond within a day or two to ivermectin that I really, truly believed how well it worked. Because it's when you have self-limiting illnesses, it's, many things look like they work. So it's always exciting to see that. This is a wonderful tour de force of like how to approach long COVID. And, and I don't think we mentioned, or maybe you did, but in my experience, I've treated pretty much vaccine reactions the same way as long COVID, because I really do think it tends to be that spike protein activating the immune system. And
it is actually the same management.
Yeah. And I just wish that we could get the powers that be to acknowledge it and just so we could treat it, so it wouldn't have to be as much of a disaster for people who have the problems. I think that if it's like I said, we need the vaccines for old people for certain. I mean, like the death rates are just so dramatically different. I mean, I don't think anybody, I mean, it makes me crazy when people tell me that it didn't make a difference. If, you know, people in Israel and New York, I mean, just that it's just so different, you know, but.
You're very correct. And one tragedy is that on one side, the good news is that long COVID is acknowledged and insurance can cover it. Vaccine toxicity or injury or whatever way you want to put it, that is not covered.
No, and it's very difficult. The VAERS database works really well if you had an allergic reaction, but if you had anything other than that, it's very difficult to navigate and to report.
And so people are getting vaccine injured, and then they're having to, one, go through that miserable journey of getting back to normal, and second, they have to pay out of their pocket to get all this.
Yeah, no, it's, but that is well, that's another story. Well, the economics of chronic illness is not nice. I am responsible for a lot of that because most of what we do is not covered by insurance. Yeah. You know, I mean, those of us who are in this field a long time, we often start off taking insurance, but along the way we stop because we get massacred and threatened by the insurance companies and Medicare, you know, because you do things that they don't approve of.
Right.
So anyway, it's a very, yeah, medicine is complex in America. The politics of it is a whole other world. But I just want to thank you. This was an amazing journey through, you know, just treating long COVID and understanding the etiology. I think that, and that's where I would love to come back again and just, you know, go deep on these things because they illuminate the immune system. And the more we treat chronic diseases, it is all about the immune response and how people hold their. One of the things that we talk about on this program a lot is also the psychological component, and not in the sense that you're sick because you're depressed. I mean, which I think is one of the worst things we do to people, is make them victims. But illness causes the chronic inflammation in the brain will flare depression, will cause obsessive compulsive disorder, and will cause anxiety to get worse. I mean, they're all self-protective mechanisms. Yes. You know, the body's trying to protect itself. And when you're constantly inflamed, you set off these, you know, just like the histamine response, great self-protective mechanism.
Correct.
Be transient. I mean, I think.
Absolutely. I think at some point you should come join me on my live show as well. And we talk a little about chronic diseases. It's very, very useful for people to hear how to manage and approach it and what to expect.
It will be a pleasure, but you know, and I'm a great proponent of. I said I've been doing this for a long time, but I learned to think differently about it after reading, you know, Dr. Navio and working with Dr. Navio's, but especially just reading his early work about mitochondria and their response to danger. Because that seems to be, you know, so much is when the body perceives danger, it hardens its defenses. You know, those shoulders come up. You know, I mean, and we get into trouble. Those cell membranes begin to get stiff. It's just what happens, and it's a good protective move, but not one to stay in. That is the problem. So I just want to, again, thank you so much. This was an amazingly deep and informative lecture. And, you know, for all the patients out there, you know, it's just important to remember that if you can educate your physicians and, you know, let them listen to this, watch Dr. You know, Mobeen's series. I mean, you can. I can't tell you, I mean, like, I don't get to watch enough of them, but every time I do, it's like I go, oh my God, so much more immunology details that I thought I knew. And it just go, oh, whole other pieces that open up. And that is what is missing because, you know, no matter how well you were taught immunology, if it was more than 5 years ago, you're already so out of date. and not understanding. And I think that's why, physicians, if there's one thing they should be constantly going back to is relearning immunology, because it gives you the tools to think
Absolutely correct.
about what you're doing. And your programs, they're for the layperson, but I find them amazingly educational. So I just want to thank you so much.
Thank you very much. Thank you very much for having me. Thank you for discussing this. I think we are, let's have a series of going deeper into various etiologies and pathologies, and meet again.
We will. Okay. Thank you so much.
Thank you.
Bye-bye
for now.
Do you feel you might miss any of these incredible interviews? Life does get busy, and there's a lot of great information being shared through this summit. So I'd understand if you did.
Don't worry about it, though, because you can pick up your VIP All Access Pass at a special discount rate right now. You will have lifetime on-demand access to the entire summit and all of its bonuses. So go ahead. Please grab your VIP access now by clicking on the button below. That way, you can watch, listen, take notes, and even read the transcripts at your own leisure. So join us, and please sign on for the All Access Pass today.
Thank you very much.
Thank you.
Welcome to this episode of the Mycotoxin and Chronic Illness Summit. Today, I'm so excited to have with me Dr. Gordon Crozier. He and I have become friends. We met at a few A4M conferences and found out that we practice very similarly. So of course, we got very excited to talk with each other a lot. And he's become a wonderful colleague to have and becoming my friend. So welcome, Dr. Crozier. It's so great to have you here.
Thank you. Thank you. It's so good to be with you again. So we'll have to get together sometime soon.
Absolutely. Yeah. So why don't you introduce yourself to our audience?
Well, my name is Dr. Gordon Crozier. I was clinical faculty at the University of Kentucky for some time, and I worked there. While working there, I actually became ill myself. I went on medical disability, but nobody could really figure out what was going on with me. Nobody could figure it out, the neurologist, the infectious disease. So I had so many different appointments with so many different doctors, and it was just frustrating after a while. And because of that, I began to seek out other entities to figure out what was really wrong with me. And I found out that a lot of my chronic illnesses that I had had most of my life were actually due to simple mold and Lyme. So mold and Lyme, and that's what, this is about, mold. And didn't realize I was living in a brand new home that was full of mold. But because of that, I began to seek out entities to help people get better from this, because I knew I wasn't the only one that traditional medicine couldn't figure out what was going on with them and why they were ill. So because of that, I sought out, and so now I've had my own private practice for over 10 years now here outside of Orlando, Florida. And we've just loved it, and I love helping people. And it's hard sometimes, and it's a hard disease to treat. Right. But you have to understand it affects every single organ system. So that's the cool thing, is you have to be good at everything.
Right? because we're accessing the body from multiple points. Right. Let's start by talking about peptides. I'm really excited about this, the role of peptides in chronic illness. It's certainly changed the way I practice medicine, using peptides in chronic illness. So.
Yes, me too. So there's many peptides. So about 10 years ago, I started using some peptides in medicine, and everybody's probably using one, and it's glutathione. So GSH, glutathione, is a tripeptide that everybody knows about, but a lot of people don't understand that that's a peptide when they're talking about the traditional realms. But there's other ones. So I began using something called thymosin alpha-1. And I loved thymosin alpha-1 because it really helped a lot of these people with these inflammatory conditions, because when you're talking about chronic disease and when you're talking about mold and mold toxicity, it causes oxidative stress, and we're causing inflammation throughout our body. And because of that, we have to have something that helps turn down that inflammatory markers and those inflammatory markers. So I started using thymosin alpha-1 and melanotan 2. Those were kind of my two key ones that I use all the time, because melanotan 2, although it might make you dark, it's really a great pathway through the melanocortin system in decreasing an inflammatory response, including, ACTH, it helps modulate that. So the ACTH, the MSH, all the things coming down from the hypothalamus, it really helps to dampen and really helps to control some of that inflammation and some of the neuroinflammation. That's not one of the ones that we call a neuropeptide a lot of times, but it really does help to bring down neuroinflammation. So that's why I got so turned on to peptides. As time went on, we started introducing more and more peptides all along. And you probably know one of my favorites now is LL37, because it works so tremendously with our Lyme patients.
Right.
And so I love it and what it does for our Lyme patients. But it's not just our Lyme patients. I'm finding all these other people with other viral vectors, and it really helps them to mediate that insult from those different vectors, either bacterial, viral, parasitic. It really helps all of them. And I love it because it goes in conjunction with other medications or other antivirals that are homeopathic or whatever you want to use. It goes along with all of them. So it doesn't matter what your modalities are. And we've spoken a lot. I use multiple modalities. So I'll use some traditional type medicine stuff. Then I'll use some more of a naturopathic approach, sometimes a homeopathic approach. It depends on the individual patient, what you're going to do. But I love peptides because they go along with all of it.
Right.
And so peptides are so critical to my practice. And it's probably because when you understand peptides in the source, we have over 9,000 different peptides working in our body. So why would peptides not be something natural for us to use in our body to augment different pathways and help people to actually gain the potential that they really need?
Exactly.
And that's why I really started using them. Now with neuroborreliosis, I'm using a whole bunch of different peptides now. And I love all those the peptides that we can use that are available to us today. So we keep having more and more, and it keeps expanding. Sure, some of them have been taken away, and the FDA has kind of squelched some of them, so we can't use them all anymore. But the ones that we can use are so useful in our practice, and I just love it. And I know you use them as well.
Yeah, they have changed the way I practice medicine today. So most of my patients come to me with tick-borne disease and mold and all kinds of infections and a high environmental toxicant load, mast cell activation syndrome, and inflammation as well. And so in the past, before I started using peptides, I would detoxify the patient first, and then I would try to kill the infections, maybe using herbs or maybe using IV antibiotics. And sure enough, many people can't even handle herbs.
Right.
Let alone IV antibiotics, right? And so then when I started coming in with the peptides, my favorites are TB4 frag and BP657.
Yes.
And KPV to start with.
Oh, those are wonderful.
Yeah, to calm down the inflammation first. But I found that once I started with those, then it became much faster and easier for me to kill their infections and detoxify them. They were less negatively reactive to the inflammatory cytokine cascade that comes with the infection kill.
Exactly. And that's why it's so wonderful to use the different peptides. And I use BPC157 and I use TB4 frag. I use something that's kind of newer now we're able to get. It's called APB7.
Me too.
And
Yes.
so APP7 is one that's really helps to calm down some of that cytokine storm as well. And it really helps with the healing of the cell too. And one thing that it's not supposed to be known for, but I've seen a really great response in some of my histamine patients. So it's been working for some of those people with mast cell syndrome. And it's really been helping them in it to a great degree, and I love it. And I use KPV too. I love KPV for the anti-inflammatory effects that it has as well.
Right.
So all these peptides, you just kind of weave in and out of them, and that's what that's what I do. I kind of weave in and out of them, and I kind of have developed a little bit of my own protocol for them, but it's really patient driven in what that patient is needing and the patient's response. So I never introduced the neuropeptides until after people have been able to detoxify, because even detoxifying people, sometimes we couldn't do that without bringing down the inflammation first. They couldn't even handle anything.
Exactly. Super sensitive people who you can, every time you try and move forward, you just can't. It sets them back. And I found that the peptides allow us to move forward.
Yes.
People couldn't have much quicker.
Yes, I love it because the peptides actually help to, number one, bring down an inflammatory response, but they actually, like BPC-157, it's one of my ones that I love.
Me too.
Because it's a genetic modifier. So it helps to modify epigenetic SNPs. So if you have some SNPs, like say your HLA-DRBQ, and you know that one's for, for detoxification for mycotoxins, and it can say chronic Lyme on there and different things like that. So it actually helps to modify some of these genetics so that they will express correctly, so that you actually are going to enable the person to detoxify on their own being, because that's what that HLA is. It's on the cell surface of every single cell. It's a very important genetic that we have to take into consideration. But even those people with ApoA, ApoB, ApoE, BPC-157 helps to modulate that. And I see it time and time again. The other one that actually is a genetic modifier is GHK. So GHK, I use it in GHKCU because you really need the copper portion of that enzymatic function to really open up certain pathways for enzymatic functions, but also in the enzymatic functions in the DNA. So because people don't understand the enzymatic functions that are going on, in the nucleus of the cell, but you have to get to them and you have to modulate that and how they're going to express.
Right.
That's how we can help a lot of our patients today, because, since we've been able to use these, we were probably getting 60-70% of our patients better, but it was a long haul and it was a struggle. So with the advent of these peptides, things have shortened. They don't need as many IV treatments, because I know you do a lot of IV treatments just like I do, in optimizing with amino acids and phosphatidylcholine and all those other things. But these actually help those go to work quicker. And you get better results faster. So that's why I love peptides. Well, you know me.
Too. I would say that somebody who it took 3, maybe 5 years to treat, it might take 1 year to treat when we're using the peptides.
Right. Exactly. So, and I like that because, those people then can get back to life sooner. I have several people that are just finishing up their treatment modality, and they've been with me for, about 8 months. They moved close by me and they've been here for 8 months, but they progressed so well because of peptides that they're now free to go back to school or work or whatever they were doing before. And some of the younger ones that were missing out on high school or college, it's nice to see them to be able to have that goal of getting back into college, to getting back into high school. And I had 3 students all in the same year that actually caught up on their high school, and they were actually able to graduate with the class that they had started with, but they were 2 years behind, but they caught up. And I just love that because that wasn't the case before.
No, exactly. They would have to be away from school or work for a couple years. You know,
Yeah.
people can come to the clinic now for 6-8 months, and we give them really robust treatment plans, aggressively treating,
Yes.
but also gentle, because each person is different.
Right.
When I say aggressive treatment, I mean ongoing treatment,
Yes.
not aggressively pushing someone off the cliff, but really watching them like a hawk, and consistent treatment. It's
Yeah, I
amazing.
don't like to push people too hard with
Right.
treatment modalities because I'm kind of a different, I believe the Herxheimer reaction is a warning for us that we're pushing
Right.
somebody too far and too hard.
Yes,
And I know
agree.
there's some doctors out there that believe that, oh, you got to push them, you got to Herx them, they got to Herx. And I'm not that person. I think if you're having a Herxheimer, oh, we've got to back off. We've got to think about all the pathways that are working
Yes.
and which ones are not. And let's try to give you the peptides that are going to optimize these specific pathways. And it will work well for them.
Right. I fully agree with that. A lot of patients will say, oh, you can push me until it hurts. You can push me until I'm exhausted. And I say, no. And then they say, if I Herx, doesn't that mean that we're doing the right things that mean we're killing? And I say, well, maybe it means we're killing the infection, but it's too high of a dose. It could be the right medicine at the wrong time. So we've got to back up, calm down the inflammation with peptides usually.
Yes.
And then reassess where we're going.
Yes, because there's some literature out there now that those reactions, when we push them too hard, are actually causing some mitochondrial damage. So if we're causing mitochondrial damage, then what are we going to do to that person? And so usually, you know, mitochondria I address towards the end.
Me too.
And I usually use VIP as one of my peptides to address the mitochondria towards the end of treatment modalities, because I figured it out the hard way. We didn't have anybody to help us.
Right.
So, you know, we kind of figured it out the hard way, but we found out that VIP wasn't working early on. In fact, actually it had adverse effects early on,
Right.
even though they needed it. And you could see it by their labs, they needed VIP. But introducing that peptides towards the end of treatment modalities really helped with some of that mitochondrial restoration. And so that's why I like to do it more towards the end.
Right. And that speaks about the cell danger response, where the mitochondria are creating external ATP outside of the cells as a warning signal. The person is sick here. And so it might not be the time to rev them up, because they're just not gonna use.
Right, exactly.
Create the ATP in the right places. So definitely I use it as an after therapy as well.
Yes, me too.
Yeah.
And I see great results with it, especially, everybody, but especially my younger patients that used to be able to compete athletic wise, but then they got sick and then they couldn't compete anymore. But I have several competing in lacrosse again, you know, just because we got them through the process, got them through it. So unfortunately, some of them get tested, so I can't use peptides on them much while they're competing.
Right.
But I continue peptides even after they're done with me, just to, you know, modulate all their inflammatory responses and everything. So I like to keep up with what's going on with the patient when they're done.
Right.
With the intense treatment modalities. Intense, in other words, they're getting IV treatments several times a week.
Right. Exactly. Yeah. Because what I notice about my patients is that they're generally sensitive people. And so once I've cleaned up the infections, I've detoxified them, of course, using peptides all along the way as well, and we get them better and they can now go have a life. sometimes it's easy for them to get knocked off again. It's they've got that immune system patterning that the body knows how to go right back into, or the neurological patterning that the body knows how to go back into very easy. Oh, I'm finding that the peptides are helping to repattern the immune system,
Yes.
the neurological system as well, which is why
Yeah.
keeping up with them after is so important too.
Yes, yes, yes.
Yeah.
Yeah, we have to repattern things, actually help people to come to a realization that they are kind of fragile in the beginning. But I see as they go on in time, because now that I have people that we've done peptides on for, 6+ years now, kind of ongoing, kind of weaving in and out of things,
Right.
I've noticed that they're kind of setting up where they don't need as much, or they don't need as often, and they're kind of really they're changing modality ways and really remolding everything. One
Right.
peptide I wish we could have in the United States, because I have some patients from Europe, and they've been able to actually get this peptide. It's called humanin. Humanin is a very cool peptide. And it actually helps to heal a lot of aspects in the cell. So not only mitochondria, but the ribosomes and the cytoplasm. It actually works in the matrix as well. So it is a very cool peptide. I had one woman that was really sick. She was from France, extremely sick. And she really had gone through all the modalities. She'd been all over the world getting treatment, but nobody ever used peptides on her. And then, I found out, oh, there's a place not too far from you. You can get some peptides. So got her in contact with this person. We could use peptides, and I would do it through Zoom, because she couldn't come here for she did come for a little bit of period of time, but she couldn't stay real long like a lot of other people. So she went back home, but we modulated her with peptides. She's now doing extremely well. And that's what I like, because she didn't think, she was told she would never be able to have children. We started her on humanin. Her fertility came back.
I love it.
She actually just had her second child now. So it was kind of cool, but we don't have that peptide here in the United States, but I'm praying that we can get it here soon. So,
Right. So Gordon, speaking of where to get peptides from, I'd love for us to talk about that to our audience, because now they're hearing us talk about these peptides, and of course they want them, and they're going to go to the internet and find that they can buy them from there. And right. So can you tell them why that's not a good idea?
So we don't want people to go online and get these peptides. Number one, you don't know the source of them. So where were these peptides sourced? Number two, I've been involved with some company, and we actually tested some of those peptides, and some of them didn't even have the peptide in that they were supposed to have in. They had a different peptide that actually wasn't going to benefit the person at all. So you're actually going to waste your money. Yes, they might be cheap online, but they're also can be filled with toxins. It might not be the proper peptide that they say it is. It might not be the strength that it needs to be for the effect that you need. So that's why I like to go with a true compounded pharmaceutical peptide. So, and physicians, as physicians, we have to write the order for that.
Right.
But, there's those pharmacies are available out there, and people can get them. You just have to go through the proper realms, and it might be a little bit more expensive, but I find it a whole lot more safe.
Exactly.
I can tell you, so I had one, I like to lift weights. So I go to the gym, and I have a lot of gym friends in the gym, and they said, oh, I just got this peptide. And they said, and I saw the name of where it was from. And I said, oh, I wouldn't use that peptide. And he says, no, I'm going to use it. I'm going to use it. I don't care. Yours is twice as much as what this one is. This one's only whatever. I forgot what it was. But And I said, seriously, I probably wouldn't use it. Well, you know what? He ended up coming back about 2 months later, and he was really sick.
Oh,
Well, you know
no.
what he had?
Mm-mm.
He ended up with mercury poisoning because there was mercury in the peptide he was using. So he was injecting himself with mercury every day because it wasn't a legitimate company.
That's terrible.
Yeah. So
Yeah.
you don't know how they're created. You don't know the toxins in them. So that's a real life story just for anybody to realize. I like real life stories that actually point to why we probably shouldn't go down this route in using non-authorized peptides. So
Right.
because you don't know the source of them, you don't know, they actually tracked one back and the peptides were made in somebody's garage. So
Oh.
one of the companies. I mean, I've been on the end of some of these people getting tracked. So it's been interesting.
Thank you for sharing that. I also know that they're often not processed well, correct? Like there's
Correct.
this final stage in the processing of the peptides in order to make them bioavailable. And
Right.
the compounding pharmacies do that, but typically when they're
Right.
made in someone's garage, it's not happening.
No, it's not going to happen. So yeah, they have to become bioavailable. If they're not bioavailable, then they just are not going to work in your body. It's just you're wasting your money. It's just going to, and actually can be introducing more toxins to you because then you have to detox those non-bioavailable forms. You know, nobody thinks about that, right?
Right, right. Exactly. Thank you for sharing that story. So did you end up having to do chelation therapy for him?
So I had to do chelation therapy for him. So this cost him quite a bit because number one, he was going to compete.
Oh,
He
no.
couldn't compete
Oh.
because he became so sick. He couldn't lift weights. And so, he was, because he was going to compete in a bodybuilding expedition. And he probably would have won because he was really buff. But even sick, he looked buff.
Oh, wow. Yeah.
But he was really toxic from the mercury. So once we detoxed him from the mercury, we were able to get him back on track. And then he did use my peptides. So now he's getting ready to compete soon. So
I love it. Yeah. He was lucky that he had you there with him to catch that. Because now not too many doctors would say, you know what, let's take a step back and see what's causing this inflammation. So we know that environmental toxins cause inflammation.
Right.
Tell me more about that, what you see in your practice.
So I like to do a whole panel that tests for heavy metals. We test for mycotoxins. We test for environmental toxins.
Right.
So very few times do I find that people have mold alone.
Me
They'll
too.
have mold, right? They have mold, and that's the major thing. But a lot of them have like cadmium, or they have a different heavy metal that's associated with that.
Exactly.
And
it's never just one toxin, never
just
one. Or never just one bug. It's not just Lyme or not just mold.
It's multiple ones, right?
Right.
So, and I find that they have a lot of either glyphosates or phthalates or different plasticizers.
Right.
We're using plastics so much in our society anymore.
Right.
So that can be a real issue for a lot of these people. And we have to detoxify them. So we have to kind of, okay, which one are we going to detoxify first? Because you don't use the same things.
Right.
Detoxify all of them, right?
Exactly.
So, you're going to have to use some DSMA, and you're going to have to use some EDTA. Right. We're going to have to kind of, which one are we going to use first? And so kind of playing that role. So I do Sears markers on everybody, and I kind of look at their Sears marker.
Yeah.
So, depending on what I think is more integral at that point to hit, that's what I'm going to detoxify first.
I always love talking to you because it's the same. We practice so similarly. It's fun, I do the same thing. Measure all those toxins and then decide, looking at their inflammatory markers, Oh, we're also, we're part of Dr. Bruce Patterson's long COVID group.
Oh, great. Yes.
Yeah. And he has a great inflammatory cytokine test on his website.
Oh,
And
wow.
we're using that test now to look at people's inflammatory cytokines, not because they have long COVID necessarily, but because inflammatory cytokines are universal, whether you have long
Right.
COVID or tick-borne disease or high environmental toxic load.
Right.
Yeah, so I'm looking
And all of those, you know, and there are several different tests available, and even glycoaging. So glycoaging, glycans, you have inflammatory glycans or non-inflammatory glycans. They can actually kind of measure those now to see what is going on with those glycans. That kind of hits a different realm too. So I like looking at all that stuff.
Right, right,
It really helps to hone down the picture on what way I'm going to hit first.
right. Where are we going to go next?
Right.
Right. People often want to start with killing the bugs first. I tell them, no, 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 not there yet. We have to prepare you
No.
for that. Yeah.
Sometimes we don't even detoxify first.
Exactly.
Sometimes I don't always go for that first. You know, I try to dampen the inflammatory response first. And the body needs a little bit of preparation. You know, if you
Right.
just start detoxifying them, you're breaking down more cells as you detoxify them. So they have to have some kind of semblance of being built and ready for that detoxification and for what's going to happen. Because when you're detoxifying, you're actually causing and creating some oxidative stress.
Right,
Right?
right.
So
Exactly.
we have to undo some of that oxidative stress at the same time as you're detoxifying. So sometimes I get rid of some of the oxidative stress first, calm
Right,
it down, and then
right,
go after the other things.
right. Me too. And oxidative stress is normal as a part of an initial inflammatory response. We want that at first, but we
Right.
want that system to shut down. And our patients are stuck in this loop of,
Yep.
of oxidative stress. So
Yep.
I'm gonna cut that loop and then come in detoxify.
Yes.
But I cut that loop with the peptides typically.
Yes, that's what we
Yeah.
do. Those
Yeah,
peptides work.
right.
So that's what's so good about the peptides, is because you can cut that loop. So I use them in combination. You know, if you have that loop that you're really needing to cut down, sometimes I start with KPV and sometimes I don't. It depends on if I think it, you know, where's that inflammation. And I'll just tell you my little hint on why I might start with KPV first. If they have high monocytes, because lots of literature state that monocytes mean bowel inflammation. So if we have bowel inflammation, that's pretty high. So if you have monocytes more than 7, you're beginning to have bowel inflammation. If you're more than 10, then you have a lot of bowel inflammation. So if they are at 12 or 13 on their monocytes, I'm probably going to start with KPV, BPC, and TB4 frag before I do any of the other ones. But then we'll kind of get to some of those other ones. But that's kind of my key I look for, is what's that differential. If they have high basophils on their CBC count, high basophils is directly related to interleukin 6. So if you have basophils of 1 or more, you have high IL-6. Inflammatory cytokines are out of this world. And we've got to dampen that down. So that's kind of what one of the measures I look at, just one of them.
Right. I love it. I love it. And another thing I love about the peptides is, maybe people have gathered this now that they're hearing us speak about them, that they're very specific messenger molecules. They don't give necessarily a broad spectrum of information like everything else, almost everything else that we give, but they're very, very targeted.
Yes. And because they are targeted, that's why I like to use them specifically, like the KPV for that bowel inflammation, because I find that KPV works so great at that inflammatory response in the gut and the gastrointestinal tract. So that's why I kind of will pick that one. If they have high monocytes, that's my first go-to. whoop,
Uh-huh.
this is what we're
Yeah.
going to first.
Right.
And then we'll weave in the rest of them and bring down the other inflammatory markers eventually.
Uh-huh. I love it. Are there any specific peptides you like to use to help a detoxification process?
So for detoxification, oh gosh, I go to a lot of them.
Okay.
So what's my favorite one's going to be? So let me think for a minute here. I'm just kind of stuck in the thought. I don't know why I'm stuck on my thought process, but for detoxification, I like to use things that are going to kind of help. So GHKCU, I know, helps with some things. It doesn't help with all things, but it does help with some things.
Mhm.
And it helps with some of my people that have specific environmental toxins.
Mhm.
If you have high glyphosates,
Uh-huh.
the glyphosates kind of block some of the copper enzymatic functions.
Uh-huh.
And so GHKCU is going to help with some of that detoxification from that.
Mhm.
Some of the other ones that I'll use or thymulin. I'll use thymulin for helping with some of the detoxification, especially if I'm thinking that they have specific toxins related to thyroid issues.
Right.
Because some toxins are going to be specifically targeted at your thyroid.
Right.
So I'll use thymulin for that. If I'm thinking about more neurotoxins, I kind of do something a little bit weird for that.
Uh-huh.
So neurotoxins, I'll use. Now, RG3 is not really a peptide, but I'll use that because it helps to calm down some of that microglial inflammation. So I
Mhm.
want to calm down some microglial inflammation first. And then we'll start into the fact of doing peptides. And some people use non-conventional ways of using peptides. They're not really for that, and they really should not be used IV, but I've seen them used IV. And
Which ones?
so like BPC 157,
Uh-huh.
it works well for that. And even KPV works well IV wise, and I've seen that used as well.
Right. Too.
And KPV is kind of one of those cool ones that if it's used IV, it will actually help to modulate a lot of the endothelial inflammation that is going on vascular wide everywhere.
Right.
And as you bring down that inflammation, they begin to spilling out some of those toxins automatically, which is kind of cool. It's kind of a double-edged thing, and it does more than one exact thing. So for as far as neurological, C-Lank is one that really elevates bone-derived neurotropic factor, but it actually helps with some detoxification, especially, and it can be it is cerebroprotective, as well as helping with some of those toxins that are latched onto some of the receptor sites. So it really helps with that C-Lank does. There's cerebrolysin that I absolutely love, and I think it really helps with detoxification neurologically.
Right.
Because that's kind of the crux of my thing is I do a lot neurologically. So I do neuroquants. I evaluate neuroquants all the time. I do something called CNS vitals. And I like to do the CNS vitals kind of towards the beginning, and then we do them midway, and then we do them towards the end, kind of see the progression, and then they can actually see the progression on how fast they can think now. They're thinking much more clearly. They're getting things correct better.
Right. People often will forget how much better they are 3-4 months in. And you say, you weren't able to remember why you went into a room.
Right.
And now you're doing your accounting.
Yeah.
You know,
Their executive functioning is much better.
right.
And a lot of these toxins, like mycotoxins, you know, they're going to affect different areas of the brain.
Mhm.
Other toxins kind of have direct effects on certain specific areas of the brain.
Uh-huh.
So it depends. So what specific areas? So some toxins like the caudate nucleus, kind of our executive functioning area.
Mhm.
So we've got to be able to get at that, and that's why I like cerebrolysin, because cerebrolysin kind of is one of those things that kind of causes some, I call it washing of the brain. Okay.
Uh-huh. Uh-huh. Yeah.
It kind of helps to grab up some of those neurotoxins and really pull them out. So I use that in conjunction with glutathione and with some other modalities as well, like BPC 157
Mhm.
and dihexa I don't use right away. Dihexa I use later on, after their brain's kind of beginning to work and function. That's when I introduced dihexa. So dihexa is a nice peptide to actually help, unless they're coming in and they're an Alzheimer patient, then I'll go to dihexa and I just will kind of continue them on that. But
Right. It's so personalized, bottom line, right?
right. It depends on the individual person. So, you know, C-Lank and C-Max, because, you know, those I kind of use in a lot of Parkinson's patients, but it's amazing how many, you know, there's some recent literature that just came out about most Parkinson's patients have a lot of environmental toxins in them.
Right.
A ton of environmental toxins. I know we saw it back in 2017. Some articles came out about it. But now there's even more articles about it, really substantiating that Parkinson's patients are probably actually environmental toxins and the way it affects them. So using C-Lank and C-Max along with cerebrolysin, so I use those three in combination on my Parkinson's patients because it really helps with that. Now, sometimes I do have to do some IV chelation for them because some of them have heavy metals. Some have some other stuff that we've really got to get rid of some of those things.
Exactly. So it's like getting rid of the toxins while we're supporting the entire system with the peptides.
Right. You kind of have to do it hand in hand. If you don't, you kind of.
Right. I learned that in my own way when I first started using the peptides. I thought, maybe I should just use them at the end of treatment. Maybe they're more just a regenerative piece, kind of like healing the mitochondria. And then I learned and realized, I can use them at the beginning, and that's what I ought to do, because it's modulating the system, setting up the system for everything else that's about to come, and I keep them on those peptides long term.
Yeah, I do too. I keep them, especially some of them. I'll keep them on them very long term.
Yeah.
Now some of my mycotoxin patients that have had some pancreatic issues towards the end of treatment, then I'll begin to put them on MOTS-C, which can actually help with some of that stuff.
Right.
And I've recently really found some great results in some of my patients that I could not get their glucose under control after treatment modalities. They're all cleaned up. Everything's working well. They're beginning to think again and everything's working, but they're still ending up with a high fasting glucose.
Right.
I started them on semaglutide, and I put semaglutide with BPC 157. It's just a once a week injection. And the semaglutide really helps these people to modulate their insulin and glucose ratios in the pancreas, because it's actually kind of helps regeneratively in the pancreatic islet cells. So it's kind of cool and what it does in helping that and helping the pancreas kind of restore, rebuild, and all of that. So, but I have them on BPC 157 every day, and then once they do the semaglutide.
Yeah, fantastic.
So there's so many different ways you can use it. You just, what I tell people is start using one or two and just getting used to that one or two that you feel the most comfortable with.
Right.
And then you'll eventually start using more and more and more and more. I mean, now we use PT141, melanotan-2,
Uh-huh.
we use Kispeptin, we use, all of these different peptides for all different functions, because I don't know if you see it like I do, but a lot of my younger, especially men that have been insulted with borreliosis, with Lyme disease, they have extremely low testosterone levels.
Yes.
They were hit in their puberty ages.
Yes, they
And
look
those,
like old men,
yes,
their testosterone levels.
it's horrible.
Yes.
And what I'm finding with them is that Kispeptin is a really cool peptide to use with them, because it really will help them build up their testosterone. It doesn't happen real rapidly, so you have to have them on the Kispeptin for a pretty long period of time, but you begin to see their testosterone levels rise and rise and rise, where they're kind of almost up to a normal range.
That's right. You don't have to use Clomid anymore then for that.
Right. Because
Yeah.
you see so many young men today with low testosterone levels. It's just rampant.
It's high estrogen.
Yes, high estrogen. So you do have to block those estrogens too a lot of times. But I found that really works. And a lot of times, some of those young guys in their 20s that were sick when they were in their adolescent years, they don't have much of a sexual drive or desire. And using just a small fraction of melanotan-2 with Kispeptin actually helps build that for them. And they're really much more satisfied in their sexual relations. So, we are sexual beings. And so it kind of helps. You feel better about yourself, right?
Exactly. And so many men need PT141.
Yes.
For that reason too.
Right.
Yeah.
Yeah.
They're so appreciative that we can change that part of their lives as well.
Right. Do you use any for female anorgasmia? What's your preference for female anorgasmia in people with chronic disease after they're kind of through their chronic disease to kind of help with that?
I found that the PT helps.
Yes.
Yeah. How about yourself?
I do. I use PT141, and then I also will introduce oxytocin along with it. And those two combined really will help some of these women that have been left post toxin exposure, either mold or environmental toxins, because there's some bad environmental toxins that really can cause that. But this really helps to augment that so that they can begin to enjoy that part of their life as well. And because you have to have both men and women, optimized,
Exactly.
Everybody needs optimized. I don't care what your sexual preference is. We all have to be optimized.
Exactly. Exactly. Yeah. What are 3 takeaway points that you advise your patients?
So what do I advise my patients? Number 1 is let's begin to decrease our toxin intake. So number 1, organic foods. Let's change the chemicals that you're using in your home. Let's probably try to go, and they can actually save some money. And I give them key hints on things that they can look at and go to create their own, like laundry detergent, which is a fraction of the cost, and other cleaning utensils around the house, so that they're cleaning their home and their home is kind of free and safe.
Right. So important.
And to have a clean, safe home, also, I usually do recommend environmental testing of your home. Do you have environmental toxins in your home? Do you have mycotoxins in your home? Do you have other environmental toxins?
It's so important, because until we remove that trigger, it's going to be hard to treat the rest of the system. They're just going to keep getting assaulted with that.
Right. Exactly. So I had one of my patients who had their home inspected, got it all cleaned up. I cleaned her up. Well, her whole family. It was a whole family that we cleaned up. But anyway, got them all cleaned up. All of a sudden, she's calling me. She says, I don't know what's wrong. I'm so sick. And da-da-da-da. So she came in because she lives in South Florida and I'm here in Central Florida. So she came up. We did a long, hard visit. Do you know what I found out at the very end of our consult?
Tell me
They built a new home and moved into a new home.
right away.
So you know what I did? I did environmental toxins on there. The off-gassing that happens in new homes is really huge.
Yeah.
So she got sick all over again, not
Mm.
because of mold this time, but because of other environmental toxins.
Right.
So, you have to understand, and that's why I tell people, you know what? If you're going to buy something new, let it off gas first before you bring it into your home. Even
Right.
mattresses, anything,
Right.
let it off gas first. Don't just go lay on it right away.
Exactly. Yeah. Yeah. Thank you so much. It's always so much fun to talk to you. Always.
It is to you too, because we kind of have similar practices. We kind of practice very similar. I
Yeah.
remember the first time we started talking, and it was like, "Oh my gosh, you do that? Oh yeah, I do that. Oh yeah, I do that." So it's like,
Yeah.
"Oh yeah."
It was so much fun. Always is.
It is.
Yeah.
It is. So
Yeah.
I can't believe we already been on here for an hour. So it's
I know, right?
wild.
Almost. I know. Well, thank you for this interview.
You are welcome. You are
Yeah.
welcome. You take care.
You too. Well, another great speaker.
Yeah, we've been very lucky.
Mhm. Truly. So before we move on to the next one, let us know in the comments below about what you've enjoyed the most so far.
Have you learned something new? Is there a particular speaker that really inspired you? Let us know and use the comment section below. And also feel free to respond to the other comments and try to get a conversation going, because we will be reading them.
We sure will be. We really look forward to doing it. Thank you.
Thank you.
Welcome everyone to the Mycotoxin and Chronic Illness Summit. I'm Dr. Christine Schaffner, and I'm here with my colleague and dear friend, Michael McEvoy, and we're going to be talking about Helminthic therapy, autoimmunity, and evolutionary mismatch. Welcome, Michael. It's really great to see you.
Thank you for having me, Christine.
Yeah, well, I think you're in this beautiful setting for this amazing topic, and this is something that I've been continually intrigued by, and I just always trust your perspective, and I know that you research an incredible amount before you become, formulate an opinion, so I'm really excited to hear what you have to say today. And as the title kind of alludes to, I want to first dive into this idea of what you share as evolutionary mismatch and its relevance to chronic illness. So can you just set the stage for the conversation and share your thoughts about this?
So evolutionary mismatch is a term that was sort of first used in the 1940s by, I believe the person attributed is Ernest Mayr. And essentially evolutionary mismatch has to do with the fact that there are certain inherited genetic traits that were once advantageous in a certain type of environment, which have now become maladaptive in a new or different or changed environment. And so this concept of evolutionary mismatch is we start to look at it, start to understand that it's really central to understanding the genetic involvement with the rising tide of chronic disease in the modern world. And it also leads us to envisioning new treatments that could potentially augment and fulfill the genetic code for certain individuals that are more aligned with producing inflammation. But if those individuals had exposure to certain types of helminths or parasites, that a lock and key mechanism is almost established to the point where if they're missing a certain environmental vector, and as I want to talk about briefly an article that I published in the Holistic Primary Care magazine that really ties this concept together, we really need to take a step back and look at how evolutionary biology has been very much relegated from the discussion of modern medicine and chronic disease. And a lot of that has to do with politics, with the fact that medicine, by its virtue of trying to identify pathogens as the sole vectors in disease, have become obsessed with that effort. And in this process, medicine still, in my opinion, does not have the maturity to investigate the concepts of inheritance and genomics through the lens of evolutionary biology. This has a lot to do with the creation of molecular biology, which is about 100 years old. And I would argue that molecular biology, which is the template that we use to study genetics today, as well as the basis of modern medicine, is more of a technology than it is a fundamental science. Molecular biology has a lot to do with neo-Darwinism and the principles of neo-Darwinists, such as survival of the fittest. The neo-Darwinists got the upper hand in the creation of molecular biology, and as a result of that, became obsessed with sort of their own personal eugenicist views of what they wanted medicine to become. But in that process, evolutionary biology has largely been relegated from the textbooks as well as from the discussions in modern disease and in modern medicine. It's very interesting because if you look at the population data and the epidemiology between the first world countries and the third world countries, we see a large disparity in the types of diseases that show up. And I specifically mean that the disparity is that in the first world nations, there is a high prevalence of inflammatory diseases. I'm talking about a high prevalence of allergy, atopy, eczema, psoriasis, autoimmune diseases, rheumatoid arthritis, lupus, inflammatory bowel diseases, on and on and on, neurodegenerative diseases, inflammatory diseases like type 2 diabetes and cardiovascular disease. These diseases have been largely minimized and to a large extent absent in third world geographies. And the question has always come up as to why does that disparity actually exist? And this was the basis of the hygiene hypothesis, which later became sort of the evolutionary mismatch hypothesis, which is that certain genotypes are predisposed to producing inflammation. Why is that the case? Because our gene pool and our immune system has evolved specifically because of diverse pathogen interactions. We do not have an immune system unless we have millions of years of pathogen interaction. And those pathogen interactions are not only capable of producing inflammatory immune responses, they also create adaptive symbiosis. The concept of symbiosis was really pioneered by a wonderful biologist by the name of Lynn Margulis. And she really led the flame to showing us that organisms evolve together. And that from this research, we have to very closely redefine what pathogenesis really is. Because as we've come to learn over the past several decades now, and there's been many years of clinical trials that have been done on helminthic therapy, ingesting either orally or cutaneously, inoculating yourself with various helminths or worms or their eggs to arrest various inflammatory autoimmune diseases. Many successful clinical trials have been performed. But through that knowledge, we have gained a deeper understanding that what we call pathogens needs to be carefully redefined. Because, for example, Trichuria suis, which is a helminth, is classified by the Centers for Disease Control as a parasite. However, Trichuria suis has clearly demonstrated the ability to arrest inflammatory bowel disease in a significant percentage of patients. I'm talking about colitis and Crohn's disease. There were 2 randomized clinical trials conducted in 2005 that clearly showed that significant benefit. So we have to really now in my opinion, revisit and redefine pathogenesis through these new lenses, because what we are learning from the clinical trials and what we're learning from metabolomics testing that has been done on how helminths interact with our immune system, how they downregulate and dampen the Th1 autoimmune response, how they dampen and attenuate the sought after immunological pathways that are centrally discussed in these autoimmune diseases, the lock and key mechanism of Helminthic therapy becomes more clear as we start to unravel this.
Wow, so that's a lot to take in because the people who are listening, right? This is focused on mycotoxins, but also the chronic illness world, right? So this is a very, and I have similar thoughts. I haven't dove as deep to you, but I do feel that, our health is highly, we've evolved, right? We have a microbiome, we have a virome, we have a mycobiome. Like, it's not this war against war against microbes, right? It's this, evolution, as you said. And then how I've made sense to that modern life has kind of insulted our terrain so much that some of these things can become opportunistic and then thrive in our body and create symptoms. And so this is like a whole nother narrative, right? That we're missing a potential parasitic infections that might not even be called parasites because they're offering value to the patient's health because of our modern, maybe more sterile, less diverse world. So it's kind of like this, there's some similarity in these themes because I think biodiversity, adaptation, resilience, all of these things are key to health, but we're looking at it from a whole different angle because parasites are really common, right, in this patient population who are chronically ill, and we have this, all these anti-parasitic strategies and cleansing the bowel and getting rid of things. And so, do you feel like these two ideas still can interact with each other, or is there a conflict there?
So the difference between a parasite and a helminth is actually very simple. A parasite feeds off of the host. A helminth provides a mutually beneficial relationship between the host and the colonized worm. And so as we begin to look back throughout history, we realize that protists and worms have been a part of the human biome for such a long time that their absence is only their absence has only appeared within the last couple of 100 years because of sanitation practices, the increased incidence of the increased use of antibiotics and other immunomodulatory therapies. But the key distinction is that a helminth provides a mutually beneficial relationship, whereas a parasite feeds off of the host. So when I'm talking about helminthic therapy colonization, I'm not talking about colonizing with parasites. I'm talking about colonizing the biome with ova or worms that are not capable of moving outside of the intestinal biome, but are at the same time capable of releasing various molecules into the host, which regulates or modulates many of the inflammatory receptors that we know are involved in various autoimmune diseases.
Thank you for the distinction, the clarification. And is there ever a situation where a helminth can become parasitic because of terrain or other conditions in the gut, or is that not a possibility?
Well, that's a great question, and it comes down to individuality. I'm not necessarily suggesting that helminthic therapy is ideal for everybody, but I think that it's first important to ask who are the patients that would benefit the most. And we know from what's already been published that type 1 autoimmune diseases, Th1-driven autoimmune diseases, are primary candidates. We know, just speaking of SIRS for a moment, I know that this is really about your summit is very much about that. I wrote an article a couple of years ago on my website, metabolichealing.com. It's a free article that's available for anybody. And the title of that article is SIRS and Helminths, Is This the Missing Link? And I just asked the question that, is it possible that SIRS, which is the chronic inflammatory response syndrome response to various either mold or mycotoxins or so-called biotoxins, can that be possibly related to a long-term multi-generational biome depletion of helminths? And as we start to peel it away, we realize that as Richie Shoemaker has done his important research uncovering that chromosome 6, the MHC2 region, which is the HLA class of genes, HLA2, is largely involved in the genetic association to SIRS. What's interesting about that is that helminths directly act to inhibit the major histocompatibility complex 2, versus MHC1 is more driven by viral pathogen selection. MHC2 has been more driven by parasite selection and parasitic peptides. There has been a flurry of studies that have shown that certain helminths can secrete cystatin protease inhibitors. We know that one of the ways that fungi and mycotoxins can adversely affect the respiratory tract is by the secretion of various proteases. We know that helminths can directly interact and inhibit this process. We also know that many people that have SIRS and autoimmune disease, many people that have SIRS may have autoimmune disease also, or may have, whenever I work with clients, taking an inventory and just seeing if there's that going on, or if it's in the family. And oftentimes I find that's the case. So there's clearly a link between autoimmunity and SIRS and the possible interaction between diverse pathogen exposure versus not diverse pathogen exposure. And what do I mean when I say diverse pathogen exposure? Again, when you have a biome that has diversity, a diversity of microorganisms, the diversity creates a situation where you become less susceptible to the pathogenesis of single pathogens. The less diversity of microorganisms you have, the more susceptible you are to the pathogenic effects of single pathogens. And that again has a lot to do with the fact that we have all evolved with microorganisms as symbionts. What we call pathogens is sort of a misnomer, because we can live with tons of, and I've run stool tests, and I'm sure you have too. And, we deal with a lot of sick patients, so that, whenever you see a sick patient, you run a stool test, you find, you could find anything wrong with them by looking at a stool test. But if you look at a healthy cohort, not too many good scientists are actually looking at controls. They're only looking at, let's just study the sick people. Let's not look at the controls. But I've actually seen many healthy people, including myself, that would show various pathogens in the stool, yet we present no symptoms. Why is that? How is it we present no symptoms whatsoever, but we have all of this colonization of all these so-called pathogenic microorganisms? They've done studies in Africa that have shown that healthy indigenous people living off of the land truly in remote regions of Africa are loaded with bacteria that are strongly associated with Crohn's disease, yet don't possess those symptoms whatsoever. How is that? And I think that what we really need to do is to take a step back and really redefine pathogenesis as different degrees of dyssymbiosis, the ability or the inability to tolerate other microorganisms. Because immunology is very much about adaptation, the ability to adapt and to get stronger, to learn, literally, biological plasticity, to actually learn from the pathogen exposure that you had, that your immune system gets smarter. It remembers what to do. It remembers not to overact next time. That's the level that we need to get, because we can try to get rid of mold from our environment. But guess what? We'll never be able to do it. It's not possible. Mold is everywhere. It's everywhere. It's always been everywhere. Why is it a problem now as opposed to 200 years ago or 50 years ago even? What has changed in the environment? What are the things that have changed that have led to a dysregulation and a dyssymbiosis to form that we now call SIRS, or we now call autoimmune disease, or we now call enter in the next disease label? We have to look at the relationships between microorganisms in each person, because we're never gonna figure out these complex problems by using the old model of medicine, which is single pathogen vector oriented, which was good in the 1800s when you had acute illnesses caused by pneumococcus or whatever. Today, it's a different world. It's a completely different microenvironment. We have completely different biomes, which are completely depleted of helminths, virtually. And that's been studied and proven.
No, you make an excellent point. And, I think I agree with you. I think I've just been thinking about this from a different angle, and I've been thinking of the increase in toxicity that we're all exposed to, and how that is weakening our terrain and how that has been underlying. I haven't, and I, of course, think about, okay, biodiversity of the gut and, all of that. But I guess maybe, how do you make sense of like the rise in toxicity and the absence of helminths in the body?
That's a really good question. And I just want to say that there is no question that the environment that we're living in is very toxic. And the interaction of various chemical toxins, many of which are not even detectable, microplastics, for example, that we're consuming on a regular basis from myriad number of sources, that all of that is going to directly affect our microbiome. It's going to. We do know from other research that microorganisms have the ability to sequester different toxins. I remember years ago, reading papers that showed that 50% of the dry weight of a bacteria can be a heavy metal like mercury or iron. Well, that's not necessarily any different from helminths or worms or any other microorganism that we're colonizing. I think we have to start to look at these complex interactions with the environmental toxic factor is how that is affecting our biome, because it is. There's no question that it is. And the ability, and when we talk about modulating the biome, most people think, oh, more probiotics or more prebiotics. Well, that's fine. I'm not necessarily opposed to that. But we have to always remember that what we have missing in the Western world that is not missing in the third world are helminths. Just talk for a moment about that article that I published in Holistic Primary Care. And I really think that it's a segue into this to kind of illustrate the significance of this. Consider that the APOE4 type has a 20-fold risk of developing Alzheimer's dementia before the age of 65. That is specific to the first world, to the United States. If you have the APOE4 genotype, you've got a very high risk of developing Alzheimer's dementia. If you live in Papua New Guinea, or if you live in sub-Saharan Africa, have that APOE4 genotype, or if you live in the Amazon basin, you do not develop Alzheimer's disease. Alzheimer's disease is negatively correlated to those regions and is not correlated to that genotype in those regions. The reason for the disparity is helminths. And the literature on that is very, very clear. There was a study done on Amazonian horticulturalists basically showing that the greater parasite diversity that APOE4 genotypes have, the better cognition they had with age. Not only did they not develop dementia, but their cognition actually improved with age in the presence of parasites. We know from other research that APOE4 carriers have a greater, stronger immune response. They have a more of a recoil in their ability to combat different types of pathogens. We know that because we look at the mouse studies and the human studies and the metabolome studies on APOE4, we know unequivocally that they have a very robust innate immune response. That's good for one thing, but bad for something else. And that specifically means that if that APOE4 genotype that many people out in the Western world have, whatever it is, 15% or so, that genotype didn't evolve in the United States in the first world. That genotype evolved in pathogen-rich regions of the world. And that's why those pathogen-rich regions don't have a prevalence of Alzheimer's disease. Transplant that APOE4 genotype to New York City, and you're going to have the appearance of a new disease in the gene pool, i.e. Alzheimer's disease, which for that genotype is relatively new. That is called maladaptation or maladaptive genetics. So just for that genotype alone, I proposed in this article that I wrote the need to look at helminthic therapy as a viable treatment, as a necessary treatment to attenuate the inflammatory tendencies of the APOE4 genotype. But it doesn't stop there, because as you start to really go into this, you realize that so many other genotypes that we now look at have specifically evolved because of parasites. The HFE hemochromatosis gene is another one. The LARC2 gene that's associated with Parkinson's disease is also a result of pathogen diversity genotype. genes that are even the RCCX cluster, genes that are copy number variations. Why did they copy? Because it was nature's way of saying we need more of this gene to fight this kind of infection. And parasites are the modifying factor for these genotypes that are now associated with modern diseases. And what happens when you deworm the third world? There's been a plethora of huge randomized trial studies and cluster studies in the third world showing that if you have patients if you deworm patients with helminths, they then do their evaluation to show glycemic markers. Huge increase in insulin resistance when you do long-term deworming protocols. Same thing with vascular disease, inflammatory markers. So not only are helminths a modifying factor of our genotypes, but if you remove them in certain populations by deworming them because we think we're doing the right thing, you wind up creating a new disease that didn't previously exist. Wonderful if you're big pharma, right? And mind you, the World Health Organization is very much aware of this subject because they have published articles linking to these specific studies and have funded some of these studies. So we know that these large organizations have the so-called philanthropic, we want to be doing good in the world by deworming the third world. But what happens when you do that, and the results of that are explicitly clear. So we have to really understand that what we think of as parasites as being pathogenic may be true in some people, may be true in certain cases. However, we have genes that we have clearly inherited that specifically evolved because of parasite interactions. And you remove the parasite, eventually you're going to see evolutionary mismatch in real time. And I believe that this is one of the more overlooked phenomenon in evolutionary biology and in modern medicine today.
Yeah, no, I mean, I'm definitely, my mind is open in a way that I haven't probably looked at this and with all of your explanations, Michael. And, I mean, we kind of think of like, also endogenous retroviruses or the virome or, we vilify, pathogen and then, forget all of the, the helpers, doing this to evolve and, actually be more helpful than harmful in the end. And so I see your point. And I guess, so walk us through helminthic therapy. Are you doing this? Have you had experience with clients and collaborating with patients, and just maybe walk us through this so we can go deeper and understand how this works?
Well, yes. So I'd like to just mention, you brought up viruses and retroviruses, and I do want to say that there have been studies that have shown that helminthic therapy has the ability to attenuate the interferon response as well as the innate immune response to viruses in particular. And this was done. There's human and some animal studies looking at this as well. So as you were mentioning, the virome, supposedly we have 380 trillion viruses or some unfathomable number in our body, in our biome, that makes up who we are. I mean, we're literally comprised of more microorganisms and viruses and bacteria than we are human cells by an enormous order of magnitude. But there is a direct, helminths definitely have an inhibitory effect on viral activity and the innate immune response to viruses, which means that they're a potential benefit for various so-called viral infections and may also be a totally overlooked treatment in that regard. Getting into treatment, I want to first give a real shout out to an organization that I think is doing tremendous work. And if you're on your browser right now, go to helminthicwiki.org. Helminthic, Helminthic, therapywiki.org. This is an organization of a community of people that have aggregated thousands of patient testimonials from people that are self-treating using helminthic therapy. And if you go through the testimonials, you'll be astounded at what you read, as I was and as I continue to be. They've also done a good job of aggregating about close to 1,000 published studies on helminthic therapy in animals, in preclinical studies, as well as in human studies. So helminthic therapywiki.org is an absolutely phenomenal resource for people to get familiar with this concept. And also there's a Facebook group there of people that are sharing their own experiences doing it, because I have to admit that a lot of my patients don't want to do Helminthic therapy because it's still too much of a foreign concept. However, those that have done it have gotten benefit. And it's simply because there's a huge potential to attenuate complex signaling in the body using something very simple. The other limitation with Helminthic therapy as it is today is that the cost to do it is still relatively high because of the fact that there are certain FDA regulations on the culturing and the sale and distribution of helminths in the United States. Many people that are doing this kind of therapy have to source helminths from outside of the country, from labs coming from outside of the country, which is totally feasible. But the cost of all of this can get a little bit exorbitant. But if your health is at stake, if you have multiple sclerosis, of which there's been at least 3 or 4 clinical trials in humans showing major benefit, and I just want to tell a quick story on that. When I was about 15 years ago, I was contacted by a 22-year-old male who had been recently diagnosed with multiple sclerosis. And he told me that he was going to enroll in some clinical trial happening in a major university in the United States using Helminthic therapy. And at the time I hadn't heard of it. I wasn't familiar with it. And I said, well, good luck. I hope it works for you. 6 months later, he calls me back and he tells me that 5 of his 6 brain lesions were gone and the 6th one had shrunk by 50%.
Wow.
I said, that's pretty dramatic. So that was my first experience with Helminthic therapy. And ever since then, I've been very interested in this concept. But the ability to do that is, the ability for helminths to work on these levels. Again, people out there thinking, well, what kind of disease do I need to have worms? I can't wait. Get me started right now. Get me started today. Where do I get started? Well, I'll say this, is that we don't yet know who is not the best candidate for type 1, for Helminthic therapy. Because as you go through the list of testimonials, anecdotal reports from individuals self-treating, you see an enormous amount of categories here. It's not just type 1 autoimmune diseases. It's also PANDAS. It's also salicylate sensitivity. It's also neurological symptoms. But it is mostly autoimmune disease, because I believe that the genes that we've inherited that are the links to autoimmune disease are the immunological genes. And those are usually the ones that are associated with HLA2 or HLA1 or RCCX or cytokine genes, etc. So I would just say this, is that for inflammatory bowel disease, if you're looking for a treatment, because I would unequivocally say, give it a shot, because there is no question it could save your life. And as you read the testimonials on the Helminthic therapy wiki pages, which I encourage you to do, I was just perplexed at how many people have gotten benefit. And why this therapy is not more widely used is really, really something that I want to get behind and promote. Because we need, from a scientific perspective, we need more data. We need more clinical data. We can't move forward unless we get more clinical data. And so I really encourage you to embrace, to just be open to this concept, because I think it could really save people's lives. And it already has.
Yeah, no, I think it's really important, especially as you said, like, and if your life is on the line, if you're having one of these really, grave diagnoses that doesn't have a lot of treatment, I think when you weigh the risk benefit, it absolutely should be considered. I mean, my brain is going, and I'm sure you've gone there too, like, okay, very different, but let's say, okay, how probiotics, we made a supplement out of them, right? Is there any kind of like forward thinking, like some of the anti-inflammatory agents that the helminths produce, like we can encapsulate, or peptides, or, things so that we can have this, or is it like that's too reductionistic?
That's a really good question, and I'm glad that you asked that. So obviously, when there's been thousands, probably tens of thousands of studies, preclinical studies, animal studies using Helminthic therapy, metabolomic studies investigating all of the, for example, one helminth that's commonly used, Trichuria Swiss, is capable of secreting 250 or 300 different peptides into the host. That's 300 bioactive, immunogenic, immunomodulatory molecules into the host by a single colonizing helminth. So, of course, most of the funding for this research is coming from drug companies or subsidiaries of that. So they're always looking for the patent. Take the single thing that's the most effective protease inhibitor and let's patent it and let's put it in a supplement or a drug, of course, is where it's going to end up. So, this is going to eventually happen. Eventually it is. This is inevitable. We'll be talking in 5 years. Oh yeah, no, did you hear about this new drug that they got? Oh yeah, it's derived from this worm, ova of this worm. But I honestly think that what's that? Yeah.
Shout out to
right. I honestly think that nature is primed to invest. And while it may certainly be beneficial to have some drug in the future that is derived from a worm, there's many nonlinear interactions between the helminth and the host that are not even studied and understood. For example, the prostaglandins that certain worms can secrete have completely different effects as our own knowledge of our own prostaglandins. We think of prostaglandins as mediating the cyclooxygenase pathways and all this, but as you start to look at research, I'm like, wait, this doesn't even seem to make sense from what I knew about prostaglandins in humans. So these worms are doing something completely different with their own prostaglandin secretion. So there's so much that we don't yet know about the complex nonlinear interactions of how worms have co-evolved with humans for millions of years. And I'm not talking about just humans, but I'm talking about all life on this planet has microorganisms that have symbiotically co-evolved with them. And that includes worms in different species. We're no exception to that. We're not separate from this earth or from the Gaian super biome that makes up all of life. We're not separate from it. And we have to realize that we've become separate from it in many ways because of iatrogenic medical treatments, because of toxins that we've been exposed to that have led to dyssymbiosis, the inability to tolerate other microorganisms. It's not getting rid of them that I'm interested in. It's how can we increase tolerogenesis? How can we increase adaptation? And how can our bodies learn from the symbiotic relationship that all organisms that inhabit us have with us?
Mm-hmm. Yeah, I have a very, this is just a new tool to think about, but I have that's my belief in health. The bioregulatory approach or looking at, regulation and resilience and adaptation. And I think, there are many takeaways for people to take from this conversation today. But, I think we have to give up the war, give up that kind of, war idea on microbes. And we have to think about also, like you said, like we can't live in these bubbles or these Faraday cages or these, sterile environments, if we have a mold issue or, it's like, how do we create a more resilient terrain, right? So that we can walk through whatever life brings and, respond, adapt, and move forward. And I think this is, I mean, to be very honest, Michael, I've always, because I do treat parasites and I do get results with that, but I know it's not the same, but it gave me that kind of thought of like, is this something to think about, helminth therapy, or is that are we just trading one problem in for another down the road? But I mean, I hear you. I mean, we look at microorganisms all the time, and it's the balance of these microbes in our body that provide health. And I think just because helminths are a little bit more unsightly than lactobacillus or like these other microbes that are not our own our human cells, I think it's probably it just we need to be educated. So I so appreciate you educating us today.
Thank you for letting me speak on this subject. I appreciate it very much.
Yeah, definitely, Michael. And you mentioned a few articles, and you have a phenomenal website. I always love reading your articles, and you've opened my mind up on many topics, and you have a really wonderful way with words and distilling really amazing, boiling down a lot of research into an article. And so I would love for people to learn again how to find you and your work and anything else you'd like to share.
My website, I have two websites. My main website is www.metabolichealing.com. That's metabolichealing.com. And my other website is true.report. That's www.true.report. That's our genomics and analyzer software. So we actually have that going on as an ongoing research project to help to have basically patients or practitioners upload their patients' genomics and or blood chemistry to get an analysis. And then the metabolic healing site is largely for practitioners. We do trainings. We have a number of different clinical training courses that created over the last 8 years, and lots of free content, 13 or 14 years worth at this point. So there's 3 specific articles on Helminthic therapy that are up there, and you can look for them just by going to all articles. There's the one on APOE4, which just came out. I republished that from Holistic Primary Care, really interesting. And then there's one that was published a couple of years ago, and then one on evolutionary mismatches, which was published just last summer.
Well, thank you, Michael, for being on this summit, and thank you for your passion for diving so deep into these topics and educating us. I really appreciate it.
Thank you very much, Christine.
Eric, I really enjoyed that last speaker.
Yes, I did too. Another great example of excitement and deep insight.
So before we bring up the next speaker,
well, let's give our audience a chance to share these important information with their friends and family. So I urge you, press the share button and let other people have a listen to the talks that really have excited you.
thank you.
Thank you. And press that button because it's important.
Welcome to this episode of the Mycotoxin and Chronic Illness Summit. I'm so happy to have with me today Dr. Alireza Panahpour. Hi there.
Hi.
So we met more than a decade ago when I was working at Dr. Klinghart's clinic, and he was as well. And now that I'm not working there anymore, it's been more than a decade, and I've been at Gordon Medical for the past 6 years. We invited Dr. Panahpour to come work with us and our patients because I understand that we need a conscious dentist on board when we're working with people who have a multitude of infections, including dental. And so we're going to talk about that today, our holistic work together. So Dr. Panahpour, welcome. I'm so happy to have you here. Yeah.
Thank you so much. Thank you so much for having me. I think what you're doing to begin with, Dr. Perpia, is so needed. And I hope this will be one of many other podcasts to come. So for us to be able to truly raise awareness on so many of our patients that have spent countless years and hundreds of thousands of dollars going from one doctor to another, where they truly needed a conscious dentist such as I, conscious naturopath such as you, or an advanced medical clinic such as the Gordon Medical Clinic in San Rafael. If you don't mind, I'm just going to jump into it if that's okay with you.
Absolutely.
First, I want to wish everyone a Persian Happy New Year. It was this morning, so Happy New Year, everyone. Second, I want to thank all my mentors throughout my years of education that allowed me to sit on their shoulders and be able to see a little bit further than them. After years, decades of studying, I have came to the conclusion that unless we have multiple practitioners that are all in sync together, all on the same ship, we would never be able to truly help our patients who are dealing with multiple chronic issues. So really early, I realized in dental school that I was not going to be that drill it, fill it, bill it type of the dentist. And I wanted to be more involved in my patients' healthcare. With that said, tooth decay, gum disease, clenching, grinding, infections of the jaw, root canals, in my opinion, they all have one thing in common. They're all chronic issues on the immune system. We know that as we're sitting here right now or talking, our immune system is dealing with over 6,000 different types of cancer cells. So the last thing you want is have a chronic issue within your system that is burdening your immune system. So that's kind of where my scope comes from. With that said, I'm seeing a lot of patients And of course, as I advanced in my education, I've somehow attracted much more compromised, more difficult patients. And what I'm seeing over and over again is that these people have, again, traveled the world from one doctor to another, have gone through multiple different therapies, anywhere from chelation to detoxification, where there's been hidden infections in their jaw or some sort of a lymphatic issue or craniosacral disharmony that has caused them oxygenation issues. So I spent ample time not only on the phone, but giving lectures to medical doctors, functional medical doctors, MDs, naturopaths, acupuncture, chiropractors, of the importance of dentistry in conjunction with their medical health. It's quite rare, I would say, within the past 5 years, for me to see a patient without working closely with their medical doctor or naturopathic doctor, et cetera, And I usually know within the first few minutes talking to these other doctors if they get it or if they don't get it. And if they don't get it, sure, I'll be more than happy to spend more time with them, go through that learning curve. But of course, I always tell my patients, you know, your doctor's great, but just not experienced enough for these type of issues. And I recommend for you to see, I mean, I only work with a handful of doctors. There's Dr. Eric Gordon at Gordon Medical is one of my primary referrals. Dr. Parpia is which in the same clinic is my primary referrals. I have Dr. Santiago that I work with in Los Angeles, in Pasadena, in my Los Angeles office, Dr. Virginia Martinson in La Luz Wellness Center in Mexico. So again, there's only a handful of doctors that I have faith and trust in that I work with closely with our patients. Now, with that said, when a patient comes to me, first thing I look at is structural harmony. Structural harmony, craniosacral harmony leads me and helps our patients in oxygenation and lymphatic movement, which is primary for all of our patients. Sometimes I have to spend at least weeks or months with certain dental appliances with these patients and with the help of proper chiropractors, not your pop chiropractors. I'm talking about sacro-occipital technique. My number one physician chiropractor is in Los Angeles, Dr. Charles Blum, which I've been working with for the past 20 years. And only through a few weeks of getting these patients turned around and allowing more blood flow to the head and neck, more dumping of toxins, oxygenation, lymphatic movement, that's where really is the beginning of our treatment for most of our patients. And from there, let's say, I'm going to put this in basically 3 different compartments for you. First and foremost, my physicians need to assure me that our patients are ready for surgery. Adrenals, thyroids, hormones, especially because hormones are directly connected to blood clotting factors. And of course, that becomes the responsibility of our physician to make sure that that system is working. Again, thyroid, adrenals, blood clotting factors. So that's step number 1. Step number 2, when I go in there as an advanced surgeon to remove these capsulated infections, in a way, what am I really doing? I'm spreading that infection now throughout the system. So how do I protect my patients? Well, if you talk to a microbiologist, infection control doctors, pathologists, mostly allopathic mind, they tell me that yes, put your patient on 3 to 5 different types of antibiotics. Why 3 to 5? Well, we know that these are superbugs. As soon as you start them on the first dose, these superbugs have babies and their babies have babies and they come immune to that antibiotic. So you got to hit them with another one and another one. But can you imagine what that does to one's system? Destroys your gut, allows even more fungal and candida issue. And your gut is your first line of defense. We have more lymphatic connection to our gut than any other part of the body. So the other option is immune modulation. And that's, again, goes to the expertise of the doctors that I work with to make sure through certain supplementations, intravenous IV supports of vitamin C, especially ozone before and after surgeries to start, and other factors too, to help to prevent the die-off and downfall of these patients. So that's number two. Number three, and this is again most important part of all, whenever you remove a chronic issue away from the body, that, for example, patient had their wisdom teeth extracted 20 years ago, or they have a root canal that was done 15 years ago, and these areas are abscessed, are infection, they're harboring biofilms, bunch of different bugs, viruses, bacteria, fungus, parasites, full of dead bone around them. So when I go in there and remove that entity, the immune system is like, wow, great. I don't have to deal with this anymore. What am I going to do next? And believe it or not, this is the hardest part for me to try to explain to the doctors that I work with. These doctors are so sometimes monolithic. They only think of certain compartment of the body instead of looking at the whole body. So as soon as one of these chronic issues is taken away from the system, at that time, the body either wants something or it wants to dump something, and mostly is heavy metals. Now, that also has its own ripple effect. Whenever the body starts dumping heavy metals, well, the body at the same time says, "Oh, heavy metal toxicity, let me dump some candida." So that's why I can only work with a few physicians in the States right now that truly understand that and are able to predict what's going to happen to the system and be able to protect our patients. So basically, that's in a nutshell, you know.
Thank you, Alireza, for that really, really important nutshell. So first of all, the patient comes in. Typically, this patient has already been my patient or Dr. Gordon's patient for a while.
Correct.
And we realize the person has some infections. We send them for a CT scan of the jaw. It looks at slices of the jaw for infections there that an X-ray won't look at. Then we say, all right, it's time to send them to Dr. Panahpour because Dr. Panahpour can clean this up here, right?
Well, let's put it in just take a step back. We know that normal dental X-rays are a two-dimensional picture of the structures we're looking at. Thank God for our new 3D technology. We're able to look at the system in a more three-dimensional manner. Yeah. And of course, when we take these scans, above and beyond me and you and Dr. Gordon looking at them, we always send them to a radiologist.
Yes.
We want, and you know, just like there's different types of naturopaths, different types of dentists, there are different types of radiologists. Some focus on looking at the sinus, some looking at the TMJ joints, some look at breathing. The people they work with are like the masters of the universe. You know, they look at everything, especially infections of the jaw. So only when we get confirmation, not from just me or you or Dr. Gordon looking at them, from an expert radiologist that gives us a report, says, from the imaging that we're seeing, there is very good evidence there are infections in these areas. And what they're calling it is chronic fibrosing osteomyelitis. It's a nicer way of saying gangrene bone, basically, to be honest with you.
Right.
And whenever I talk to an infectious control doctor or a pathologist and they see these reports, their jaw drops to the floor. Oh my God, she's got chronic fibrosing osteomyelitis. I'm like, listen, 90% of your patients have this. You just don't know about it.
Right, right.
Yeah. So only at that time is when we start putting the plan together of how do we get this patient ready to basically carefully and properly, in as non-invasive way as possible, to remove these infections away from the body and allow the body to go on its path of dealing with further chelation, detoxification. I mean, how can you chelate? How can you detox? How can you get well when you have breathing issues, lymphatic issues, and infections that are harboring in your jaw? That's impossible.
Not only that, but infections harboring in the jaw can cross the blood-brain barrier, or at least inflammation from those infections
Absolutely.
cross the blood-brain barrier.
Absolutely.
And then that can affect the pituitary, our master hormone regulator. It can affect all kinds of different areas of the brain. So we need to
Absolutely.
work with a leaky gut-brain barrier sometimes as well. There's a lot of work that we as doctors need to do to prepare the patients to see Dr. Panahpour once we've made that assessment with the radiologist.
That's why I'm truly blessed to, it's not like I'm around the corner from you. I'm actually in your clinic. So that's where the magic happens.
Yes.
And of course, both of us being trained with autonomic response testing, we're able to truly at least focus on what the patient needs, what the patient does. I'm not saying that that's just exclusively, of course, there's other markers that we look at also, but I think autonomic response testing done properly also truly helps us. So I truly want to thank Dr. Klinghardt for, again, teaching this to us, and allowing us to advance in it. Dr. Panahpour, are you familiar with the NUN study?
Yes, tell our audience more about it.
Yes. So a NUN study is an ongoing research study that's been going on right now for the past, I would say, almost, 40, 50 years. It's in Baltimore. Basically, there's a convent right across the street from a medical school and dental school. And all these nuns and pastors got their dentistry and medical help free, basically. And at the end, God bless them, when they passed away, they gave their body to science. So they started doing a lot of different research. And of course, as technology got better, they were able to look at things much deeper. So for example, basically, going back to the NUN study, what they realized was that, let's say if patients were dealing with any kind of, let's say, breast cancer or ovarian cancer, or any kind of a medical issue, there was a specific part in their brain that was diseased. So let's say breast cancer, there was one area in the brain, ovarian, another spot. And when they looked at these areas in the brain, top 3 things they found. Number 1, mercury. 2, aluminum. 3, biofilm. Now the question was, how did these heavy metals get to that part of the brain? Because there's a blood-brain barrier.
Right.
The conclusion was that these buggers, these heavy metal toxins, can travel through the nervous system. And the closest part to that brain was the oral cavity.
Right.
So I found that to be, and this was actually in the American Dental Association journal, which I'm not a big fan of that organization, but it was really interesting. Even they came up with this research. So I found it to be very interesting. So again, the oral cavity is the gateway is the gateway to your health.
In functional medicine and naturopathic medicine today, everybody's talking about the gut-brain connection. And it's really, really important. And yes, I focus on it a lot myself. But what I'm noticing is that nobody's talking about the dental and sinus brain connection. It's something that I focus on hugely in my practice. And once we can turn the corner in treatment in those areas, a patient's life absolutely changes.
I've had many patients after, when they see us, like literally within hours after the surgery, they tell me, I don't know who I am right now.
Amazing.
Their body has been on such an adrenal roller coaster.
Right.
Fight, crash. Fight, crash. That they don't know who they are. I'll give you a perfect example. I had a young man come to me a few days ago, 17 years old, jiu-jitsu master, 3rd-degree black belt, chess club, debate club, very active individual. They went to a very schmancy-mancy oral surgeon in Beverly Hills who removed 4 wisdom teeth at the same time. And they ended up putting cow bone in there after the surgery. Well, all the 4 surgeries not only ended up getting dry sockets because there was infection left behind, and the cow bone, because it's different DNA, the body rejected it.
Uh-huh.
This patient has completely crashed, can barely walk 2 steps.
I'm
And
so
this
sorry to
poor
hear that.
young man is losing his mind. How is this possible? Of course, the parents feel so guilty, but it's not their fault. They didn't know any better. They trusted the the oral surgeon, what have you. So
Right.
imagine a 17-year-old boy is so active, is so strong, goes to a dental treatment and barely can stand. So I try to explain this to the functional medical doctors. It was like I'm speaking alien. They couldn't even understand. When I even said, give him an IV vitamin C drip, get his system, well, that's not common.
Neither is this response.
That's not the norm. Well, I called the parents. I said, I really want to help your son, but I can't work with this doctor.
Mhm.
You got to come to my people. Of course, being in LA, I referred the patient to Dr. Santiago, who's a very advanced naturopath. And within 3 days, this young man is back on track again. Not the same that it used to be. So basically, we're preparing him for surgery going in. And we took we took the CT scan. The radiologists confirmed that these wisdom teeth that were extracted a year ago are infected, and we need to clean them out. So now the doctors are getting him ready to for the upcoming surgery. What I'm just saying is that imagine what that does mentally to our patients. They've been chasing their health for so long, and after years and years and years, they come to the conclusion that, oh my God, that guy who told me about I should take care of my dental infections, which I didn't listen to, now I got to go back and do it.
Right.
And
right.
I would say more than 50% of the cases that I do right now are redos. They went to some weekend warrior who took a weekend class at some holistic dental organization calling themselves biological dentists now, or even some of these other ones who advertise such thing. They went in like doing a filling. They went in, removed the infection, gave some vitamin C, some vitamin D, K2, and they think, yeah, that's it, it's over. It's not.
No.
The preparation before, during, and after is so crucial. So again, that's why I love working with you, working with Dr. Gordon and other practitioners. As you know, I'm sitting in the Alaska Lounge right now on my way to your office.
That's right.
Because we have patients for the next few days at the clinic. So I'm really actually excited and looking forward to it, to be able to truly help our patients on these levels.
I know. I'm so excited that you're at our clinic, because now we can change their lives in a deeper way.
This is a new paradigm.
It is.
This is a true new paradigm. Hopefully, this will be a start of other clinics having a conscious dentist with proper expertise in their clinic. That's where the magic happens. I truly believe in that from the bottom of my head.
I believe in that too. That's why you're with us. That's why you're working with us. I mean, it's
Thank you so much.
exciting. Absolutely.
And let me tell you, like with my LA office, San Francisco, I consult in Miami and and a clinic in Mexico. I'm traveling all over the place. And people tell me, how are you able to do it? I said, is the results that I'm getting. When I see these patients get well, when I see them get strong, when I see them finally are able to change their life around, that gives me the strength to keep on going.
Absolutely.
Truly.
Thank you for the work you're doing.
Thank you. I could never do it without you guys. I want to be honest about that. So again, I spend ample time talking to other doctors, naturopaths. I would say only 1 out of 10 truly get it. And I'm willing to train the other 9 out of 10.
Right.
I've go through the learning curves with them. But it's truly an honor to be able to work with someone that can hear me, understand me, and for us to be able to help our patients in a synergetic manner. 1 + 1 = 3.
That's right. That's right. Well, thank you, Alireza. Thank you for this interview, and thank you for joining our practice. We're also
Thank you so much. I look forward to seeing you guys this coming week.
Yes, we'll see you very soon in person.
Thank you. Thank you so much.
Thank
Bye.
you. So there you have it. This wraps up day 1 of the Mycotoxins and Chronic Illness Summit, and I hope you've learned a lot. I know that I have. So you've heard from many speakers today. Dr. Paul Anderson, who spoke on the obstacles to cure in COVID long haul. Dr. Isaac Eliaz on biofilms, pesticides, and mycotoxins. Dr. Jill Carnahan on diagnosis and treatment of mycotoxins and mold-related illness.
And Dr. Mobeen Sayed on COVID long hauler pathology and management. Dr. Gordon Crozier on the use of peptides in chronic illness. And Michael McEvoy, Helminthic therapy, autoimmunity, and the evolutionary mismatch.
And Dr. Alireza Panahpour on oral systemic health.
Make sure you tune in tomorrow because we have another set of amazing speakers ready to share their insights and breakthroughs with you on healing and preventing mycotoxin and other chronic illnesses.
But if for any reason you feel you might miss any of these inspirational and potentially life-saving interviews during the summit, I do encourage you to secure lifetime access by purchasing a VIP All Access Pass today.
That way, you won't miss anything, and you can watch and listen to these interviews again and again at your own pace. Simply click the button below to order your VIP All Access Pass at a special limited time discount right now while it's still available.
And before we wrap up, please leave us your comments in the section below and let us know what inspired you the most about today's interviews.
Thank you again for joining us in the Mycotoxins and Chronic Illness Summit. Please remember to share this with friends and family so we can all work together to increase our vitality and health and make for a better life for all of us.
Thank you.
Thank you.